inviting me to be a part of this extraordinary course. But for the past and of course, we know as a necessity the they are interested of and thank you very much.
थोड़ा से आवाज तो जाओ बाहर से कैसे करेंगे
My privilege and honor to be along here with all the clinicians over here for this, and I'm sure I'll have a good learning over here, and it will be a very beautiful day. Thank you so much.
Dr. S.S. Amarnath, very familiar phrase from Bangalore. So,
thank you, Dr. Introduction. And definitely we need to take this forward, as Dr. Chandrasekhar said. It's a shared responsibility and a shared knowledge to have patient care in the best possible way. Thank you.
And Dr. Ravi SAUHTA from Gurugram, Delhi.
Good morning, everybody. At the outset, I thank Sabja and all team from Bihar Orthopaedic Association. We have a great running today from across spectrum. Thank you so much for inviting.
Dr. YOGEESH from Mangaluru.
Thank you. It's lovely to be here. I'm an exclusive hip and knee surgeon. So this being an orthopedic conference, Dr. Jha thought it necessary to talk about a few technical aspects of joints and complicated kind of surgeries in inflammatory pathologies, which I will be highlighting here, along with addressing the importance and evolution of different types of inflammatory diseases in various lectures. I look forward to interacting with you all.
And from Guwahati, Dr. CHINMOY Das.
Morning, everyone, and thank you for inviting me. Assam and Bihar Orthopaedic Society. I have to confess one thing: I'm not an expert as the during the procedure. I'm not an expert of rheumatology, but I know some of the basic things, and I will stick to that. Thank you for inviting me.
Thank you, CHINMOY. And now I would like the President Bihar Orthopaedic Association, the Secretary Bihar Orthopaedic Association, and the Organizing Secretary and say hello. Meeting has not formally started. We are going to start positively at 9. Good morning, everybody. Let's start.
good morning. Hope you will enjoy. And, I can hear from yourself during the day discussion. I now hand over my mic to my secretary.
Thank you, sir. And now a special day for Bihar Orthopaedic Association, our Honorable President, Dr. RAJEEV, sir, Organizing Secretary, Dr. RAJEEV and Dr. AMULYA, and all our participants and national faculty of all corner of the state, Dr. Chandrashekha, Dr. AMARNATH, Dr. CHINMOY, and many more, and especially all our postgraduate, all welcome today for a special topic, the most confusing and most demanding today, the rheumatoid arthritis. So we hope this workshop, this course will definitely boost a lot and learn many things why the experience of our legends of rheumatology, and hope we will memorize this forever. Thank you.
Now it is already 9. We will start the proceeding, and for starting the proceeding, Organizing Secretary Dr. RAJEEV Anand.
Welcome to all of you. Very good morning to all. And first of the outpost, I would like to thank our Vice President, Dr. Ramchandra, and now the President-elect now. Sorry, sir. And our Honorary Secretary, Dr. Naveen Thakkar. Good morning. And Dr. Manish Khanna, who is the
Good morning
of the Rheumatological Association. Welcome to all of you. Welcome to all the delegates. We'll be shortly starting now. So thank you very much.
And that's all from our side, and inauguration is going to start. Good morning, Dr. Ram. Good morning, Dr. Naveen. Good morning, Dr. Manish. We are here to start another course of rheumatology orthopedics. Basically, lots we have to learn, and all credit goes to Dr. S.S. Jha, our
little bit problem with the audio. Audio is not coming.
Patna Rheumatology course 2023, and on behalf of Bihar Orthopaedic Association and Indian Orthopaedic Association, I welcome you all. A very good morning to all of you. So shortly we will be starting this very prestigious CME that we found that it is very necessary for all the orthopedic surgeons of Bihar to learn the basics of rheumatological conditions. So without wasting much of the time, I welcome all the national faculty who have come over here. Welcome you also, and all the faculty and the delegates who has come and who is about to come. So we'll start this function now, and may I call upon Dr. S.S. Jha, who will be addressing this session.
I think let's go the reverse way. Since Bihar Orthopaedic Association has planned it, it goes to the credit of the current president, Dr. Ranjit Singh, who has thought of organizing this rheumatology course as his first webinar, or you can say this is a combined online and physical meeting. So first of all, Dr. Ranjit comes to welcome, and then we will go to our central offices. Dr. Ranjit.
Good morning. Namaskar. Respected Dr. Manish Khanna, Dr. Ramchandra, Dr. Naveen Thakkar, who have joined on the web with us. Audience, faculties from across the country, BOM members, and would be BOM members. Warm welcome to all of you in this first of a series of games organized by Bihar Orthopaedic Association, and this one is in the days of Rheumatological Subcommittee of IOA. Rheumatological disorders are very common. A large chunk of our patients comprise of these patients. And at times, we are confused, clueless lot in a primary as to the diagnosis and treatment. And that's why this conflict. To track the conundrum, much boundary, quantitative boundary, I would say, has gone into planning and structuring the program, selecting the subjects. And many people, like Dr. Neeraj, our secretary, Dr. RAJEEV, and Dr. SAUHTA, Dr. AMULYA, work hard under the stewardship of Professor S.S. Jha to plan it and formulate the program. During the day, through the discussion, through the interactions, I think we all will be more enlightened, more knowledgeable, and better still, we will have better understanding, which is more important, of the knowledge. So, I again welcome you all, but before that, I would conclude with a Urdu couplet. एक नई शम्मा अंधेरे में जलाए रखिए, सुबह ज्ञान की सुबह होने को है, माहौल बनाए रखिए.
Thank you very much, President Ranjit. So, friends, well begun is half done. To add to our confidence, we have lined up dignitaries from Indian Orthopaedic Association, and we are proud to have our President-elect, Dr. Ram Chandra, who always takes keen interest in any academics, and especially so for our rheumatology subcommittee. Can we have inaugural blessings from Dr. Ram? Dr. Ram, please.
Good morning, all attendees, delegates, faculty of the Patna.
Right now, wait a minute.
Good morning, everybody. Am I audible? Good morning, everybody. Am I audible? Okay. Respected seniors, Dr. R.R. Prasad, Dr. Professor S.S. Jha, seniors, Professor Dr. Ranjit Singh Ji, President of the Bihar Orthopaedic Association, BOA, which is as big as the British Orthopaedic Association, Dr. Mahesh Prasad Ji, Dr. Rajiv Anand Ji, Dr. Amulya Kumar Singh, whom I just had a look at, and invited faculty. On behalf of the Indian Orthopaedic Association, my dear friend, Dr. Naveen Thakkar, Secretary General, the IORA representation online, Dr. Manish Khanna, we welcome all of you for what will be a collaboration between the surgical and the non-surgical aspect of orthopedic care. And rheumatology happens to be the most important part. Very often as surgeons, we are confounded and face situations where we don't have an answer. And we have to actually look within and find the answer, which is non-specific, not known to us as non-surgical. And usually it comes under the vertical of a rheumatological ailment. Hence, it's an extremely important part of our daily practice, and knowledge and wisdom on how to handle such situations is critical. I appreciate the inputs that will come in from the President-elect of the Rheumatology Association, Dr. S. Chandrashekha, and the other invited faculty, besides our orthopedic colleagues who are having keen interest in rheumatology, which include Dr. S.S. AMARNATH, Dr. Ravi SAUHTA, Dr. KAMAT, and many more who are there and would actively participate in these discussions. We all know that Dr. Manish Khanna has been very active, but is physically not there, but I'm sure his inputs would add value. Dr. Naveen Thakkar, my dear friend and colleague, would also address each one of you, and we are happy to be here to co-brand this event today with the Bihar Orthopaedic Association as a part of the Indian Orthopaedic Association. Thank you for taking it ahead. The rheumatology subcommittee, believe me, and we all know that, is the most active subcommittee. And we sort of bow our heads to Professor Jha for taking the initiative. Thank you, sir, and keep the good work on. God bless you.
Thank you, Dr. Ram. You have been personally very close to my heart, and I can say our hearts in the OA. Well, now it is the turn of our very own Secretary General of IOA, who also is a member of BOA. So we love to have inaugural message from you.
Naveen bhai, you are not audible. Naveen bhai, you are not audible.
You are muted, Naveen.
Okay. Now I am audible.
Yeah, perfect.
Respected all teacher, all seniors, all darbaris in the Darbar Hall, and all Chanakya in the have worked very hard. I have seen through from the genesis of this program in last 2 times my visit to Bhagalpur at Patna, Patna at GovCon, where they were discussing different aspects of rheumatology, this course, and all nitty-gritty they have planned very well. And the delegates will get the most out of it. And the Bihar Orthopaedic Association and his office bearers are very, very vibrant and active academically. Dr. Ranjit C and Dr. Mahesh Prasad has already crafted the whole year calendar of the academic activity. And we congratulate whole association. Along with Dr. Amulya Singh and Dr. Rajeev Anand, they were planning a lot of new academic activities in the Bihar Orthopaedic Association. And it is the most active orthopedic association. And this subcommittee, headed by Dr. S.S. Jha sir, is very precisely forming the academic content. We have seen since last 2 years. And this committee has been awarded in last 2 icons as a very good best committee of the subcommittee of the IOA, which has given a very good academic content. And I feel that everybody will get something new out of this. This is the real sharing, contributing, and learning together. Thank you all. And a small request on behalf of the IO office, please update your Aadhaar, verify your Aadhaar. Some of the office bearers of the Bihar Orthopaedic Association has done. Last time when I visited Bhagalpur and Patna, there and there. So I wish great success to this program. Thank you very much to all.
Thank you, Dr. Naveen, for your words of wisdom, and we are very confident that we can stand as you have thought about this.
Thank you, sir.
Right. When you talk of Dr. Manish, it seems almost as we have always been a part of the same mission, the mission in which the orthopedics got into solving the problems of rheumatology, and thus Indian Orthopedic Rheumatology Association. I always wanted that he should have been here, but due to very many commitments, he is not here. So, Dr. Manish, your words.
Good morning, a very warm namaskar to everyone here at Patna. as a grassroots worker of the association, yes, this is a very important aspect which we have reached now as a physical webinars being converted into physical meetings, truly speaking. As already been mentioned, 60 to 70% of our population is still in the villages. Although the different medical colleges are being open, institutes are being open, but still a lot of the OPD situations from 40 to 50% from the cold orthopedic, one has to start with. The young orthopedic surgeons who start the practice, they start with a cold orthopedics, truly speaking. So unless and until we are masters on it, the thing is not being done. So for the last 12 years, we are just trying to go for it. And I'm very happy with the blessing of Almighty. This Patna rheumatology course has been organized. I'm really very thankful and congratulating each and every member of the executive committee to go for this program to enlighten the general orthopedic surgeon. And definitely the second aspect is we orthopedic surgeons, we open the joint, we see the synovium, just having a little bit knowledge about the basics would cater a wonderful surgical skill to cater the needs of the patient. So this is a very important thing. And such type of academic continuous learning activity has been done today throughout the day would go a long way for the general orthopedic surgeons, young orthopedic surgeon who are skilled in the surgery, but still missing some part of the medical part, which we have understood very well in our UG level to go and take it further ahead. Thank you so much. Thank you so much.
Right. Thank you, Manish. So we have in fact allotted a physical seat for you in the audience. So you are not moving from that seat. And you have to reply from that seat physically. Thank you very much, Manish, for being there. And thanks again to Dr. Ram and Dr. Naveed. Now we will be lighting the lamp, and before that, there are some ceremonial moments to be performed by Organizing Secretary, Dr.
Thank you, sir. And really, heartiest thanks to our President-elect, Dr. Ram Secretary of IOA, and Dr. Naveed. Thank you very much. Your words really mean a lot to us. And I'll request Dr. Mahesh to say a few words before electing.
Today, we welcome you all and we start the session very shortly. And I thank to our national office bearer, Dr. Naveed, Dr. Manish, and Dr. Ram sir to come in this activity. So thank you so much for coming here. And we
request Dr. Anil Kumar sir. The patients and after our past president to come. Dr. Upendra, Dr. Pradeep, please come.
And these recordings will be available on IOTV in IO website.
Yes, sir. इसमें कि माइक का ग्रीन सेंस कम आएगा इसलिए कि चारों टू टर्न मैं ज्यादा तक
रेडी है? साथ में क्या क्या देना है? वहाँ खाने पीने का कुछ मिल जाएगा, पानी वानी मिल जाएगा? चल।
Thank you very much. For inauguration of this
नाम आपका? अभिषेक। ओके। हमारे क्या है बेटा?
We'll start the first. And all of us are aware, Dr. S.S. AMARNATH was the convener of the first IOA committee on orthopedic and since then he has been also working hard for the success of this. He starts his session with a topic in which he will familiarize everybody with what encompasses orthopedic rheumatology.
To start the session, I would like to call the chairperson, Sir Ravi Kumar sir, Dr. J. Choudhury sir, and Dr. Patel Kumar sir. Kindly take your seat on that, sir.
सबों का स्वागत है. Good morning everybody. Sir, before starting our this first BOA rheumatology course, I want to say few words. When we take admission in orthopedic surgery, we are the best. We are the best rank placed after MBBS for the competitive examination of different subjects. But today we are talking about pain, joint pain, where we are caught. We don't use our best brain for our patient. We just want to use our brain for earning a lot of money. Sir, just now Dr. Manish said 50% of our patients are villagers. They don't have access to many of facilities given by super specialists. We as orthopedic surgeons can use our brain. No need of lot of equipment, instruments to diagnose joint pain. But we have to take some pain to diagnose the pain, which we are not doing. Once patient comes, अच्छा फिर ये दवाई को करना, फिर आया, चल जाओ rheumatologist, दूसरे डॉक्टर के पास चलो. This is very painful. We have to understand. We have to spare some time and to make everything understand. I am requesting all of our make it so simple and easy that all of our colleagues can we understand the subject and we treat, we give this advantage, we pass on this advantage to our patients which are not reaching to the higher centers. Thank you very much, sir. Now I request Dr. S.S. Amarnath to start with.
Thank you. Good morning, respected chairpersons, teachers, faculty, and all the ladies who mentioned. It's a pleasure to have this academic forum in the new financial year. The new year is started, but it's the financial year, and taking it forward for the knowledge base. What better way that we can do is to share a knowledge for a better care. It, gives us an edge to take care of patients' ailments in a better way to make their life better. So they need a comfortable life and a better nation. IOA has the presidential theme, and we take it forward. With that, today we have running out of time now by 20 minutes. I'm going to wrap up very soon. What compasses the this is me. Thank you for the introduction. And this is the hospital where I work. And I'm involved in two organizations. And thank you, Bihar Orthopaedic Association and Patna Rheumatology course for inviting us to this seat of knowledge. Literally, today, in fact, yesterday we were discussing the kind of the knowledge base, what Bihar, the Nalanda, Takshashila, and goes beyond our imagination, were the seat for the entire world's knowledge at one time. And today, that is being emulated by the activities and the kind of thing that is being taken care. So this is the presidential theme for IOA, and we're taking it forward and making sure that each one of our citizens are going to be given the best of the health and the knowledge that we can care for each other. Sharing and caring is one of the biggest thing that we have, and we learn from each other. And sir, thank you. I will definitely simplify and take it forward. Now, it's not an easy affair, but I'll definitely wrap it up very soon so that we get a little more time. As been told earlier, we are the first touch points along with the family physicians. If you and I don't have this knowledge, it's not going to be easy. That is the biggest thing that we need to make sure. We should understand we are not just surgeons, but basically we are physicians. We are orthopedician before we became orthopedic surgeons. So with the knowledge of orthopedics, physician, which is very essential, we can make sure that the surgical indications are going to be the biggest thing that we can advise, and the unnecessary, uncalled for, unethical surgical interface has led in many of the practices all over India. So that we need to curtail. One, today with the kind of advancements of the medicine that is available, both oral and parenteral, we can not only just control, many a times we could prevent further complications and also make sure that we don't have to do that kind of a surgical, which is required. So running a couple of slides, I will not read each and every bit, but I'm sure the last person in the last seat also can read this slide. So this is the biggest thing. It is affecting nearly 60 to 70% of our population, and a large population of our country, 140 crores, are in the rural background, living, not having access even to an orthopedic surgeon. Forget about rheumatology. Rheumatology is like a Mercedes-Benz or even BMW for some patients. They're not even able to afford to come there to consult even. Forget about even discussing things. So this is the area where Rheumatology Association, Indian Orthopedic Association coming together under the banner of each organizations and learning from each other, caring for each other. So that is the biggest thing that we need to talk about. And the questions are asked, there are questions, there are confusions that need to be cleared by air. So this is where the whole thing is. It is not that I am superior or you are superior, you're inferior. No, it's not that. When once we understand the patient care, we working as a team is the biggest key answer for this. I've been a part of IOA for many years, 40 years plus now, probably. Now, IRA, Indian Rheumatology Association, I'm a part of it almost 25 plus years now. In the formatting years of IRA, I've joined and then understood. And working in UK for 25 years, we work together. There is a clinic where orthopedic surgeon, rheumatologist, a physician, geriatrician, plastic surgeon, OT, occupational therapist, physiotherapist, all of them work in one clinic, addressing the challenges of the patients. Thankfully, today we don't do those kind of surgeries what we did in the past. Tendon transfer, be it the metacarpal or even interphalangeal, replacement, what's been going on. Even though it has not come to India in a big way, we have medicines that can arrest and make sure that we could control and make sure that patient gets a better care. So that is where the whole thing is. We need to focus on the medical terms and also surgical. So we have co-discussions. Simplifying the knowledge is the biggest thing. We have the technique, we have the ability, we have the expertise as orthopedic surgeons in our surgical skills. With the best of the implants the world has, India has it too. Now, with the kind of health programs the government is rolling out, there are issues, there are policy issues. I mean, we cannot expect everything to happen in overnight. So we need to address those, making sure that the government, the authorities are sensitized so that we could push that forward for a better patient care. I mean, Ayushman Bharat is one of that, which is covering nearly 40 crores of Indian population, which is literally 1/3 of it, or a little less than 1/3. So that is coming in a big way. So those things, and insurance segment is another big thing we need to talk about. Here, as practicing orthopedic surgeons, you and I may have certain knowledge of rheumatology, but we need to understand better so that we should know our limitations. Now, just because you and I attend a course doesn't mean that we know everything. We need to understand, involve, and learn. It is not just one Google and we know everything. No, that is not the answer. So that's the reason, as an orthopedic surgeon, let us share, understand, and probably work as a team. Today, 45 to 50,000 orthopedic surgeons across the country. We are about nearing 14 to 15,000 who are registered in IOA. IRA is just coming to touch about 1,000. In that, the practicing rheumatologists are probably 300, 400. Maybe I may be wrong. Dr. Chandrashekar will tell me. So that's where we are. The numbers are huge. And working as a team with rheumatologists makes sense to take this patient care in a big way. What, as an orthopedic surgeon, I and you see is this. That's where the whole challenge is coming into. How do we address it and taking it forward? Now, apart from surgical, I know most of the postgraduates are very keen to learn a lot of surgical techniques, but today the entire focus is on preserving your own joint rather than replacing the joint. We have preserving, conserving, and regenerating. Those techniques have come in a massive way. If you're not understood, if you're not having a practice of that, you need to look into that, because that is the future. 2021, second lockdown, when we had an geriatric orthopedic association organized a web meeting where we had about 850 orthopedic surgeons across the globe. We were talking about the stem cell, which is changing the entire scenario of the replacements. So as we go on, we will definitely make sure that is going to be there. As doctors, we need to address musculoskeletal system. Same thing happens with rheumatologists. So this is where the whole challenge is coming to. So it is not just one joint or multiple joints. We have to address the systemic problem that is there. So a lot of knowledge, there'll be a lot of slides, there'll be a lot of overlay and overlapping happens. That is good for us to re-insist and re-educate ourselves. So if you think you know everything, no, you need to know. Unlearning is the biggest issue. That is the biggest baggage we have. and we need to relearn what is the future. So that is the key factor, and this course is meant just for that. And as a General Secretary of GYSI, Geriatric Orthopedic Society of India, I invite each one of you to Jaipur, which is going to happen during the month of October, last weekend of October. Thank you. Thank you.
Thank you, Dr. S.S. AMARNATH, for your nice presentation. Next speaker is my guru, Dr. S.S. Jha, and his topic is two-step diagnostic strategies in rheumatology, arthritis versus arthralgia in early disease.
Thank you, friends. Very good morning. So from one SS to another SS. Well, coming to diagnosis, what becomes very important, each one of us have been trained. History and clinical examination will be the foremost. And about history, I'm in the habit of saying, talk and talk to the patient till the patient gives you the diagnosis. Friends, all of us have been eating cake. So if history and clinical examination is cake, imaging and clinical investigations, they are the frostings. But first, bake the cake and then apply frosting. With these words, friends, I would like to start my discussion that what is the diagnostic goal in rheumatology? So the basic symptoms related to anatomic compartment as shown. Suppose our faculties, they arrived at the airport and they had to locate Hotel Chanakya and reached. So how does he come to Hotel Chanakya? So he will have to remember where he has to go. So he knows the venue, Hotel Chanakya. Now, what are the different symptoms related to articular, periarticular, muscular, or systemic? So the first goal is get to the right neighborhood. Do not go too far from our final diagnosis. So the first step in differential diagnosis is you have to have familiarity with main syndromes. So establish the main syndrome on pattern of symptoms. So step one, define generic type of pathology, design initial interview. This is what is talking. So based on the pattern of symptoms, and must determine existence of typical features of a given syndrome and distinguish them from others. Do not delve into too many details. Be precise in details. That will be most decisive in identification of a syndrome, and diagnosis by art of exclusion has to be adopted here itself. Well, the step two says, after arriving at a particular set of symptoms, the joint disease or the generalized pain or bone pain, back pain, proceed to detailed investigation to distinguish these conditions. And this is the second step in differential diagnosis. Not moving. Right. Friends, I'm talking about whenever you talk to the patient, try to arrange the discussion into magic of 10 words. Do not exceed 10 words and you will get a diagnosis. So describe patients with as few accurate keywords as possible. And as a rule, will not need more than 10 words. Like example, this young man with inflammatory back pain, no systemic signs. This woman with symmetrical additive chronic predominating peripheral polyarthritis with no axial involvement. This patient has generalized pain with no objective finding. So remember the word 10. Well, friends, talking about arthralgia and arthritis, the joint involvement pattern could be either a polyarthralgia, polyarthritis, monoarthralgia, and monoarthritis. Well, we have been overemphasizing on early detection. So in the early detection part of the disease is better named pre-rheumatoid arthritis, but This is a retrospective diagnosis. We become wise after symptoms have evolved. So this is usually labeled before any stage of the disease, but only retrospectively who has subsequently developed rheumatoid arthritis. The genetic factors, risk factors we have to be aware of them. And all of us know HLA-DR4 is the genetic link in about 70% of the rheumatoid arthritis patient. The associated with DRB1 allele, this is third hypervariable region, is called SE, susceptibility epitome. Other two genes which carry twofold risk of developing rheumatoid arthritis, apart from other genes carrying lower risk, they are PTPN22 and PAD14. Well, friends, there are 5 stages in evolution of a rheumatic disease, and these are at-risk individuals who finally blow into a full clinical picture of rheumatoid arthritis. So stage 1, interplay of environmental and genetic risk factor. Stage 2, production of autoantibodies like ACPA and sometimes rheumatic fever. Stage 3 is most important. Patient will have arthralgia, joint stiffness, but no clinical arthritis. Stage 4, arthritis sets in 1-2 joints in the early stage, and that is known as undifferentiated arthritis, or is also known as palindromic rheumatism. Stage 5, finally 30 to 40% progress to clinical rheumatoid arthritis. Friends, the question always hovers in our mind. What is polyarthralgia? What is the number of the count of the joint? So whenever the pain is in more than 4 joints, it is polyarthralgia. That means without demonstrable inflammation, diffuse ache and pain only, cannot get localized. So poor localization. Now polyarthritis, again same formula of 4 or more number of joints, but here there is definite inflammation. That means swelling, tenderness, warmth. If it is only 2 to 4, this is oligoarticular or polyarticular arthritis. Well, monoarticular onset will be discussed later on by other faculty members. They occasionally manifest later into polyarticular disease, number 1. Number 2, most common acute monoarticular onset could be a gout, reactive arthritis, even osteoarthritis, and septic arthritis. The monoarticular symptoms, the most critical diagnosis, exclude joint infection. And the rule of thumb says acute monoarticular arthritis, assume infection until proven otherwise, and confirmatory aspiration must be done. Thank you very much.
Thank you very much, Dr. S.S. Jha, sir. Now it's time to call Dr. B.N. Jha, sir, from Sitamarhi. Friends, many of you don't know Dr. B.N. Jha, sir. He is a well-known physician from Sitamarhi and a well-known rheumatologist also. He has completed EULAR courses from the Europe and a very good name in Indian Physician Association as a rheumatology. Now he will say about the mimics of rheumatoid arthritis. Now, Dr. B.N. Jha, sir.
Thanks, chairpersons, and good morning, ladies and gentlemen. I'm grateful to the organizing committee for having provided me an opportunity to stand before this august audience. Now, why talk about rheumatoid arthritis and its mimics? Because we do not want our rheumatoid patients to end up with hands like this. The hands, you can see, are completely lost as an organ of dexterity. For this not to happen, we must recognize rheumatoid early. And for that, we should also know how to differentiate it from its mimics. Hence, the talk. Let us start with a couple of cases. A 50-year-old lady presents with joint pains of 2 years duration, both her wrists, 5 metacarpophalangeal and 2 proximal interphalangeal joints, and both the knees are painful and swollen with morning stiffness lasting more than an hour. So 11 joints out of 9 are small. Rheumatoid factor is high positive, that is more than 3 times upper limit of normal. ESR raised and X-ray is normal. So what is the diagnosis? A middle-aged lady with symmetrical inflammatory polyarthritis with morning stiffness, predominant involvement of the lower, smaller joints of the hands, and seropositivity and acute raised acute phase reactants. Is it rheumatoid? Well, it looks like. Let's apply the litmus test. These days we use 2010 ACR classification criteria for diagnosis. If more than 10 joints are involved and out of which at least 1 is a small joint, patient scores 5. We have got 9 small joints, so patient scores 5. In serology, high positive rheumatoid factor 3 points, symptom duration 1 point, and abnormal ESR 1. So 10 out of 10 is an open and shut case of rheumatoid arthritis. In the second case, a young woman, 35 years, again presents with joint pains of 2 years duration, both her wrists, 5 metacarpophalangeal joint, both the ankles, knee, and 1 elbow are symptomatic, again with morning stiffness lasting more than an hour. But she is seronegative, acute phase reactants, and X-ray is normal. So what is the diagnosis this time? A young woman with symmetrical polyarthritis, hand joints involvement also, but investigations are normal. Is it again rheumatoid, this time seronegative? Let's go back to the drawing board. More than 10 joints, 6 small, 5 points. In serology and acute phase reactant domain, she didn't score any. In symptom duration, again she scores 1, so again 6 out of 10. Again a case of definite rheumatoid arthritis. Both the patients were put on anti-rheumatoid treatment, and we will have a follow-up later. Before talking about the mimics, let's have a brief introduction about the protagonist. Rheumatoid arthritis is the commonest chronic inflammatory arthritis encountered in clinical practice, affects 1% of general population, presents as symmetrical polyarthritis involving mainly medium and small size joints with morning stiffness lasting more than half an hour. Although any joint can be involved, but small joints of the hands and at times feet are primarily affected with morning stiffness more than half an hour. Importantly, however, distal interphalangeal joints are never involved as a rule in rheumatoid arthritis. In fact, their involvement is an exclusion criteria for the disease. Majority of the patients are rheumatoid factor and anti-CCP antibody positive. Diagnosis is essentially clinical, aided by lab tests and imaging. 2010 ACR classification criteria helps, especially picking the early cases. Differentiating rheumatoid from its mimics can be challenging because any disease having oligo or polyarthritis as one of its features can mimic the protagonist. So differential diagnosis is broad, but we will limit ourselves to these 5 subheads because of the constraints of time, and we'll be discussing them under these heads. Osteoarthritis is the commonest joint disease of human beings. Large joint monoarticular osteoarthritis involving knee and hip are not difficult to differentiate from rheumatoid arthritis. Generalized nodal osteoarthritis, more common in women, presents such a polyarthritis, affects hand joints also, mimics rheumatoid. Yet there are points of differences, like rheumatoid arthritis is an inflammatory disease, whereas OA is non-inflammatory. So inflammatory features like morning stiffness, systemic involvement, and raised acute phase reactants are not found in osteoarthritis. Swelling is bony in OA, whereas it is boggy in rheumatoid because of synovitis. as opposed to rheumatoid arthritis, distal interphalangeal joints are involved in OA and wrist and MCP joints are spared. Lastly, Haverden's notes on DIP joints and Bouchard's notes on PIP joints are also found in osteoarthritis. Spondyloarthritis are a group of interrelated arthropathies sharing some common features where the main involvement is of axial skeleton. Peripheral joints are also involved, and there are some extra-articular features also. Now, spondyloarthritis is quite different from rheumatoid arthritis in the sense that they are seronegative. Other differentiating features are enthesitis, HLA-B27 gene positivity, and involvement mainly of the larger joints of the lower limbs. Despite so many differences, some of the subtypes of spondyloarthritis still mimic rheumatoid, and closest mimic among them is SLE, psoriatic arthritis. Now, psoriatic arthritis is such a close mimic that till 1964, it was regarded as a sub-variety of rheumatoid itself. In 64 only, for the first time, American College of Rheumatology recognized it as a separate entity and a part of a SPA spectrum. Now, one of the phenotypes of psoriatic arthritis so much resembles rheumatoid that it is known as rheumatoid-like spondyloarthritis. In this case, smaller joints of the hands are symmetrically affected, mimicking rheumatoid arthritis. But the point of differences are that lesser number of joints are involved, and as opposed to rheumatoid arthritis, distal interphalangeal joints are also involved. Significantly, in majority of these patients, typical nail and skin changes of psoriasis are found, which give a clue to the diagnosis. Here, a point of caution regarding the psoriatic skin changes, that at times psoriatic changes are hidden in inaccessible parts of the anatomy, and patients also don't volunteer the information because they think that articular lesions and skin lesions are not interrelated. So, search for psoriatic lesions should be very, very thorough because they are going to give you a clue to the diagnosis. Majority, that is 90% of psoriatic arthritis cases, psoriasis precedes arthritis. But in 10 to 15% of the cases, arthritis predates psoriasis. Now, these are difficult to diagnose cases, but in these cases, history of psoriasis in first and second degree relative generally gives a clue to the diagnosis. Another SPA subtype which can mimic rheumatoid is reactive arthritis. Here, arthritis follows infection elsewhere in the body by 1 to 4 weeks, usually a gastrointestinal or a genitourinary infection. Presents as, unlike rheumatoid, presents as acute asymmetrical oligoarthritis, generally involving bigger joints of the lower limbs, and is associated with one or more extra-articular features like conjunctivitis, iritis, urethritis, or dactylitis. Few patients may exhibit verrucous lesions over the palms and soles known as keratoderma blennorrhagica. Connective tissue diseases can also mimic rheumatoid arthritis, as all of them have got either oligo or polyarthritis as one of their features. Closest mimic among them is SLE. More than 90% of SLE patients have got inflammatory polyarthritis as one of the initial manifestations, where hand joints are also involved, so they mimic rheumatoid. But these patients belong to younger age group, and in these patients, one or more dermatological features are also found, like malar rash over the face. Other features are discoid rash, alopecia, and photosensitivity. 60% of these patients suffer from kidney ailment, and 15% have got neuropsychiatric involvement, unlike rheumatoid arthritis. Anti-nuclear antibodies, although non-specific, are found in 100% of these patients. ANA subsets like DSDNA and Smith are specific for the diagnosis. Sjogren disease is the commonest CTD found in clinical practice, far more common than lupus. This can also mimic rheumatoid arthritis because 53% of these patients have got arthritis or arthralgia, which is intermittent and symmetrical. Problem is further compounded as 60% of these patients have got rheumatoid factor positivity. However, although in these patients, articular features are there, but Zika symptoms like dryness of mouth and eyes and enlargement of the lacrimal and salivary gland dominate the clinical picture and give a clue to the diagnosis. Anti-Rho or anti-LAB antibodies are serologic hallmark of the disease. Infections can also mimic rheumatoid arthritis, and it is important to rule them out before putting the patient on treatment with rheumatoid arthritis treatment, because immunosuppressive agents are known to exacerbate these infections. Parvovirus B19 infection can present with polyarthritis and mimic early rheumatoid arthritis. But in these patients, onset is generally acute with fever, and there is always a history of contact with young children in whom the disease is known as slap cheek disease. Importantly, arthritis improves completely within 6 weeks, unlike rheumatoid arthritis, and IgM antibodies can be detected up to 2 months after the infection. Acute chikungunya doesn't pose a diagnostic dilemma because of its acute explosive onset with fever, rigor, and association of bone-associated pain and swelling of the joints. Chronic chick or PCRA, post-chikungunya rheumatism and arthritis, is a condition when musculoskeletal features last more than 6 weeks after the abatement of the acute stage. If the patient is seen during this stage, it can mimic rheumatoid arthritis, but there is always a history of acute chikungunya in these patients, which gives a clue. Unlike rheumatoid arthritis, distal interphalangeal joints are also involved, and there are soft tissue swelling as well. IgM antibodies appear on the 5th day of the disease and remain positive several months thereafter. Ponce's disease, in fact, is a reactive arthritis, a hypersensitivity response against tuberculous protein, presents with fever, constitutional symptoms, and inflammatory periarthritis, where the small joints of the hands are also affected, mimicking the protagonist. But these patients belong generally to juvenile and young adult groups, and arthritis is generally symmetrical and involves bigger joints of the lower limbs also. A tuberculous focus, mostly extrapulmonary, can always be found in these patients, and MON2 is strongly positive. Chronic polyarticular gout can also mimic rheumatoid arthritis, and gouty tophi can be mistaken as rheumatoid nodule. But gout is always a monoarticular disease in early years with typical very acute onset. And in more than 60% of the cases, initial joint to be involved is first metatarsophalangeal condition known as podagra. It is only later, after several years, if untreated or badly treated, that it deteriorates into polyarticular disease. But history of recurrent monoarthritis in early years is a vital clue for diagnosis. Lastly, needle-shaped monosodium urate crystals in tophi and synovial fluid is the gold standard for diagnosis. Another crystal arthropathy which can mimic rheumatoid, albeit on rare occasions, is calcium pyrophosphate deposition disease. Why rarely? Because it usually presents as acute monoarthritis involving knee in an elderly. Only rarely, which it becomes chronic and affects fingers and wrist joints, that it mimics rheumatoid arthritis. But in these cases, X-rays are very suggestive with the presence of chondrocalcinosis, as you can see here. Lastly, rhomboid-shaped CPBD crystal in synovial fluid is diagnostic for the disease. Well, these are some distant cousins we could not discuss because of the constraints of time. Now let's have a follow-up. After 4 months, can I have 1 or 2 minutes more? After 4 months, the first case reported marked improvement, whereas in second case, there was considerable deterioration with involvement of more joints and uncontrolled inflammation. So the case was revisited, and it was found out that ACR REULA 2010 classification criteria was inappropriately applied. When you apply these criteria, two caveats should be kept in mind. And first is that there should be confirmed synovitis in at least one joint. Now, this was covered because we had 11 joints involved. The second is that the synovitis should not be better explained by any other diagnosis, meaning that it should not be explained by a mimic. So the case was re-examined, and it was found out that she had a skin condition behind her ear and over the scalp. Now, these conditions were psoriatic plaque. So, ladies and gentlemen, the second case was that of a mimic rather than a protagonist. It was a case of psoriatic arthritis. So, to conclude, all polyarthritis are not rheumatoid arthritis. Mimics are there to confuse the picture and need to be singled out to avoid diagnostic errors. Thank you very much for your kind attention.
Thank you, Dr. Neeraj. Now, next speaker is Dr. CHINMOY. Thank you.
Good morning again. Good morning, Chairperson, sir. So it's very hard, and I'm really honored to speak in the same session as both the Jha sirs and Dr. AMARNATH. So I will be speaking on methotrexate. That's the anchor drug, or that's the first drug to be used in a case of rheumatoid arthritis with biologics. So methotrexate, it's considered as the anchor drug. It was developed as folic acid antagonist in the 1940s. What it basically does, in simple words, it calms your immune system, stops your cells from going, and it is mainly excreted by the kidneys, so it can accumulate there, and it is metabolized in the liver. But there are side effects to methotrexate, and main side effects are GI, as already has been told in the previous lecture. So around 20 to 65% of patients have these side effects, and most commonly they have nausea. Abdominal cramps are there, black tarry stool, blood in the urine or stool, increased heart rate, itching, rashes, reddening of skin, hair loss, around 1 to 3%, sores in the mouth and lips, swelling of the eyelids, face, lips, hands, feet. But it has been found that patient can stay on methotrexate for more than 20 years. And the success rate of this drug alone or in combination with other biologics is around 65 to 95%. This is the mode of action, how it acts. It acts on this dihydrofolate reductase, thereby reducing the production of purine pyrimidine, and it also acts on the ACAR transformylase, whereby it increases the intracellular adenosine and thereby downregulation of the pro-inflammatory cytokines. So why methotrexate? See, there are no strict guidelines that which conventional DMARD to be used first. But this drug has got a rapid onset of action than other conventional DMARDs, then patient tolerance, cost consideration, ease of once weekly oral administration. Methotrexate is the DMARD of choice. It is widely prescribed in the world. Up to 25 milligram per weekly you can give as oral, or in some cases you can go, if the patient is not responding, you can go for subcutaneous route also. This is how it acts on the ACAR transformylase, whereby it increases the adenosine, intracellular adenosine, and has got a down regulation for the cytokines. Should conventional DMARDs be used singly or in combination? Combination therapy has got an inherent appeal because as BOA has also invited faculties from all over India, so it's the combination that is appealing. Conventional DMARDs, the combination is especially effective if they include methotrexate as the anchor drug. And combination of methotrexate and leflunomide, they are synergistic. And see, the other conventional DMARD, leflunomide, it is as effective, as potent as methotrexate. But this drug should not be taken with trimethoprim or your trimethoprim because of increased side effects, and with adalimumab that increases the life-threatening infections. Nowadays, this term has come, that treat to target. So in this Euler guidelines of 2022, they have used this term, that treat to target, to use methotrexate as the anchor drug and the first drug. So what happens when it fails? We have 4 options. Either you switch from the oral to the subcutaneous route, add other conventional DMARDs like corticosteroids, hydroxychloroquine, leflunomide, sulfasalazine. You can go on adding biologic agents like your TNF-alpha. One of the main drug, infliximab, is used concomitantly with methotrexate, or you can directly switch over to tofacitinib. The biologics, they they prevent or they suppress the rheumatoid arthritis by preventing the T cell activation, targeting the B cells, or targeting the macrophages. So methotrexate with biologics, it has got a mechanistic reason, increases effectiveness of the biologics, reduce the antigenicity with the drug, means mainly reduces the anti-drug antibody, and prolong the time of you can stay on the biologics, reduces clearance of biologic agent, that is longer persistence of treatment. Some publications supporting this. The 2022 Euler guidelines for the management of rheumatoid arthritis says that you can start with methotrexate, and you can, if they are not responding in 3 to 6 months, you can switch over to add other DMARDs, or you can add JAK inhibitors. So they are clearly shown that methotrexate is the drug of choice for treatment strategy, and then the treatment target is not activated with the first conventional DMARD with poor prognostic factors. Then the DMARD of you can go on with adding JAK inhibitors like your tofacitinib. Thank you.
Thank you, Dr. Chandra. Now, any question out of this first session?
How to deal with the situation when methotrexate leads to nausea and vomiting in a patient? How to deal with a situation when methotrexate leads to nausea and vomiting in a patient?
Nausea and vomiting. See, the best thing is you continue with the folic acid.
Pardon?
Folic acid. The best thing is to either, if there is severe nausea and vomiting, you just stop the drug for a few weeks and then again restart. That is one option. Second option, you continue with the folic acid. Most of the people think that It is a folic acid, this thing, antagonist. So you do not use folic acid. The folic acid reduces most of the toxicity of methotrexate. So you have to continue. Don't take it on the same day, but regularly other days you can continue with the folic acid. And another is you can use folinic acid also. That's an injectable form or active form of folic acid. So that reduces the toxicity.
So your conclusion is that when methotrexate leads to the nausea and vomiting, one should stop it for a few weeks, but continue with the folinic acid. And again restart orally or injectable form.
You restart with the oral form only. If you are restarting, again start from because these drugs, all DMARDs, they have got sensitivity issues also. The patient may be sensitive to that particular drug, whatever drug you are using, DMARD you are using. So that issue may be there. And main thing is you continue with folic acid or folinic acid. Sir, you want to add something? If
the patient is intolerant to methotrexate, so that's what we do. As a repeated nausea, not able to tolerate. There are two options. One is you can try to check for you add folic acid, increase the folic acid, add folic acid, try don't get it out. Any one of those antibiotics. But no, you need to continue with don't discontinue. If is similarly like this, usually this nausea vomiting could be there for the first few weeks, and subsequently they will become tolerant. Give the option if they can tolerate. What they do once a week, less expensive. So you can use the same trial to methotrexate, right? Continuing methotrexate by adding on folic acid or the subsequent single day or 3 to 4 days. It is not getting out of it. Still, nausea and vomiting is persisting. You can use antiemetic on the day of taking the drug or the second day of taking the drug. Still, if you are able to tolerate, you can try subcutaneous or aerosol route. And if you still not able to tolerate, you need to discontinue the drug and switch over to the next. Yes. Subcutaneous. Both are. We can have both.
Sir, my question is how to say the methotrexate is not working and which dose?
We start with the lowest dose, that is 7.5 milligram weekly. You can go up to 25. If it is not working, you go up to 25 per weekly orally. Sir, if it is not responding after 3 months, you will come to know if the markers, they have not come down, if the symptoms, they have not come down, then you go for addition of some other DMR, like your TNF alpha. The best one is your infliximab or this etacept. And he has got a lecture there, so that's why I have not covered it. And even the EULAR guidelines of 22, they suggest that you can directly go with JAK inhibitors.
The dose that you have initiated from methotrexate also becomes very important, and you must choose a particular dose. We are always frightened to use a higher dose, but 15 milligram weekly is optimum oral dose. There are studies to suggest that systemic use of methotrexate sometimes can be more effective, but for the fixed well, friends, I also wanted to highlight one thing as far as use of methotrexate is concerned, that development of when it is used in combination with other drugs, maybe biologics or even non-biologics. Anti-drug, antibody development does not take place. So this is a very important role for the.
Sir, I have we are taught initially that we should, once the case is diagnosed as rheumatoid arthritis, so once you start with all demands, like methotrexate, like a hydroxychloroquine, and sulfasalazine, along with folic acid. So, what is your view? What is your opinion regarding this?
Sir, as I have already said, that combination therapy has got an inherent appeal as well as it has got increased efficiency. But what I am trying to stress here is that methotrexate is the anchor drug. You have to use. If the patient is sensitive or he cannot tolerate methotrexate, you can go with other DMARDs. And you can always combine methotrexate with other DMARDs, conventional DMARDs or biologics or JAK inhibitors. So you have got a wide range of choices with methotrexate. And nowadays it is said that the NSAIDs, means the analgesics, what we are using, it should be used for a very short time, for flare-ups only. They are not for long-term uses, as well as your steroids. They are not for long-term use. You know, the Euler guidelines show that the chronic glucocorticoid dose for a rheumatoid patient is 0. You should not use it. But with methotrexate, you can continue up to, there are studies supporting you can continue up to 20 years without significant side effects. So it's a very good drug, very cheap drug, and it can be used for a longer period.
Right, Professor Anil, well, if I can intervene. You are right to say there are situations where we can have the triple therapy combined, but there are definite indications for them. Is it a low disease activity that you are dealing with, or a medium disease activity, or a high? So, one drug, two drug, or three drug combination can be used. So there has to be indications for them. Friends, there have to be some duplication. So we will be having repeated discussion on this topic. So thank you.
Sir, one. Thank you, sir. Thank you, sir. And it was a very nice discussion. And may I call upon our first speaker, Dr. S.S. AMARNATH, please come. And our President-elect, Dr. Anil Kumar, I'll request him to give a memento of token of respect to Dr. S.S. AMARNATH. Dr. S.S. Jha, please, sir, come. Our President, Dr. RANJIT Singh, please give a memento to Dr. S.S. Jha, our Organizing Chairman and the Chairman of Indian Orthopaedic Association Rheumatoid Committee. S.S. Jha, sir. Pehla Amarnath. May I call upon Dr. B.N. Jha, sir, from Sitamarhi, sir. Excellent talk you have given, and you have really detailed the mimics of RA that will come aware of that. So I'll request Dr. S.S. Jha, sir, to give a memento to Dr. B.N. Jha. Dr. Chinmoy Das. Yeah, it was a wonderful talk, sir. So may I request President-elect and President to give a memento to Dr. Chinmoy Das. Thank you all the chairperson and President, sir. Please felicitate them, and Upender, please come to our chairperson. I think so many of queries will be answered in the next talks. Over to Anand.
So after a very interactive first session, there is a time for the second session. So I would like to call Dr. Hari Prasad sir, Dr. Santosh Kumar sir, and Dr. Ritesh Runu sir. Is he here? I think Dr. Ritesh Runu sir is not here. So I would like to call Dr. Ashok sir, Popular Hospital. Kindly come to the dais and kindly start the second session, sir. Thank you, sir.
We have started the second session, early detection of rheumatic disease. Early detection is main key of the rheumatoid arthritis that halt the disease and prevent the disability. So, first speaker, start with Mahesh Prasad, Patna.
Good morning, everyone, our respected chairperson and learned audience. My topic is spinal surgeon and rheumatology. And this topic is designed by our senior professor, Dr. S.S. Jha. And this is the whole day topic about the rheumatoid arthritis. This is the new thing. So I will try to something related with the spine and rheumatology. So rheumatology is usually a disease of smaller joint or a medium joint, and we usually spare the spine. So I must emphasize that when you see the patient of rheumatoid arthritis, you can examine, you cannot miss the examination of a spine because it's a disease of all the system and all the area of your body. So it's our prime aim to examine the spine. And as a whole spine, the rheumatoid arthritis involve all the area of a spine, but especially cervical spine is more important to involve in this scenario. So, rheumatoid arthritis is an autoimmune disease affecting many of the joints, and the occurrence of spine in which the cervical spine involvement is of 50%. Severity tends to follow disease durations. It means that when the rheumatoid arthritis is a chronic disease, so when a patient comes to you, you must examine the cervical spine as well. Disease modifying anti-rheumatic drug and other biologics are definitely changing the natural history of this involvement. Inflammatory process targeting mainly the synovium of the joint show the area of cervical spine is a very complex ligamentous status. So it will loosen and there has an instability in the first C1 and C2 area. And it also have a necrosis of the bone. So there is a loosening on that area of stability. Destruction of cartilage and bone, synovial cyst, and ligamentous laxity. And your back is not immune to the symptom of rheumatoid arthritis. Here, how to handle this area. So you must, I will already aware that the examination of a spine is not missed in a rheumatic patients. So you must have consider on this area. Basically, a rheumatoid arthritis cervical spine has a three identity of a specific pattern of involvement. First is the stentoaxial subluxation, it's the most common variety. Second one is the basilar invagination, and third is the subaxial subluxation. All these three manifestation of cervical spine, basically it can have a very dire situation consequences of the patient, and a patient may have died due to this involvement. So you must care of that. So first one is C1, C2 instability. And the Ranawat classification has given the status of the patient examination. Class 1, a simple pain and no neurological deficit. Class 2, subjective weakness, hyperreflexia and dysesthesia. And class 3 has two variety: A, objective weakness, long tract upper motor neuron sign, and this is ambulatory. And class V, all these have, but this is the non-ambulatory. The importance of this classification has the treatment role, and the last B had not role to surgery. It's a very worst thing. And the symptom of rheumatoid arthritis of spine is simply a neck pain. So it must be emphasized that whenever you see a patient of a rheumatoid, you must examine the neck, because you just miss it. Usually a patient of rheumatoid come with a smaller joint pain, and usually a neck pain is missed. Swelling of joint as usual, warmth around the joint, headache may present, pain at the base of the skull, especially when the cervical spine is involved, painful and stiff joint, and loss of flexibility and function of joints. These are the C1-C2 instability. You just look the picture, the C1-C2 configuration of the spine. When the movement of the C1 vertebra over the C2 vertebra and the cord in between, so there is the compression of the neural element and the symptom will be there. So how can we assess the instability on this area? So first thing is the ADI, this is atlanto-dental interval. Normally it is a 3 millimeter. It's a normal thing. When it increases more than 3.5 millimeter, it may be an instability. So you must be examined carefully, and it is a simple test by an X-ray, inflection and extension view. You can appreciate the instability there. If the ADI distance is more than 7 millimeter, it must be a very much wide. So there may be a ligamentous instability more. Like this ligament is broken and all the structure is very much compressed here. Second thing, apart from the ADI, the posterior atlanto-dental interval, that means the space for the cord, it is a most better screening test that can predict their cord injury. So if the PADI interval is less than 14 millimeter, it can predict the spinal cord injury. So second thing is the basilar invagination. How can we assess the basilar invagination? Those certain lines in the C1-C2 area, one is the Ranava C1-C2 index. Just draw a line from the pedicle of the C2 vertebra and midpoint of the line of the C1 vertebra. This is the distance. Normally it is a 15 millimeter. If this distance is less than 15 millimeter, it definitely have their basilar invagination. Second thing, another line is the McGregor line. The same thing, the tip is just inside the foramen magnum. So it again show the basilar invagination. And third, the Chamberlain's line. All these lines are basically show their invagination in the foramen magnum and a status of your neural compression. This is the other line by which you can show the invagination. Just see the tip of the odontoid process go above the McGregor line, Chamberlain line, and it will definitely compresses the neural element and cause many dire consequences. Another apart from this, another involvement of a spine is subaxial subluxation. Below the C1-C2 vertebra, you must have subluxed the subaxial spine, and this involvement about 20% of the patient. If the space available for the cord is less than 14 millimeter, then do a surgery, usually a posterior fusion. Clinically, C1-C2 instability, just showing the picture, this is the ADI distance more than 14 millimeter, and basically symptomatic, like simply a neck pain, headache, must be a sign of myelopathy, abnormal gait, paresthesia, difficulty in fine motor control. These are the actually symptoms by which you can predict the spinal involvement. This slide shows if you see a patient of rheumatoid arthritis and having hip arthritis or knee arthritis and examine and you find out the C1-C2 instability, first to treat instability of the C1-C2 rather than THR, before THR. So this is the message. And when do you perform surgery for rheumatoid arthritis in cervical spine? This is the questions and this is the guideline. So surgery should be done if the patient is experiencing severe pain in the neck when cervical spine or other spine is involved and their joint will be damaged. And of course, neurological deficit in the various kind, either is the mild, moderate or severe. So you can see for this surgery. Second, X-ray showing that the PADI is less than 14 millimeter. You should have think about the surgery of the patient. Superior odontoid migration. That means the basilar invagination in the foramen magna, it will definitely a case of surgery. 14 millimeter, you must have our surgical options. And these are the various treatment option of the spine in rheumatoid arthritis. If C1, C2 is unstable, you can fuse this by a first picture is intra-articular arthrodesis, posterior or sublaminar bearing from C1, C2. Second one is the occiput cervical fusion. And third one is interpedicular fixation with C1, C2 with rods. And these are the option for stabilization of the C1 and C2. So the take-home message of this topic, especially the involvement of cervical spine, is the first noticed by the Garrod in 1890s. First noticed the cervical spine involvement in rheumatoid arthritis. Early diagnosis and treatment should be priority because if the spine is involved, they definitely have a very dire consequences, even death of the patient. So you must be very careful about that. Cervical spine instability in the form of three C1, C2 instability, basilar invagination, and subaxial subluxation. The most important PADI interval is better screening test that can predict spinal cord injury, and neck pain is one of the earliest indicator in cervical spine involvement. And all rheumatoid arthritis patient should have cervical spine examination. Yearly aggressive medical treatment can decrease the risk of cervical involvement. Thank you very much for kind attention.
Thank you, Mahesh. You have last thing, if the diagnosis of rheumatoid arthritis, the cervical spine have to examine properly. Only cervical spine is involved, not the rheumatoid arthritis.
Not all spine is involved, but especially cervical spine. Thoracic and lumbar spine is not much involved. And apart from the rheumatoid arthritis, many other spondyloarthropathy involved, like ankylosing spine is much more common in these lumbar area or this thoracic area. But especially the rheumatoid arthritis involvement, cervical is more common, most common.
Thank you.
Next speaker, SS AMARNATH, Bengaluru.
Thank you. Thank you, chairpersons. Thank you. Without taking much of our time, we are already stretching our time now and taking it forward. I literally request each one of you, if you have not silenced your phone, please do it. Thank you. With this in mind, I will run the slides. I'll be very simple and straightforward so that it will be very easy to understand. If there is a question, we will probably answer later, because as we are running late, we don't want to take too much of your time there. And definitely we have lunch, and during lunchtime and post we can discuss. Thankfully, we have learned a lot of things. COVID has such a small microorganism, has changed the entire world scenario. What did you and I take it? We are living in a very, very fragile world, but we have to understand it's extremely essential for we share our knowledge, care for each and every human being, the Homo sapiens. It's very important for us. This is the biggest thing, that we have to unload our baggage and relearn, rethink. So just don't think that I know everything, because learning is a process till the last breath of our, the presence in our very delicate world here. This is a presidential theme. I'm going to repeat it. There will be a lot of repetitions in many of our speakers. Definitely, we did a lot of things. COVID changed the scenario. And we also had so many meetings, one could have been exhausted. Thankfully, today we are all physical, yet we have the virtual scene as well for people who are not able to attend this program. Now, taking it, oh gosh, this is a different one he's given me. Thank you. Apne, I realize it now. No, approach. हाँ, ये वाला. हाँ, thank you. Thanks a lot. But thankfully, we are not majorly mistaken there, but I'm going to run those slides and taking it forward there. Yeah, fantastic. Thank you. My topic has been made very simple by all the previous speakers. So this is where we are. And yes, how do we take it forward? It could be mono, it could be posi, or maybe poly. Doesn't matter. One thing is sure. I don't drink. I don't eat non-veg. I don't smoke, but I still get this. People talk about, a lot of patients talk about it. Patients say, I'm alcoholic. I don't have this problem. I have this problem. I'm rich. I'm very poor. Doesn't matter. As a human being, it affects each and every one at certain stage, or early or late. Doesn't matter. All of us are going to go through this. Many are very, very blessed souls who may not get this in their lifetime, but majority go through this issue. So that is where we need to understand. We have to address this. Previous speakers have said early detection is extremely important. That is where the key factor for us is to make sure that mono doesn't go into posi or even poly. So that's where the whole challenge is. I'm not going to be dwelling into the ACR or UDOC criteria, which has been told enough, and it's going to be banged on your high heads in the future classifications and the detailing as well. The key factor Dr. Jha did mention about is the important one, where if we need to have infection, how and where the emergency comes into picture. That is where we need to address it. We may miss a key factor by missing an infection. So we all have learned DOLA, PALA, CALA, and so many things, what the inflammatory responses are in our body. But similarly, we need to pick it up and treat accordingly. Unless you and I differentiate the challenge, we'll not be able to treat it right. So that is where the key factor comes into. Well, yes, fracture is a parameter, injury, if not fracture, at least even a soft tissue injury can mimic a lot of things. Many patients do forget, and we are dealing with many of the geriatric patients who are senile and also having little challenges in the remembrance of Alzheimer's kind of a thing. So naturally, there is issue. There are issues that we need to address it. So that's where the whole challenge comes into. Differential diagnosis is essential, and locating it is important for us, so that when once you and I know the cause, we can treat effectively. So that is where the way we need to approach each and every arthritis wherever we are going to be dealt with or dealing with. Now, modalities, Dr. Jha has insisted so many things on history. Listen, listen, listen. Taking it extremely important. Today, you and I as surgeons, we are very happy go knife lucky people. But are we doing the right thing by using a knife deliberately or irrelevantly or unethically? So we need to be very careful in our usage. Yes, that is very important for us. We need to look at clinical diagnosis is 95 to 98% is made in the history. That is the biggest thing. You and I don't have time. We have so many patients waiting. when you listen to the patient pours out the diagnosis right into your hands. So that is where the key factor. Imaging, hematological, serological are secondary, supplementary, and to cover you and I, what is called as medico-legal. Yes, that's a part of it, but definitely are essential so that we could indicate and treat and prognostically evolve and evaluate the next kind of treatment, what we may need to change, continue, or probably discontinue. So those are the things which is very, very important for us. So without taking much of our time, I'm going to finish as early as possible. History, extremely important. There is a satisfied ask what Dr. Jha said. A teacher like Jha has given this is the golden words that we as practicing surgeons, be it young, energetic, and also seasoned orthopedic surgeons or doctors, we need to make sure that we have this. Today, we have this very, very basic. I'm going to go very basic here. So that's the reason we have to understand that many kind of conditions can be coming in there. A simple thing from trauma to infection to synovitis of many, many origins can come in the picture. But it could be an acute one. It could be insidiously coming in. It could be going on to chronic nature. Before it gets into chronic and destructive, we need to address it very early. That's where we need to have a clear-cut approach as what we need to do. So that is very important for us. Now, this is the key factor for us. It could be arthralgia, polyarthralgia, or arthritis going into. So that's where the key factor comes in to make sure we don't get into that problems. Now, taking the next scenario in the pattern of involvement, how do we take it forward in the history and clinical examination? Very, very important for us. So this could be a key factor that you need to understand if it is migratory, or it could be simultaneously present in the inflammatory response. This is extremely important here. Is there a flare-up or a recurrence that we need to pick up? And it could be episodic. So that is where we need to make sure what kind of conditions affects which. I'm just naming a couple of them here. Doesn't mean that it's only limited to this, but that is the understanding that you and I take home. Now, Dr. Jha also mentioned earlier that it could be symmetrical or asymmetrical. Thankfully, if you and I believe in God, we had 4 limbs and today we have 2 limbs that we walk on. If one is affected, you and I are disabled, not going to be easy. Being we are either right or left-handed, we are not polydextrous like many, but even with one finger in a dominant hand, one small joint of PIP or DIP is involved, it's disabling. So we need to make sure that how we can make it better. So that's where the key factor comes into picture by understanding. And you can also differentiate in the kind of distribution of the joint problems that one occurs in a condition, which is very typical to certain arthritis. So that is the key factor. Now, Dr. Mahesh talked about the spine. Even there are quite a few things where it doesn't have to be the limbs alone. Even the central axial spine can give you the challenges. That's very important for us. So keeping that in mind, we move forward in the movements. What kind of movement that one can have? That's the biggest thing. Is it the whole day, the get up in the pain, or the sleep in pain, when they get up, the morning stiffness? We can go on and on, right? So we need to differentiate in these kind of very clear what condition is suffering from. And obviously we need to never ending story. I'm going to repeat here. It has to be very clear in the history. I'm going to run a couple of slides. I'm sure you and I can read, even the last bench, even in the, even the trade partners can read that probably. If there's any issues, let me know. I will talk about it. So we may need to understand, is it intra or extra? It could be juxta-articular. So those things are very important for us in certain conditions where the joint is affected, how you can treat it medically, surgically or intervening, probably either invasive or semi-invasive. It could be infiltration into the joint. So treatment comes into picture later. So that's the reason you and I have to be very clear, where do we go from here? And earlier speakers also talked about the hidden challenges of patient not coming out very openly. It could be the religious factor where they have clothing from head to toe, but not easy. They may not want to tell. So this is where you and I come into picture. There are limitations for us. There are issues with us. So we need to tackle that and make sure that we diagnose it very, very clearly. And many a times as orthopedic surgeons, we talk about the soft, never talk about the soft tissues. We are very keen on bones. This is the biggest challenge. In fact, there is one whole day discussion on the prebiotics and probiotics that has changed the entire scenario of arthritis in humans. So that's another total field. We can look at organizing another event, another conclave only on that. That's the kind of thing we can talk about. You know, that is where we need to make sure that it is seronegative or positive. The next speaker who's going to come, Dr. RENUKA, is going to be talking more on the investigations. I will not touch upon that. So clinical examination and history taking. Postgraduates, you and I need to spend more time with the patient understanding that. I'm going to hit the nail on the head repeatedly. Sorry about that, but that is where we are. That's where we need to focus. So this is where we can approach very clearly. So this is where the whole thing comes into. It's not just taking a pulse or BP or the weight or even BMI, doesn't matter, but that has a bearing. Pulse can give you majority of changes that's happening, will give you a clue. So apart from that, you and I need, the moment you see a patient, you know, the way they walk, the way they sit, the way they stand up, you can pick up the diagnosis. You could be Sherlock Holmes of the diagnosis of this particular conditions. So that's where we are. So we need to make sure physical examination is extremely important. I'm going to go back on those slides, a busy slide, excuse me for that. There's a chart, I can't change it. And I'm not going to be dealing with the intra-articular changes and challenges because it's in rheumatoid, it's systemic. Presentation comes into picture for joints. That's where we are. And I'm not going to be touching upon each and every aspect of osteoarthritis either, but this is where challenges comes into. You need to make sure in clear-cut diagnosis, you and I evaluate very clearly and taking it forward with the kind of symptoms, signs, and the examination point that we put across and taking forward. I'm not going to run on each and every slide there. One issue which was also been talked about earlier, joint aspiration and joint fluid analysis gives a better clue. So very important for us. We need to take points. I'll not be touching on the ACR points or EULAR guideline points, but we need to make sure that there is issue. It could be an axial spine that is causing the problem. It could be your weight bearing or non-weight bearing joints which are affected. Make sure that you and I take a clear-cut history on their bowel habits, food habits. That gives us a very, very key factor. In the last 25 years to 30 years of my journey in arthritis, I have given, my prescription is not complete without giving them a pre and probiotics, and people have come into remissions in a big way, even with biologicals. I'm not going to be touching upon that. There's a lot of other speakers will talk about it, but this is one point you need to understand. So with this in mind, I'm going to be finishing my talk. Osteoarthritis, no, I'm not going to be touching upon that. This is very important. We have to address this extremely fast and clear cut. If there is a septic arthritis, you need to, diffuse it. That's where the key factor comes into. The moment you diffuse the joint, inflammation is down. What appropriate antibiotics is to be given. Till you get the culture report, you need to cover the patient with some appropriate antibiotics, broad spectrum. And today we are seeing the COX coming back. The skeletal COX is coming back. It is affecting many of them. So this is where the whole challenge comes into. So make sure you and I take detailed history, clinical examination, and appropriate investigations tool to make sure. Again, going back, I'm inviting each one of you there, and thank you.
Thank you, Dr. S.S. Amarnath. Very nice talk. Next speaker is Dr. Renuka.
Patna, RENUKA. Yeah, second. Good morning. First and foremost, I would like to thank the organizers for having given me this opportunity to speak on this August forum. I bring to you greetings from Chandra Diagnostic Lab and Bangalore, the Garden City and the IT Hub. Today I'll be speaking on rheumatoid arthritis investigations. And I, being a pathologist, will give you a perspective on some of the, not just the tests, but even a little bit on methods, so that how to interpret them also becomes important. From morning, it has very clearly been already discussed that rheumatoid arthritis is a common inflammatory autoimmune disease, which is characterized by chronic erosive polyarthritis and by the presence of various autoantibodies, both in serum and synovial fluid. When a patient is genetically susceptible, and in case he has other environmental factors, which could be smoking, obesity, dietary habits, patients on oral contraceptives, these patients are more prone to developing this rheumatoid arthritis. And when these people are infected by any infection, it generates autoreactive T cells. Once you have this autoreactive T cells, there could be an expansion of the inflammatory milieu, epitope spreading happens, and finally you might have pathogenic autoantibodies. And once these pathogenic autoantibodies are present, it can lead to rheumatoid arthritis. What I would like to say here, if you look at, do you have a pen drive? A pointer? In a patient, these antibodies can be present earlier, much before they become as a full-blown rheumatoid arthritis. So you have at the base a patient who is pre-symptomatic, transitions to symptomatic rheumatoid arthralgias, and then develops rheumatoid arthritis. We all know that the diagnosis of rheumatoid arthritis is currently based on the ACR 2010 criteria, and new criteria have emerged for early rheumatoid arthritis, and markers such as inflammatory markers such as rheumatoid factor and anti-CCP have become very important currently for the diagnosis of rheumatoid arthritis. So if a patient has polyarthritis with a positive rheumatoid factor, citylated peptides, and also has high CRP and ESR, then there is very high likelihood that the patient will have rheumatoid arthritis. What I would like to say is not just the positivity, even if a patient is having, you can have a higher point if the patient is having a high titer. And when you say high titer, it indicates it is 3 times the upper limit of normal. But first and foremost, of course, I didn't mention, because it has been mentioned from morning, that clinical symptoms are important. Initially, for diagnosing rheumatoid arthritis, picture has to be there, clinical picture has to be there, patient should have polyarthralgia, possibly involvement of the small joints, and then you have to establish that it is inflammatory in nature. You have to look for whether there is high ESR or CRP, and then go on for rheumatoid factor and CRP. Coming to, I will be focusing on these parameters, rheumatoid factor and anti-CCP. The rheumatoid factor was the first autoantibody which was discovered in rheumatoid arthritis patients way back in 1940 when they saw agglutination of the sheep RBCs, and which was then labeled as rheumatoid factor. Mind you, it is a very common condition, commonly mentioned as RA factor. It is not RA factor, it is rheumatoid factor, because it is not present only in rheumatoid arthritis. So it is better to use the terminology as rheumatoid factor. It is produced in the inflamed synovium by the B cells. When we do a histopathology, this is the picture that we see under the synovium, where we see increase in the lymphocytes with lymphoid follicle formation. So basically, it is produced in the inflamed synovium by B cells inside lymphoid follicles. And it is this antibody, that is the rheumatoid factor, is an autoantibody that reacts with the FC portion of the polyclonal immunoglobulin. These high affinity and high titer rheumatoid induce the formation of immune complexes at the site of synovial inflammation and cause activation of the complements, leukocyte infiltration, and increase inflammation. Arthritis. So this is an antibody, which I've already mentioned, reacts to the FC portion of the polyclonal IgG. And most of the assays that we detect for rheumatoid factor is basically an IgM rheumatoid factor. This test can be done by various methods, what we call as latex agglutination, immunoturbidimetry, or nephelometry. Latex agglutination is a very simple test, which can be done in any PHC or anywhere on the field in camps, wherein you take a slide, you look for an agglutination assay. But however, there are problems with latex agglutination because it is a semi-quantitative assay and you do it in titers, 1 in 20, 1 in 4, or 1 in 40. So whereas immunoturbidimetry and nephelometry are automated methods, so it has a very short assay time. When you send it to the lab, it is simple to operate, it has a very high sensitivity, and most important of all, it gives us the quantitative value. The other aspect which I would like to bring in is, suppose a patient has rheumatoid arthritis. You may come across problems, patient is having, the orthopedician or a physician will say, patient is definitely having rheumatoid arthritis. He is having all the symptoms. How is it that your rheumatoid factor is negative? So what happens when you do a simple test like an agglutination test? What will happen is there is a maximum antigen antibody reactions in a zone of antibody. Then it may so happen that because of the excess of antibody, there may not be a proper antigen antibody reaction which is happening. And it might, which is called as a pros-and phenotype, advisable to go for a quantitative assay, could be a nephelometry or an immunoturbidimetry. Nephelometry requires a separate instrument, but turbidimetry can be done in any of the routine biochemistry instruments, even a semi-automated biochemistry instrument. You can do a immunoturbidimetry method. So it is advisable that you insist on getting a quantitative assay for rheumatoid factor. Factor is present in 75 to 80% of patients with established rheumatoid arthritis. And of course, in early rheumatoid arthritis, it might not found only in 40 to 50% of cases. Again, we have already said it is not just that, it is very non-specific, present in about 5% of the general population. So you cannot use it as in this kind of a forum tomorrow, one of us can easily be positive for rheumatoid factor. And it is also very non-specific, found in other connective tissue disorders, as well as some chronic hepatic and pulmonary disorders, cryoglobulinemia and lymphomas. But the one part of it is that high level of rheumatoid factor is a prognostic indicator. Because the higher the titer of antibody, that the patient probably has aggressive disease, he has increased disease activities for monitoring. It does not wane and wane based on the disease activity. It is just an indicator, a prognostic. We all now antibodies were first discovered, reported in 1998 by the Van Banerjee group. And these are produced again by the plasma cells in the rheumatoid arthritis joint. So they are actually present at the site of inflammation. Several citrullated proteins can be found in RA. However, Fibrin, which is a degradation product, is the most citrullinated antibody, protein which is found in arthritis. Whenever there is an inflammation, what happens is there's infiltration of the immune cells, the leukocytes, the macrophages, lymphocytes. Then there is an increase in the enzyme PAD, which leads to cell death, increase in the calcium concentration, and ineffective clearance of apoptosis in turn cause citrullination of the target antigens, which is the arginine, which is converted to the citrulline by the enzyme PAD. And here it is where it gets citrulated, which then cause the activation in the susceptible individuals, which are the HLA-DRB1, which sir has already mentioned in the morning, and the which has the single epitopic allele carrier, and cause also the activation of the B cells, release of antibodies, formation of immune complexes, upregulation of the pro-inflammatory cytokines, and perpetuation of inflammation. Simultaneously, these antibodies also work on the bone, causing osteoclast, causing osteoclastogenesis, causing erosive disease, net formation, and complement activation. So it just does not play, CCP is not just a marker which is found at random, but it also plays a role in pathogenesis. So there are various types of CCP tests. You have CCP1, CCP2, linear CCP, RACCP, but the cyclic form is the one which is more specific, and it was first commercially available in 2002. And these CCP peptides, CCP2 antibody is the one which is most commonly used and which has got a high sensitivity as well as a high specificity. The anti-CCP assays are generally done by the ELISA method, but now because of the need, because even before the test reaches, the sample reaches the lab, the doctor is in a hurry to get the report. So that being the thing, we have all moved to chemiluminescence immunoassays for detection of anti-CCPs. And these assays, however, have variable cutoffs. So you have to harmonize it to your lab. There are some equipments which are of Roche, which gives a cutoff of 17, Abbott gives of 7, Diacerin gives of 5. So you have to correlate, but generally they all correlate with the parameters which are found when you harmonize them. Anti-CCP I've already mentioned. What is good is it is produced locally in the inflamed joints. So it is present much earlier before the symptoms happen, develop. So it is frequently positive early in the course of the disease. And unlike it is not affected by other conditions, and it is extremely specific for rheumatoid arthritis. Though it is not picking up all the rheumatoid arthritis cases. We had done one study over here wherein we proved that in early cases of rheumatoid arthritis, where the RF was still negative, anti-CCP picked up quite a few cases, and it is a very good marker in the diagnosis of rheumatoid arthritis. So in addition to that, it is also a prognostic marker, just like what I have described in rheumatoid arthritis. High levels indicate that patient can have erosive disease, it can have a persistent disease, and it decreases with remission, induction, and increases, but still it is not now currently being monitored as far as the therapeutic is concerned. So, as I said, there are quite a few cases, though which we are doing rheumatoid factor and anti-CCP, which we are missing of rheumatoid arthritis. So that is why newer antibodies are being developed. And one of these antibodies which has already been come into use is the anti-carbamylated P protein antibody, or the anti-carb antibody, which is detected though only in 45% of rheumatoid arthritis. It is known to occur in those patients which are citrullinated peptide antibody negative. So the advantage is that it will increase the sensitivity. Instead of doing 2 tests, probably we may have to go for 3 tests for early detection of rheumatoid arthritis in those cases where it is, unclear, the picture, or where you want to detect early. Of course, there is no need of doing so many tests when there is a clear clinical picture and you are able to diagnose with a single test. So its presence in RA is associated with more severe joint pain and might be a useful biomarker in the early cases, as well as it has been detected in juvenile idiopathic arthritis. There is another antibody which is there, that is the PAD4. I'm sorry, okay. PAD4, which is a calcium-dependent peptidyl argin, which I said was the enzyme which helps in the citrullination of the antibody, which has been found. Though it has a low specificity. Its prevalence has and extent of interstitial lung disease was found to be higher in patients with rheumatoid arthritis. So a patient who is having rheumatoid arthritis with a complication of interstitial lung disease, this test could be useful. Other antibodies are there, like BRAF antibodies, RA33 antibodies, malonyl-dihaldehyd and anti-malonyl. These are all in the pipeline, but they are still, none of them have given as good importance, and they are not yet into the clinical practice. So currently for me, it is rheumatoid factor, anti-CCP, and if required, a carbamylated P protein, which will be required. So the rheumatoid factor and anti-CCP, of course, are remarkable antibodies currently used in diagnosis. Anti-CCP helps in early diagnosis and has a high predictive value compared to rheumatoid factor. And it is associated with both RF as well as CCP associated with severe and erosive disease, not useful in monitoring. And it is very clear that it is a rheumatoid arthritis, a heterogeneous disease characterized by presence of many antibodies. But what is required is, for all the labs, a harmonization of the assay procedure and cutoff values is necessary. Mind you, even in our criteria, they never said this should be the cutoff value. 3 times the upper limit, 1 time the upper limit. So whatever is the lab established cutoff value is what we should take into consideration. Thank you so much. I'm open for questions.
Thank you, Dr. Renuka. Thank you very much. Very good. I mean, your talk on diagnosis. Okay, thank you.
Thank you, sir.
So, may I?
Sure.
Question and answer will be, I mean, after, I mean, completing this session.
Sure.
So, may I invite Dr. S.S. Jha, sir, for next talk? After that, we have. Sir.
Well, friends, I think the time is mature when everybody is eager to hear the learned speaker, Dr. Chandrasekhar. So I drop my presentation for now, and we will switch over to the next session. We will save 15 minutes more. Thank you. Thank you very much.
Thank you all the speakers for the wonderful session. We'll have a 5 to 10 minutes of tea break. Otherwise, the tea will be served at your place. But if you want some snacks and all, you can have it. So in the meantime, I'll request, thank you all the chairperson, and I'll request Dr. Mahesh Prasad to come and take a memento from our chairperson. And the next, Mrs. Renuka. Wonderful talk, ma'am. We'll have a discussion later on after this. Please come on the stage and have a moment of token of respect and love. And may I call Dr. S.N. Sarraf, sir. Dr. S.N. Sarraf, sir, please come, our past president, who will be giving a moment to Dr. Renuka. So Dr. Mahesh Prasad, momento. He's our past president, ma'am. Dr. S.N. Sarraf. Chairperson, we'll shortly call you, sir. Thank you so much, sir. Discussion. So in the meantime, we'll have a 5 to 7 minutes of discussion. So if anyone wants to ask a question, you can ask to Dr. Mahesh Prasad, Dr. S.S. Amarnath, Dr. Renuka. So any question?
Yeah, here, sir. My question to Dr. Renuka.
Any question from any of our
ma'am here
speakers? Where is Dr. S.S. Amarnath? I have a question from Dr. Amarnath. Please listen me. Dr. S.S. Amarnath is here.
Yeah.
There's one question. There's one query. Please, sir. So, actually, what do you do when there is diagnosis dilemma, in particular the monoarticular arthritis? Diagnostic dilemma means sometimes you confuse with the rheumatoid or tuberculosis. So we have, after many investigation, suppose even with TB or rheumatoid factor, NTCCP, whatever you done, even you have done synovial biopsy. In spite of that, we are confused. So which we should start treatment for rheumatoid or tuberculosis?
See now, the guidelines on tuberculosis treatment is extremely clear because the National Board of Tuberculosis has very clear-cut understanding. Empirical usage of anti-tubercular 84, 80K3 is not recommended. Not recommended unless you have a proof. One, histopathological is biggest thing they talk about, or if you have a serological. But again, Dr. RENUKA can highlight probably in case if you were to have what we call as the TB-feron or interferon, then we could probably talk about, is it an active disease that we have in the body or is it an inactive? Probably
where we work, we have all tests done for rheumatoid arthritis. Okay, it is all negative. On for tuberculosis, yes, it is negative, but problem is there. So what treatment we should start? So that there is a gray zone where we have dilemma. So which treatment? Suppose you have to give some treatment. Even after synovial biopsy, there is very lot of confusion. If there is granulomatous tissue, there is no causation. We cannot say it is tuberculosis. So what the treatment is?
Whether it is a monoarticular.
Exactly, I'm telling you monoarticular.
Then you will have to provide. Sometimes we do a biopsy. Yes, we do give a non-specific synovitis many times. And sometimes we do get a classical granulomatous inflammation as far as histopathology goes. But see, if you want to monitor an assay, then what he's asking, I don't know, probably you as clinicians and doctors.
You can close it.
Probably the patients, Chanakya and Dr. AMARNATH,
Yes.
to guide you on that aspect. But as far as the question on is something like a wanted test. So it is not it is an objective test. It is not a test for diagnosis of tuberculosis.
Exactly.
It is not a test for diagnosis because it can be any latent tuberculosis, which many of us probably. But still now there are better quantiferin assays where we also do the microarray test and there are tissue tests and all, where we can sometimes differentiate, but still we are not really able to clearly identify whether it's active or latent disease. It is the clinical picture itself which will be guiding whether the other history, whether the patient has any other cervical cardiomyopathy anywhere else, he has any other condition. You give a whatever you treat your monoarticular arthritis, your X-ray findings, all this clinical picture
Sir,
will actually help in differentiating.
please, your experience, sir. If you don't find any, diagnostic criteria fulfilled, if it is tuberculosis or monoarticular arthritis, so which treatment do you start, sir?
Sir, I'll just add a couple of instances where we have come across 2 or 3 of such cases where I think we have used the TB test just as a negative factor. Because what you don't want to do is start or be over enthusiastic on any immunomodulating therapy if there's an infection. That is a clear no. So the test,
Monoarticular arthritis.
exactly. So that is where infection is the main reason, and TB is the main reason. If particularly it has been chronic, what I can say is TB, which is there for many years, with a good MRI, you should be able to find out the bony lesion. It will not remain synovial. And good MRI these days and a negative PCR, which will not be only from fluid, also you need to get some tissue. So for that, to save the patient's money, I can just put in a JD biopsy, scratch around a little on the local anesthesia, get a little bit of tissue, send that tissue. Then my microimmunologist is happy that we ruled out PCR 2 times from fluid as well as from tissue. Then safely, what I would do is then you think about the other process of probably some radiation CHINMOY to be a very rare indication for cytology, because then that allows you to start some demand. I mean, it's okay. That's the line of approach we have.
There's more than positive, negative.
Yes.
Go for, I mean, too much investigation and patient poor. In that condition, we start tuberculosis first. The reason being, once you want to start tuberculosis, may, I mean, worsen the condition and patient responds many times.
So there is a very famous proverb that if you have to ask
Exactly.
between the diagnosis of tuberculosis and rheumatoid, you are on the side of tuberculosis.
Exactly.
You find what's the difference for rheumatoid?
This is the answer, in fact. This.
As long as each and every one of us are going to be counseling the patient, extremely important, and documented, because you and I don't have to be taken or dragged to the court of the law. That is happening. Document, counseling.
So
Yeah.
interestingly, just 2 cases this week, and suddenly they put up that there are cases throw you off your balance.
Yeah.
So one case, he done an arthroscopic synovectomy because you don't want to open, and he started DMART. The other one, exactly like you said, I had put him on DMARTs. I'm sorry, anti-cox treatment. 2 months back, he had a discharging sinus after a DKR. 4 years after a DKR, suddenly developed a discharging sinus, and I was puzzled. So after all, two successive negative microbiologies with a good microbiology lab, good surprise, including negative PCR. But with that, with the prosthesis inside, I had to give an antibiotic. So I just gave the everything subsided, but nothing grew. Interestingly, 2 months later, when I see the patient, he shows me neck nodes, added neck nodes. I said, great, this was the plan.
So I think we are running sort of a time. So I request all the delegates and faculty members, please take your seat and keep quiet. We'll start our next session just now.
Last question from Dr. RENUKA. You have talked about the rheumatoid factors. Now, there is IgA, IgF, and IgE. But never reports are coming in this form. All the 3 reports are available. They can be of prognostic value as well. Thank you very much.
And Madam RENUKA, can anti-CCP bill act, we can prescribe as a prognostic test? Like rapid, not for monitoring. And suppose without any symptom, if the anti-CCP is positive, can we warn the patient that you might have rheumatoid in the future? No.
It is not like I see an 8 test, I know what it is.
Right. Clinical situation. Yeah, definitely.
Dr. Renuka, I would like to ask one question from your side, because so many orthopedic surgeons here and they all criteria for the diagnosis of rheumatoid arthritis. But your side, I want to know, tell me one or two tests by which we can assure, yes, this is the rheumatoid arthritis.
Even if it is 2 joints, 3 joints, small joint involvement, over a duration of more than chronic course of more than 2 months, 2 months criteria has to be met with. So it's a chronic, it's not something that is just developed. With a high inflammatory character like ESR or CRP, as well as a rheumatoid factor positive or a high even if it is not anti-CCP, just rheumatoid factor.
Yeah.
Oh, thank you so much. So the chairperson be here. I'll request Dr. Subhash Chandra please to give a floral bouquet to our chairperson. They have done a very remarkable job. I'll ask Dr. Hari Prasad to join. Dr. A.K. Sinha. And Dr. Hari Prasad. So over to Dr. Anand for the next session, please.
So after the end of highly igniting session 2, now next let's start with session 3. So may I call upon Dr. Manoj Chaudhary sir, Dr. Subhash Chandra sir, and Dr. Vinod Singh sir kindly come on the dais and start the session 3, sir. I think Dr. Vinod Singh sir is not here, so I would like to call Dr. Rajat Charan sir. Kindly come on the dais, please, sir.
Now I call upon Dr. S. Chandrasekhar from Bengaluru for his topic on approach arthritis. Basic and red flags indicating it is more than arthritis. Dr. Chandrasekhar.
Good afternoon. At the outset, I thank the organizers for sharing some thoughts on arthritis. I think in many of our previous speakers have covered about how to approach and what are the ways and means we need to look into when a patient walks into us with a joint pain. So usually, I think Professor Jha made it clear that first we need to ascertain ourselves the pain for which the patient has walked into you is really from the joint or not from the joints. I always put the first term, is it arthritis or not? And the next term we have to resolve ourselves is it arthritis or arthralgia what we are dealing with? Because sometimes the pains in the joints, which could be from the small joints.
Please have your seat.
Yeah, I think it's audible. Yeah. If the moment the patient walks in with a pain, say even in the ankle or in the small joints of the hands, so the question that comes is it from the joints or is it from the neuropathic or is it from the muscles or is it from the nerves or is it from the ligaments surrounding it? So we need to ascertain that the pain is from the joint. The next question that comes is it inflammatory or not inflammatory? And the subsequent also what we have to make ourselves clear that is it periarticular or articular? Is it from the surrounding joints or from the joints? Why I'm saying is a leukemia can also present with a joint pain. A metabolic bone disease patients may walk into you with a joint pain. The patients who has an injury long back may also walk into you and may not let you know anytime that I had a joint or I had a problem for several reasons. It may be a fight in the home between the husband and may not like to reveal that has happened. So pain arising out of the joint, if so from the joint, is it inflammatory or non-inflammatory? If it is from the surrounding structure, which could also be involved by inflammation, whether it is the ligamental or other periarticular structures which are inflammations, that makes us very clear whether it is the patients whom we are dealing, is it arthritis? So then having known that it is an arthritis, the next way we approach is based on the numbers. I think Dr. Amarnath has dealt that. We call it as mono if it is single, oligo between 2 to 4, poly if it is more than 4. The differentials approach will depend upon if it is a single joint. We most often acute onset, we think of sepsis. If it is single joint, elderly, we think of possibility of osteoarthritis. Single joint in the toes, acute onset, possibility of gout. So if it is oligoarticular, then the differential is going to be reactive, psoriatic, and others. And if it is polyarticular, then we think of rheumatoid, psoriatic, and so on. So just by the count, we are likely to have a differentials in our diagnosis. And the other critical point we like to differentiate ourselves, as I said, is it inflammatory or non-inflammatory? Why this point should be clear is, when we talk of an inflammatory arthritis, most often the problem what we are dealing with is more often a systemic disease rather than a localized joint disease. If it is non-inflammatory, you are looking into a benign conditions more often. It could be fibromyalgia, it could be sometimes a metabolic disease, even it could be an endocrinal disease like Hashimoto thyroiditis. Thyroids, hypothyroids can just present to you with the multiple joint pains. It's in our practice in the last 20 years, I can say in a year at least 5 patients with a early onset diabetes walks into you with a joint pain. Look at their sugar. Sugars are high. Glycated HP will somewhere around 7, 7.5. The articular manifestations what the patient was walking in to you or to me was an early onset diabetic and diabetes associated arthropathy. So they are all non-inflammatory variants. Most of them, when it is inflammatory, you are dealing with a inflammatory autoimmune rheumatic disease, a long list which is there, starting from rheumatoid arthritis to so on. So the next thing what we do is, following the type of counts, you would love to know whether it is inflammatory or non-inflammatory when you are trying to approach the diagnosis. Then comes the pattern of involvement, additive, migratory, or fleeting type, or what is the varieties on which it is coming. Episodic arthritis are more often in gouts. Migratory type of arthritis, what we classically see in rheumatic fever, it's not just for rheumatic fever, you also see in immune complex diseases. Any migratory arthritis is one of the red signal I always keep on telling. Either you are dealing with a rheumatic fever if it is an young child, in an adult if it is a migratory type of arthritis. What I mean by migratory is pains at knee, pain settles in the knee, even the swelling settles down, then he develops in the ankle. Ankle starts healing, then it moves to the wrist. These kind of migratory type of joint pain is one of the warning signal of immune complex diseases. Most of the immune complex disease, what you see in adults are lupus or lupus related connective tissue disease. In young children, what you see of these kind of migratory arthritis are rheumatic fever, especially where the poverty is still stuck with rheumatic fever is still there in the children. So you need to be very careful about a possible missing diagnosis of rheumatic fever, especially in a child when he comes with a migratory type of arthritis. So next question that we all have to look at is whether it is a deforming or non-deforming. I always keep telling, please see to that we should not come to a point where we should make a diagnosis after the deformity has settled in, but there is other way around looking. A patient not on treatment, on some alternative or any other therapies, comes to you after 3 years without having deformities. That's a point where you have to think twice to label this patient as rheumatoid arthritis or a psoriatic arthritis. Most of the rheumatoid arthritis patient, if not appropriately treated and managed, will have one or the other mark of deformities or erosions. If there are no erosions, a non-erosive arthritis of more than 3-year disease, you need to seriously reconsider, is it a connective tissue disease? Is it a scleroderma? Or is it simple fibromyalgia or a metabolic syndromes like hypothyroid, etc.? So presence of or absence of deformities post 2 or 3 years in an improperly managed arthritis. If he is properly managed, appropriately managed, rheumatoid arthritis may not have the deformities. So absence of deformity in an inappropriate managed arthritis patient, you need to reconsider, should I entertain a diagnosis of rheumatoid arthritis in these patients? Because it's a little unusual, very rare. Very 5 to 10% of rheumatoid arthritis who have milder diseases may not develop rheumatoid deformities despite not being treated appropriately. So that's why non-deforming arthritis, think twice to label it as rheumatoid arthritis. I think Dr. RENUKA said very clearly, even if rheumatoid factor is positive, non-deforming arthritis, think it still may not be a rheumatoid arthritis because Sjogren's syndromes have a highest possibility of rheumatoid factor positivity. Lupus and scleroderma are not an exceptions where you may still have rheumatoid factor positivity. Hepatitis C viral infection and hepatitis B viral infections can also present with polyarthralgia or polyarthritis without developing deformities. In them, it's an immune complex disease. Usually they are migratory, transient, episodic. So as I said, absence of deformities of a longer duration arthritis should raise us a suspicion. Am I really handling a patient of rheumatoid arthritis? Why these are all critical? Because the moment we say rheumatoid arthritis, we are planning to start them on disease modifying anti-rheumatic drug. Is it worth? Is a question which we have to address ourselves. For example, if it's hepatitis B or hepatitis C associated arthritis, you may, if you put methotrexate or leflunomide, you are doing the heinous mistake because you are putting a drug which is not otherwise supposed to be prescribed, even if he has a rheumatoid arthritis, even if he has rheumatoid, Hep B, Hep C positive, normal recommendation is not to use methotrexate. So when he doesn't have rheumatoid arthritis, you need not prescribe those drugs. So in addition to that, the most of the red flag signs are arthritis plus. What I mean is, if a patient has, in addition to the joint pain, any other additional symptoms, you need to think that it is not a simple arthritis what we are dealing with. Most often are skin changes. For instance, if patient has photosensitivity and a malar rash, the case what you are dealing is lupus. Patients with a polyarthritis or joint pain has a heliotropic rash or a face rash or multiple rashes in different sites. Possibly what you are dealing is the early dermatomyositis. And the patient with cutaneous or skin rashes or a purpuric lesions, it could be vasculitis, presence of vasculitic ulcer, Raynaud's phenomena, any other things if you see, or what we call it in our rheumatology term as arthritis plus. If you have any other additional symptoms, the patients what we are dealing with is not a simple plain rheumatoid arthritis or a spondyloarthropathies. These are all having a possible systemic complications which needs an attention. Because all of you agree, the fundamentals in our healthcare or a health management as a doctor is do no harm. If the do no harm also includes a passively doing a harm, in a sense, the delay in diagnosis of a case which needs an early intervention, like lupus, vasculitis, where if you pick the diagnosis, you are going to go do a good job or a good thing with reference to these patients will be missed if you don't look into these things. So what it looks like is a malar rash, especially in the Indian skin, we are little colored. It may not be the classical picture what you see in the textbooks. you have to look carefully over the face to look for those malar ulcer. That's why I picked this particular figure. You have to very carefully look into her face to figure out that she has a malar rash on either side, sparing the nasolabial fold, which clearly suggests that possibly what she is having is lupus. This was a case of polyarthritis treated for more than 3 years without a deformities. Look at the face, gave me the clue that what she has is lupus. And this is a small child presenting with polyarthritis. If you look at her foreheads, you have 3 thickened skin areas, what otherwise called scleroderma or linear scleroderma, which gives a clue that this child, what she was having is linear scleroderma. These are the small petechial rash in an elderly, which was suggesting of henoch-Charlin purpura. She had both knee and ankle pains. Similarly, the ulcers, I think it's a spot diagnosis. If you look little carefully up over his hands has a typical rheumatoid arthritis deformities. It's a rheumatoid arthritis with a systemic vasculitis manifestations. And the hands, which have a gangrene at the tips, and the most carefully you should look at the way the skin folds are. She is around 45 to 50 years, and you don't see such an ironed out skin in the fingers. They are what we call as acrosclerosis, which clearly suggests a possibility of scleroderma. And this is the face of the same, these are the vasculitic ulcer. This is the face of the same patients, which clearly gives you a clue that what we are dealing with is scleroderma. Look at her pinched nose. And she is around 45-50. What we expect at 45-50 is not a nice ironed forehead. You normally see some wrinkles. The absence of wrinkles and the mouth will very clearly tells you that it is possibility of scleroderma. These are very subtle signs. These subtle signs tell you what you are dealing with or what you are working with is a disease which is more than just the joints pain, because these patients are likely to have systemic manifestation in the form of interstitial lung disease, digital gangrenes, which are all preventable if we intervene very early in the course of the disease. So these are thick sclerodactyly of another patients where you can see the nails are brittle and nails are slowly getting reduced. That also gives you a clue of a possibility of scleroderma and other systemic disease. I mean, this is something I think most of the other speakers have said. Watch and look carefully in the skin. You can see the small lesions over the edges of the fingers, which suggest psoriasis. Actually speaking, this is not the hand of the patient. This was the hand of the patient's attendant, the father. The son was the patient who came with a joints pain, which you were thinking of JCA. And father, when he was trying to put the paper across, we could see that there was a psoriatic skin rashes in him. So that gave us a clue. The child, what he had, the child never had any skin rash. The father had the skin rash suggestive of psoriasis, and the child was rheumatoid factor negative, anti-CCP negative, ANA negative, presenting with oligoarticular manifestations. There is the clue. Clue may come from the attender if you see their face and the hands carefully. So that's why I think Professor Jha started the whole process. His experience of years has said very clearly, it's not just the history of the patients. Spending some time in looking at the attenders may also help you to get a clue in the diagnosis. He was unbothered about that because he says, I'm a mechanic and I get these regularly, I get it. So it's not important. He was not ready to show his hands. So the clue comes sometime like this. So scleritis in the eyes is another clue. So red flag signs, as I said, presence of malar rash, discoid rash, photosensitivity, oral ulcer, serositis, renal involvement, neurological and hematological features. And so most common errors which happens is not all elevated uric acid is gout. Psoriasis is something where uric acid could be elevated. No patient with arthritis should miss urine routine examination. My sincere request for everyone is, even if a patient with arthritis, if more than 2 is come, ask him to spend 50 rupees and get his urine routine examination. Gives you a clue of 2 things: a early renal involvement in the form of RBCs and pus cells. If it is there, it's a time the patient needs a full evaluation of the renal system. And other thing is not sure of diagnosis. I make it very clear there is no room to start the DMRs. DMRs indication is to start only when you are very sure that what you are dealing is rheumatoid arthritis. and there is no shortcut to clinical examinations and the history in rheumatology practice. So you need to take in a detailed history of the patients, starting from the beginning to the end, and that really helps you to pick the red flag signs as well as in concluding the right diagnosis. Thank you very much for patience.
Thank you, Dr. Chandrasekhar. Now it's time to call Dr. Ravi SAUHTA, Gurugram.
Well, friends, Dr. Chandrasekhar has just talked about rheumatic fever as well. So after the discussion with initiation of rheumatic fever, here Professor Ravi SAUHTA is with us, and he is going to talk on reactive arthritis, which includes streptococcal reactive arthritis. Will also perhaps tell us about differentiating points from rheumatic fever. Thank you.
Thank you, Dr. Jha. So the learning objectives today are to identify the etiology of reactive arthritis, to review the presentation of the patients, and also to understand how to diagnose these patients and describe differential diagnosis and outline the treatment for management of these patients. I'm going to, the pathogenesis of reactive arthritis basically is a sterile arthritis after bacterial infection, whether it could be gastrointestinal or it could be genitourinary or respiratory infection. Generally, these are the pathogens which are described for the reactive arthritis. There could be bacterial and also fungal and viral. It was described way back in 1969, where they talked of aseptic or non-suppurative arthritis following microbial infection of the site other than the joint. So it is very, very clear that it is other than the joint, which is the cause for the microbial infection. Hemolytic streptococcal tonsillitis, upper respiratory tract infection, and also, as was talked about, a specific reactive arthritis in tuberculosis, which is known as Ponce's disease. And we are also going to be talking about intravesical installation of BCG in bladder cancer treatment. So reactive arthritis is restricted to HLA-B27 related arthritis associated with spondyloarthritis, and limited arthritis involving the organisms that cause urogenital, intestinal, or respiratory infections. And here is the part of which is spondyloarthritic component, which is which comes under the. So reactive arthritis basically is inflammation, which is infection other than the joint, and it is more due to the autoimmune inflammatory reaction. There could be seronegative, and after the infection, it could be gastrointestinal, it could be psoriatic or throat infection. And basically, there is an immune complex pathogenesis, which is which leads to stimulation of a CD4 helper T cells and a major histocompatibility complex leading to class 1 and class 2 pathogens activation, histocomplex activation, and also B cell activation leads to antibody formations. And then ultimately it leads to involvement of the joint. These patients most have HLA-B27, for which mechanism is unclear. So classical reactive arthritis, there are high antibody titers in a patients where there is a ASO titer which is high. Presence of a tonsillitis is very important. Tonsillar stimulation test which is done in these patients where massage of the tonsils is done. There is an increase in the CRP level, blood count, and also body temperature after 24 hours if seen in these patients. Chronic and recent manifestations of 62% of patients may have a positive ASO test in these patients, and a throat culture may be positive for streptococcus in about 50% of these patients. 40% of these patients are unable to demonstrate the history of streptococcal infection. Classical presentation, usually there could be IgG antibodies which are positive. There may be infective endocarditis. Synovial analysis, if done, more than 10,000 to 50,000 of blood cells, which can be seen mostly neutrophils, and the bacterial component and a DNA of the joint in these patients has been reported. Bacterial cultures are negative all the time, and there is no viable bacteria which can be seen from or isolated from the joints. As far as the clinical presentation is concerned, these are oligoarthritis, may present with acute onset 2 to 4 weeks after the antecedent infection, and asymptomatic oligoarthritis, conjunctivitis, uveitis, urethritis, and approximately half of the patients of reactive arthritis all will have resolved over a period of next six months. And approximately 1 year, most of the people become asymptomatic. Musculoskeletal signs are basically involvement of the lower limb monoarthritis or oligoarthritis over a period of 6 months, but usually transient arthritis, there is a recurrence of approximately 15 to 20% of these cases. Dactylitis is seen in almost 40% of the patients, and spondylitis seen in HLA-B27 positive patients. 2 or more of above features shows involvement of the arthritis, which establish the diagnosis of reactive arthritis. And these are the clinical pictures. You can see sacroiliitis in about 20% of the patients, and dactylitis, as I told, about 40% of these patients. There can be axial skeletal involvement. There can be pain, large joint effusions, sacroiliitis, and balanitis, enthesitis, which is very, very common in these patients, especially Haglund deformity, retrocalcaneal bursitis, plantar fasciitis, and quadriceps tendon or patellar tendon pains may be there. As described earlier, the extra-articular symptoms must be looked for. These are urethritis, conjunctivitis, and approximately in chlamydal infection, about 60% of these patients. There may be prostatitis, epididymitis, and also balanitis in these few of these patients. And keratoderma is seen in these patients. In women, there can be dysuria, vaginal discharge, and purulent cervicitis and vaginitis. Cardiac lesions can be seen. Approximately 10% of these patients may have a pericarditis. There may be associated aortic regurgitation because of involvement. As they say, the patients cannot see, pee, or climb a tree. Basically, there is the involvement of these 3 main features, which can be very, very suggestive of a reactive arthritis. There is a bimodal distribution. Few of these patients are very younger, in 18 to 14 years of 8 to 24 years of age, and a secondary is between middle age, 21 to 37 or 40 years of age. Acute asymptomatic non-migratory polyarthritis is seen, and recurrent tonsillitis, arthritis over age of 10 years. And obviously, there is no deformity, residual deformity, as Dr. Chandrasekhar was pointing out earlier to us. Axial skeleton, there is a sacroiliitis, which is very, very uncommon in these patients. Duration of arthritis in adult presents with these reactive arthritis before the diagnosis is made clear. When you look at the acute rheumatic fever, these are the patients where generally in acute rheumatic fever, there is a pharyngitis, tonsillar test is positive, large joint are involved, and it is a classical fleeting type of arthritis, whereas large joint and small joints are involved in reactive arthritis. And ASO titer, DNA may and no cardiac involvement, especially as described Jones criteria, which are classically positive in acute rheumatic fever as against the reactive arthritis. And mild rise in ESR CRP is seen, whereas in acute rheumatic fever, there is a very high levels of ESR and CRP. 1 year of prophylactic antibiotic may be recommended in these patients, whereas for acute rheumatic or rheumatic fever, the recommendation is up to the age of 21. These are various differential diagnoses where there can be acute rheumatic fever, GRA, Lyme's disease, leukemia, as Dr. Chandrasekhar was pointing out, can present with the joint pains, and a reactive arthritis of a bacterial origin, viral origin, or and these are various other gonococcal, gouty arthritis, disease, septic arthritis, rheumatoid, psoriatic, ankylosing, and so forth. All of them need to be differentiated, and this is how classically there is a comparison between the reactive arthritis, which is classic reactive arthritis, post-streptococcal reactive arthritis, and Ponce's disease, and BCG-induced arthritis, which is seen in patients of bladder cancer, where it is used as a treatment. It is instilled into the bladder. So you can see there is an extra-articular polyarticular disease in streptococcal reactive arthritis, where it is intracellular parasitism, where leading to a monoarticular disease in classic reactive arthritis. Ponce's disease, as was discussed a while earlier, is seen in active tubercular patients. There is no erosion, and extra-articular tubercular lesion may be found in these patients in the lung or skin or in lymph nodes. These are Sharma's criteria, which talks of non-erosive arthritis has to be confirmed. Extra-articular tubercular lesion needs to be confirmed if tuberculin test is positive and erythema nodosomes are observed in these patients. Underlying possibility of tubercular anti-tubercular drugs needs to be taken in consideration. There is in BCG-induced bladder cancer therapy for the bladder cancer, there is no single definitive diagnostic test, and there may be history of taking these over a period of a few years. These patients develop it after few years. 50% of the patients may have a polyarthritis, 40% oligoarthritis, and 10% may have a monoarthritis. Conjunctivitis arthritis is seen in 40% of patients. Adverse reactions, it is an adverse reaction possibly to leading to a reactive arthritis and needs to discontinue BCG therapy. As far as evaluation is concerned, these are the various tests which you have already learned them in, which needs to be done for these patients. X-ray imaging, plain radiographs, approximately 40 to 70% of patients will not have any findings related to this, and positive emission tomography may look at the tonsillar foci, which may be positive. Dactylitis is another important sign. Major and minor criteria for a diagnosis of reactive arthritis were brought out in 1999, which talks of oligo monoarthritis. There is enthesitis urethritis, 3 days to 6 weeks, and a minor criteria are triggering infection, persistent synovial fluid, and genitourinary symptoms, which could be seen in about, and the specific, and HLA-B27 may be positive, 69% of the patients and 93% specificity. As far as treatment is concerned, antibacterial drugs that targets the streptococci should be given. There is no evidence whether these patients no evidence that the antibiotic therapy for endocarditis is effective. So, and resolution of arthritis is seen within 3 to 6 weeks after the tonsillectomy. Few of these patients have serious symptoms. NSAID oral steroids make a mainstay of treatment. NSAID over a period of 2 weeks. Systemic steroids may be given in a dose of about 40 milligram daily in a moderate to severe cases. Intra-articular injection, if there is a monoarticular involvement, is very effective. Sulfasalazine, methotrexate, and other DMRDs may be given in a chronic arthritic states. And methotrexate has been used as a surrogate agent with NSAID steroids in patients with refractory symptoms, ankylosing spondylitis with peripheral joint lesions. TNF agents have also been described in these few patients where enthesitis and dactylitis is persistent and progressive. Methotrexate 3 to 4 months is adequate for a chronic arthritic conditions. Prognosis depends on the complete remission should be seen in reactive arthritis in 6 to 12 months after the treatment. About 20 to 50% of the cases, chronic patients may develop signs and symptoms of ankylosing spondylitis or inflammatory bowel disease, but few of the cases may have a cardiac symptoms. Complications are many, and obviously, in conclusion, understanding the similarity between the streptococcal reactive arthritis and septic arthritis or acute rheumatic fever. Differential diagnosis is basically post-streptococcal reactive arthritis, Ponson's disease, BCG-induced reactive arthritis, tonsillectomy, NACID, and various other management may be helpful. DMRD may be required in few of these cases. Thank you very much for your attention.
Thank you, Dr. Ravi. Now, once again, we call upon Dr. Renuka from Bangalore. We have just heard her with her, and she is coming with her second topic, which is role of autoantibodies in connective tissue disease. We are privileged to hear her second talk. Now, Dr. Renuka, please.
Shall I? Yeah, this is a topic. Can you hear me now? Yeah. I'll speak here. A topic which is very close to me, heart, and I hope I will be able to do the justice to this topic in the next 10 or 15 minutes. When you come to connective tissue disorders, the production of autoantibodies that react with various self-antigens. So it's the hallmark and distinctive feature of autoimmune systemic disease. So it is basically an autoimmune disorder where the antigens are working against cells, and it should be proven that they are pathogenic, that these are the antibodies which are not just present, but they are basically pathogenic autoantibodies. The connective tissue diseases which are associated, of course, are well known to everyone, is lupus, rheumatoid arthritis, scleroderma, dermatomyositis, Sjogren's syndrome, vasculitis, mixed connective tissue disorders. It was in 1948 that the LE cell was discovered by Higreaves et al., and which we used to earlier do, and now we have moved on to the anti-nuclear antibody. After that, there has been a worldwide lot of studies which have been taken up for autoimmune disorders, and later on there were antibodies developed for ANCA, and now we have so much work being done in other connective tissue disorders like mixed connective tissue disorders, myositis, as well as scleroderma. When I talk, the first test, when you think of an autoimmune disorder, whether it be a lupus or scleroderma, Sjogren's, the first test which we do is the anti-nuclear antibody. This anti-nuclear antibody is not a single antibody. It is basically a heterogeneous group of antibodies directed against the nuclear and cellular antigens. So if you see a cell which has a nucleus, a cytoplasm, a then in the nucleus, you are again having various nucleoli, and in the cytoplasm, again, you have Golgi, your lysosomes, entire cell structure. So antibodies can develop against any one of this. So when you do an ANA test, basically, this is not a single test, and it is basically a group of antibodies that you are doing a test against. So the presence of ANA has been a hallmark of systemic rheumatic diseases, of which SLE it is. And earlier it used to be like SLE, ANA means SLE, but it's not so. We know that it is present in so many other conditions. So, but this test should be done only if there is a strong clinical suspicion of an autoimmune disorder, because about 3% of the normal population can have an ANA which is positive, and unless you have a clinical indication, it should not be done. And you should never do a screening, just as a screening test. So it should be done only if there is a clinical suspicion of the connective tissue disorders like lupus, sclerosis, inflammatory myositis, Sjogren's syndrome. And also it becomes intrinsic to some of the diagnostic criteria for diagnosis like autoimmune hepatitis, mixed connective tissue disorders, drug-induced. And it sometimes is useful in cases like juvenile chronic arthritis and Raynaud's. But it might be possible, not just in normal population, in so many other places like rheumatoid arthritis, sclerosis, and infections, malignancies, you might have sometimes an ANA which is positive. That is why do an ANA test only when there is a clinical suspicion of any connective tissue disorder. How do you do this ANA test? It can be done both by an ELISA method as well as by immunofluorescence method. So currently IIF is still the gold standard method because it can detect any antibody binding to a structure inside the cell. So both unknown and known antibodies also we are able to detect. We are able to find newer antibodies also. And various patterns have been seen which have clinical characteristics of certain disease. It's not that ELISA methods are not useful. Where there is no availability, please do an ELISA test, but otherwise ideally prefer to go for an ANA by immunofluorescence method because here you are able to visualize the cell directly. Here we use an IF microscope and this is a typical homogeneous pattern. So in 2002, guidelines were given very clearly for use of autoantibodies in diagnosis of monitoring of autoimmune. It was realized that they're not very useful in monitoring, but you should do it only if there's a clinical suspicion, do preferably on the HEP2 cells. Now you have variants like HEP2000 cells. It was considered as negative if it is less than 140 and positive beyond that, and it was not to be used for monitoring. So there were some more criteria also that you do a dsDNA or further workup only if an ANA is positive. This is just a summary of what I'm telling, but otherwise it's a used thing. But now in 2014, the international consensus on ANA patterns, they started an initiative in 2014 as a workshop wherein they started this in Sao Paulo, where you look at the patterns and you give them the ANA pattern. So here we are, which very clearly says that ANA has to be done by indirect immunofluorescence, and it also was basically devoted to establishing the consensus on the nomenclature, because there is a lot of variation in the way the reporting is done for ANA. So some will give it as positive, negative, then what is the titer? Some do it in 1 in 40, 1 in 160, 1 in 100. So that variation was there. So it was also recommended that you mention what is the type of assay and also preferably do an endpoint titration. Now, endpoint titration may not be possible sometimes in our Indian scenario, but at least we should be able to do a screening, and we do something called as a intensity grading. And then titration is considered clinically very significant because a very high titer is associated with positive likelihood. Even the Dutch actually said that you could do reporting in a intensity grade instead of a titer. So based on this, the ANA positivity, here you can see there was an international consensus. Whether the antibodies are present in the nuclei, cytoplasm, in the mitotic figures, you had a various patterns. So currently now there are about 30 patterns, 29 patterns which are there. And some of them have become a lot of interest currently, the dense fine speckled and the SCL topoisomerase pattern and all. But I will not get into the details, but you have various patterns. And these patterns are important because it will have a clear antigen association and clinical correlation. So you mentioned what is the type, mention the primary pattern, and mention the antibodies association. If you look at this, a homogeneous pattern could be associated with dsDNA, meaning SLE. A speckled pattern is associated with multiple antibodies. So it could be positive in Sjogren's, in mixed connective, in lupus, as well as, but here based again, whether it is fine speckled, large core speckled, dense fine speckled, whether on the competence of the, you have different levels for reporting the ANA. I'll not get into the details of this. So, but what is important, I would like to say is do an ANA, preferably by an IF method, and also give the method, give the titer, and give the intensity. Please ask for this with your lab whenever you all are getting the reports. How is the test being done? Because these things do make a difference. Or now, of course, there have been a lot of newer techniques. Once an ANA is positive, then you want to work up further. What does this mean? If a test is ANA positive, patient has clinical symptoms, you want to do a further workup. At that time, you can ask for specific autoimmune condition tests. So where it will be more specific antibodies you will do. And there are, you can sometimes have, because problem with autoantibodies is that one condition can have multiple antibodies, and sometimes the same antibody can be positive in so many conditions. So that is the reason you have different tests which have been coming, line immunoassays, microarrays, flow cytometry. So ELISA for that matter, automated. Newer techniques have come which definitely help us in the speed, in reducing cost and tests. So what we preferably do is do an ANA by an immunofluorescence and then follow up with a blot assay for reducing the cost. And wherever only required, you do an ELISA assay. So there are various blot methods where the antigens are actually coated on there, and then you follow it like an enzymatic principle and you look for the antibodies. Earlier we used to do some 10, then it went to 17 antibodies. Now we have 24 antibodies. So there are various antibodies which are there. And what is important, or I would like to say, is that depending on your clinical condition, you can ask which is the kind of a test that you are requiring. And when there is a confusion, you can go for a ANA profile or a blot assay where you will come to know which are the antibodies and come to a conclusion. Let us just look at some of the conditions, say SLE. So it is a multi-system disorder because of the presence of various antibodies. It has ANA. If you look at the criteria, 4 of the 11 criteria are lab-based criteria. One is ANA, presence of dsDNA either by IF or by ELISA, anti-SM and positive APLA. So there are so many antibodies which are present in lupus. Of about 200 autoantibodies have been identified. Some of them are disease-specific like SM, dsDNA, C22. Some of them have predictive. When a patient has an SM, probably patient has renal problems also associated. Centromere could be because of pulmonary hypertension. Cardiolipin antibodies could be because of the patient has antiphospholipids. Then Rho52 could sometimes indicate the patient has neonatal lupus. And some of them are pathogenic. So they not only have a role in a presence of antibody, but they actually have a role in the pathogenesis of the conditions like dsDNA, nucleosome, and SSA are dsDNA and nucleosome and SM actually are associated with nephritis, and SSA60, that is Rho60, is usually associated with neonatal lupus. This is actually sometimes helpful. You can even predict earlier, and you can start the patient when the patient has recurrent abortions. Now, looking at idiopathic inflammatory myositis, you have again various antibodies. Here, basically, you having inflammation of the sciatic muscles along with proximal vessel weakness, and you have classified them based on the clinical picture as necrotizing pure and overlap myositis. And these autoantibodies are present in about 50 to 80% of patients with inflammatory myositis. There are myositis specific antibodies. A lot of work has happened in the last few years, particularly in myositis. Earlier we used to do only about 10 antigens. Now we have come to about 17 antigens that we are doing. Why is it important? Why is it important that once you know that it is myositis? Is because they have a clinical significance. You know that these patients, how they are going to behave. Like for instance, anti-synthetase antibodies like JO1, PL7, PL12, they are usually associated with interstitial lung diseases, whereas anti-Me2, anti-MDA5, and the anti-SE antibodies usually associated with, correlate with the cutaneous form of dermatomyositis. NXP2 TIF1 antibodies indicate the patient is going to have a very severe disease. And particularly when it comes to TIF1, it indicates that probably the patient also has a risk of malignancy. So that is why once you have done a diagnosis of a particular condition, these specific antibodies also indicate how severe the course of disease is going to be, and how do you need to treat the treatment. One of the things which is coming up now is HMG co-reductase antibodies, which is associated with the statin use. Everybody has been giving statins in the last couple of years, and now, last decade, I would say, and now this is again causing myositis problems. So HMG co-reductase to some extent helps in differentiating whether it is statin-induced myopathy. Similarly, there are systemic sclerosis. You have systemic sclerosis specific antibodies as well as the non-specific antibodies like topoisomerase, centromere, and things. To cut it short, you might get various patterns on the immunofluorescence. For instance, a centromere pattern usually very well correlates with the blot also. Even when you do a blot, you will get anticentromere, nucleolar pattern or a speckle, nuclearly associated with TO, PMSCL antibodies as well as U3RNP. What I would like to say over here is that these are the disease-specific antibodies. And anti-centromere antibody usually indicates a limited form, whereas a topoisomerase or a TH2 indicates that the patient has a more aggressive course of disease. So it actually helps in as a predictor of an organ involvement. Antiphospholipid again is a condition where the patient will have usually a recurrent pregnancy loss or a thrombotic tendency, where you have to have at least clinical criteria of vascular thrombosis, recurrent pregnancy loss, and some lab criteria like antiphospholipid antibodies, which include lupus anticoagulant, cardiolipins, beta-2 glycoprotein. One of these should be present for diagnosing an antiphospholipid. The good part of is these antibodies can actually, once you know that the patient in a recurrent or a bad obstetric history has a APLA workup, you can actually treat the patient much earlier. You can start them in earlier stage, so it's preventable. And when it comes to vasculitis, ANCA is the antibody which has been done, which is the anti-neutrophil cytoplasmic antibody. Based on the pattern in immunofluorescence, it is called as C-ANCA or P-ANCA. We get requests saying, please do C-ANCA test, please do P-ANCA test. But basically, it is based on the pattern. When you do an immunofluorescence, we call it as C-ANCA or P-ANCA. Again, you have atypical. It is not a separate test. Rather, it is because it is associated with the antigens. Like C-ANCA pattern is usually associated with PR3 antigen, which is present in the neutrophils, whereas P-ANCA is usually with MPO. That is the reason we can make out what are the specific antibodies. And now clinically also they are giving a separate group for granulomatous polyangiitis called as PR3 associated antibodies, PR3 associated vasculitis. So what I would like to say is there is a separate condition itself called as ANCA associated. Oh. Should I wind up or? Okay. So there is a separate ANCA associated vasculitis, which is in which you can get and the good part here is PR3 antigen is the only one which along with DSGN, they are two antigens independently, I mean, which can be used in the follow-up of these conditions. These antibodies can appear years before the disease. So they not only help in diagnosis, they form a part of the classification criteria. They're helpful in monitoring and to predict the outcome of disease and prognosis. Thank you. I don't know if I was too fast for that.
No, you have made this one test and autoantibody for a connective tissue disorder made so simple, and it is so deep that it's really a torch to this problem. Thank you. Thank you very much. Any questions from the audience to Dr. Renuka, Dr. Ravi, and Dr. Chandrasekhar?
Thank you so much, sir. So may I call upon Dr. Chandrasekhar, please? And I'll request Dr. Manoj Chaudhary, sir, our past president, to give a memento to the president-elect Indian Rheumatological Association. Please join all the chairpersons, sir. And I'll call upon our president-elect, Dr. Anil Kumar, sir. Please come and give a floral bouquet to all the chairpersons. Thank you, sir. Thank you for a wonderful session. So over to Dr. Anand for the fourth session.
So very quickly, we would like to start with session 4, and I would like to call Dr. Bharat Singh sir, Dr. Ashok Kumar Sinha sir, Dr. Rakesh Chaudhary sir, and Dr. Om Prakash sir. Kindly come on the dais and let's start with the session 4, sir.
Good afternoon, everybody. We will start this session. This would be one of the most interesting session for all you orthopedic surgeons because it is really which we are interested in using DMRDs and the steroids. बाकी जो टेस्ट होता है वो होता रहेगा, but these are really which we are important, really important to us, and we will go for it. So very interesting, and it also the just a pre-lunch session. So just remember, after this we are going to have a lunch also. So not without much ado, we'll start with the first lecture, and none other than Dr. Chandrasekhar would be giving us choosing DMRDs in RA, and exactly what we want. Thank you very much.
Good afternoon. I think I will spend next 15 minutes about the crux of how exactly we choose disease-modifying anti-rheumatic drug. It starts with a presumption from my previous talk. We have made a right diagnosis that the patient is suffering from rheumatoid arthritis, and then we roll in to start choosing the disease-modifying anti-rheumatic drugs. What are the fundamental principles on which we try to choose or pick and choose the disease-modifying anti-rheumatic drugs? And why should we use these disease-modifying anti-rheumatic drugs? It's very clear now. The moment you make a diagnosis of rheumatoid arthritis, since it's a chronic, progressive, destructive disease, you need to put the disease-modifying anti-rheumatic drug. Its basic reason to put it is to prevent the disability as well as to reduce the extra-articular manifestations, which in turn overall improves the quality of life. Of course, with the introduction of disease-modifying anti-rheumatic drug, we have increased the life expectancy of rheumatoid arthritis, but from last 5 years, we have stagnated. We couldn't go beyond that for a variety of reasons, comorbidity, etc., which is not the part of the talk today. Also because of the complication related to a wrong choice of DMRs, also have added to the reduction in the total overall life expectancy. So one of the major concerns when we think and start prescribing about disease-modifying anti-rheumatic drug is its low margin of safety. What we talk about as therapeutic to the toxicity ratio in majority of the drug is very small. For example, paracetamol has a very high therapeutic to toxicity ratio because toxicity occurs after 6 grams. You normally use not above 3 grams. Whereas if you come to the methotrexate or if you come to the leflunomide, therapeutic to toxicity ratio is very high. So that puts us into a part that we need to think about to choosing these drugs. There are varieties of factors we work about. One of the major point on which we start thinking about which drug to choose is what about rheumatoid? Rheumatoid is a heterogeneous disease. I think Dr. RENUKA made it very clear that we have several autoantibodies in it. And we have rheumatoid factor, anti-CCP positive. Again, in rheumatoid factor, if it is high titer, it has an aggressive disease. If it is low titer, disease should be low. Anti-CCP positive, it could be erosive. Anti-CARP positive, it may have interstitial lung disease and other features. So disease is not a uniform disease like what we are dealing with. It's a heterogeneous disease. And it can range from a very mild disease, as I said, very unusual, 5-10% of patients, even though it's 2 years disease, unmanaged, not treated, may not develop deformities, but majority of them may develop deformities. But I have seen a additional comorbidities. So he has a problem and also another additional problem with reference along with rheumatoid arthritis. So why this topic has come is we have a lot to choose. Menu is big. It's not as it was when I started practicing 25 years. We had methotrexate, sulfasalazine, and leflunomide just walked in at that point of time. We had 3 drugs to choose with and steroids to add with and NSAIDs to work with. Now, there are more than 12 disease-modifying anti-rheumatic drug in your menu. Menu is big. And also we have few more additional immunosuppressive which can pick, which are not otherwise designated as disease-modifying anti-rheumatic drug like cyclophosphamide, mycophenolate, and various other drugs which are not otherwise categorized as disease-modifying anti-rheumatic drug. We can choose those drugs. Then we have more than 10 biologics which are available in Indian market. Leave alone if you work with the across world market, we have more than 22 of different biologics which are available with 5 different strata being used. You have anti-TNF, you have anti-IL-6, you have anti-B-cell, T-cell interventions, and we have multiple facets of the immune responses which we can block and have a different menu with reference to biologics. And there are 2 more molecules, what we call target-specific disease-modifying anti-rheumatic drugs, which called tofacitinib, baricitinib, and few more to be added in next 4 years about these group of drugs. So I have a menu to choose with. So the trouble starts. So if you go to a restaurant with a large menu of a big spread of a buffet, then you have a trouble to choose them. You have 5-6 menus, you have no problems, which we had 20 years back. We never had issues. 3 more drugs to use, nothing works, then tell them that nothing more works. So then the next issue is we have changed the target of treatment. If you look back in 90s and 2000, we were very happy if the patient pain comes down, swelling comes down, he's able to walk back to your clinic. I call that as a palliative care of what we were doing at rheumatoid arthritis. And from there, we have slowly moved to work for a low active disease, low disease activity, or if possible, a complete remission where disease activity score is maintained less than 2.6. We changed our target. From there, now with the menu available, we have changed the target further. Can I go for a drug-free remission where I can discontinue these drugs? So change in target also has made us to think about, can we choose a right drug and a right point of time? Because variations in the response is another issue which we are worried. The question that comes to everybody's mind, especially those who have read the rheumatology, that is remission a possibility in autoimmune rheumatic disease? The answer to that question is yes. Because earlier days, we used to call it as we should treat it like a diabetes mellitus, we should treat it like a hypertension. Once you have a disease, you have to continue to have the disease. There is a very major difference between the diabetes as well as the autoimmune diseases. Autoimmune disease occurs because of commission, not because of omission. In the pathology of the rheumatoid arthritis or any autoimmune disease, it is the committed error of the immune system which is responsible for the disease. When it comes to diabetes, it is the dysregulation or a reduction in insulin capability of functionality, a reduction in immune receptors, insulin receptor is responsible, and the defect is permanent and cannot be altered or augmented other than obesity related, which is a new concept which is coming. When it comes to autoimmune rheumatic disease, we always call it as a disease of commission, not because of omission. If it is a commission, you can always modify it, and you are dealing with a system called immune system, which is dynamic system, and the status keeps changing. Because whatever happens in a autoimmune rheumatic diseases, any of the autoimmune disease, is it uses the normal natural immune response, but in a skewed way of hurting self. So that being the case, what I can do or modify or alter can go for a permanent switch back. So if that is possible, remission is achievable. So that being the case, now we are theoretically clear, I can achieve a remission in these autoimmune rheumatic disease. Hence, the target was slowly moved into a phase of remission. So what are the critical factors that can influence with reference to drug is, first is the availability of the drug, whether the drug is available in the market or not. Next is the cost of the drug, which is of course one of the points in Indian practice. We need to look into both availability of the drug and the cost, whether the patient can work with it. Safety and other factors related to drug, how safe this drug is with reference to the given patients. The patient whom I am addressing, how safe it is. For example, patient has a pre-existing liver disease. Methotrexate, leflunomide are not the right choice. Patient who have a renal impairment, the drugs which are excreted by the kidneys are not the right drug of choice. So if patient has a sulfur allergy, as simple as that, sulfur drugs like sulfasalazine is not the drug of choice. So safety and other factors related to drugs. And the last, but very critical, is the guidelines and approval with reference to the drugs, because this is both of a medical legal consequence when you prescribe that. Is it an approved drug? If it is not an approved drug, how you are justified, how much you are justified to use these drugs in a given scenarios. So both guidelines and approval of drugs, I try to touch on these areas. So when it comes to the disease factor, the factor that we have is how severe is the disease in question. If the disease is mild, early, if it is mild and early, you can work with low profile drugs. If it is aggressive, you have to go for combination or biologics. Presence or absence of extra-articular feature, whether patient has ILD, whether patient has vasculitis, whether patient has neuropathy, carpal tunnel syndrome or anything else if he has, then the treatment choice and line will be different. If there is ILD, we would like to prefer the patient to go to cyclophosphamide, mycophenolate mafetil, and those group of drugs. Whereas if there is no ILD, it's isolatedly only arthritis and arthritis related, we still prefer to work with methotrexate, leflunomide, and sulfasalazine combinations. These are the combination we see when there is no other extra-articular manifestations. Presence of prognostic factor, as we said, high titers of rheumatoid factor, high titers of anti-CCP, even if the patient at his presentation, especially in the early course of the disease, he has a very minimum disease, very few joints are involved. And the DAS score, what we calculate, is still around 3.5. The possibility of this patient going to an aggressive disease is very high. If these prognostic factors are present, consider even if the patient in the first early 6 months presenting with a milder disease, he is more likely to have an aggressive disease. Based on these prognostic factor, you can classify, though at presentation is not very aggressive, likely to go for aggressive. Erosive or non-erosive disease, especially the patient walks in after 2 or 3 years, take his X-ray of hands or the joints which are predominantly involved, you don't see erosions at all. Even the juxta-articular osteoporosis findings are not present. Whatever the pain the patient is complaining, even if the tender joints are multiple, if it is non-erosive, consider it technically it is not an aggressive disease, because the deformities or damages likely to happen in these group of diseases, patient with a less erosion down 2 or 3 years is less likely. You need not be very aggressive in these type of patients. Early or late presentation. Early presentations, patient can and do very well with monotherapies or a very combination of 1 or 2 drugs. Late presentations, usually we prefer them to either use biologics or preferably combination disease modifying anti-rheumatic drugs. That's why it is preferable to pick these patients in early, because responding to monotherapy or a simple combination is much better in early rather than late presentation. Another thing you can always see is previous failures of DMARDs. If patient has been exposed to methotrexate, has not responded to methotrexate, there is no point in reusing the same. But make yourself sure the previous physician or a previous doctor has used adequate dose. If the previous physician or a doctor has used only 10 milligrams per week and patient is not responding, he is not been adequately exposed to methotrexate. On the contra, patient has been used 25 milligrams methotrexate, not doing adequate response down 3 months, he is probably have a primary resistance to methotrexate. Or previous exposure to methotrexate, leflunomide, hydroxychloroquine combination has been given, not responding. Probably he's one of the refractory case of rheumatoid arthritis, where you start thinking about using the biologics in the very beginning. So previous exposure to DMARDs or the success or failure of the DMARDs, you need to say. For instance, there is another case scenario where patient has been taken methotrexate, leflunomide, and sulfasalazine, doing very good, 6 months, stops everything, comes back after 6 months with all the flares. It's very clear he does respond to the same drug, reintroduce the same drug with the same optimum dose what the previous physician used, convince them he has used right. What the error you did was you left the drug halfway. Tell them to continue the drug at least for 1 to 2 years before the disease settles in, and then start withdrawing the drugs. So other patients factor which you need to consider while choosing are the gender. The male or a female, you need to take a call. And the age of the patient, whether patient is in the reproductive age group or has completed the family. and whether the patient or the couple is planning for pregnancy or not. So look at the way how you have to choose. For instance, for men, sulfasalazine should be carefully introduced if the couple is planning for a pregnancy, because sulfasalazine can interfere in spermatogenesis. There could be a problem in sperms. Whereas if it comes to women, sulfasalazine is a preferred drug because sulfasalazine is permitted for her to go for a pregnancy and even continue through the pregnancy. On the contrary, methotrexate can be used in the men because methotrexate doesn't have much interference in the spermatogenesis, whereas in women, it is absolutely contraindicated. Leflunomide is not a drug to choose in a woman or a partners, especially women, if they are planning for a pregnancy, because you need to stop the medicine leflunomide at least for a year or two before they plan for pregnancy. If they have a plan to have a child within couple of months or couple of years, please avoid leflunomide, so that the teratogenicity is one of the major concerns when it comes to leflunomide. That's how the age of the patient, gender of the patient, as well as the pregnancy and the possibility of them having children status is going to be important. Most other two things are compliance of the patients. Never try to pick and choose the drug which has a very therapeutic toxicity margin very low in a patients who are less compliant, who don't come back to you with a blood test, who don't come back to you with liver function test, who doesn't see you back once he feels good. Avoid very low therapeutic toxicity drugs like the target specific DMRs like the tofacitinib, or the drugs like etanercept, etc. Even if he's affordable or rich, if he's non-compliant, try to avoid these group of drugs because chance of them landing up in a adverse event is high. Because in India, you can get these drugs even without a prescription. He just shows the same old prescriptions, gets back the drug. So that being the case, see his compliance, pick and choose the DMRs. DMRs with low therapeutic to toxicity ratio should be avoided in the less compliant patients. Presence or absence of comorbidity. With the permission of Chair, I'll take 5 more minutes. I compensate in my next lecture. The presence of a comorbidity is another important point which we need to consider. For example, if patient has hypertension uncontrolled, leflunomide and cyclosporin are not the drug of choice, because one of the expected complication of leflunomide is hypertension and uncontrolled hypertension. If possible, you preferably avoid. Of course, you can use it with the help of physician, bring down the blood pressure. Simultaneously, you can use leflunomide, but leflunomide can cause a little dysregulation in the hypertension medications. So be a little careful when those comorbidities are present. Presence of IHT, presence of congestive cardiac failure, or any other cardiac events, better and preferably one should avoid tofacitinib, because one of the major issue or a concern with tofacitinib is MACE. The adverse cardiac event is one of the major concern. Patients with the ischemic heart diseases, if possible and preferably, one need to avoid. So comorbidity is another factor which determines what are the best drug to choose. So we have the drug factor, we have the disease factor, we have the patient's factor, and we have the other comorbidity factor, and as plus the availability of the drugs. Based on that, we make a choice of the disease modifying anti-rheumatic drugs. So these are the possible comorbidities one can expect. So now, how should I now use the EULAR recommendations? Now, how does the recommendation comes? You need to remember in the recommendation, and in the last page it is written, it is a recommendation and not a guidelines. And it is very clear and disowns you after you make you to read through that. So they leave it to your wisdom to take a call, which is the drug which you would like to choose. And hence it is a guidelines. It is not necessary. You need to adhere and go on these pathways. But of course, these guidelines are required whenever we go for a medical legal. Why did you choose this drug? Why not that choose drug? But if you deviate from the guidelines, we should have enough wisdom or enough documentation to say why I didn't give this drug as per the path prescribed and why did I change to other pathways. So now, we made a diagnosis of rheumatoid arthritis. Initial, if has no contraindication for methotrexate, advice is to use methotrexate. If there is a contraindication to methotrexate, use leflunomide or sulfonamide. What I suggest here is, what the new things which we look at is, if there are bad prognosis, if patient has an early, aggressive disease, if patient have associated comorbidity, you have every right to deviate from this. So if patient has a very aggressive disease, preferably go to the level 2, where you can start using the combination DMRs. You can use methotrexate, leflunomide, and sulfasalazine combination, methotrexate, leflunomide, and hydroxychloroquine combinations, or any of these combinations can be initiated in the very beginning. What in my clinical practice normally we do is, we start in an aggressive disease, a 3-drug combinations, and in a little milder cases, we use 2-drug combination. Very mild cases, which we don't really get, because being at tertiary referral centers, usually the patient who are aggressive, refractory, not doing good with the simple drugs are the one who reaches our peripheral center. So very rarely, because of the patient's reference, we come with a very mild disease. I use a single drug like monotherapy of methotrexate or hydroxychloroquine. Once you need to keep a watch on their disease activity for the first 3 months. If they don't do good in the first 3 months, you need to move to the phase 2. 3 months is a time where you need to revise whether patient is doing good or not. When he comes back within 6 weeks, if he doesn't show any changes despite escalating on the optimum dose, you need to relook at the combination of DMRs which you are using. So if not responding, they recommend to go for biologic DMR and JAK inhibitor. Currently, with the available generics, we are able to afford to the JAK inhibitors, but otherwise, this was a very difficult step in the Indian scene. So biologic DMR is out of questions. If they are refractory or fails to the combination of disease-modifying anti-rheumatic drug in the 3 months, then you go for JAK inhibitor. JAK inhibitor failure, then you can work for biologic DMRs. What I do in our practice, because of the financial constraint, we use different combinations. We use igrutimod being added and replaced. We try to use cyclosporin or tacrolimus in that place, or we try to use 4-drug combinations sometimes, which also work. But when you are working on 4 drugs, you should be very clear about the adverse events of all these drugs and need to be followed at a more frequent interval every 4th week or 6th week with the liver function test, creatinine and urine routine. And that should help you in figuring out the adverse events. So if improved, 3 months, achieve a target of remission, maintain it for 6 months, then you can go for gradual withdrawal of the DMRs, especially biologic DMR and TS-DMR, and maintain them on methotrexate. If fail, no response, then you can use multiple combinations and you can use varieties of other things, and also can go for newer experimental combinations. That's where you can. So there is a possible of switching the DMRs from one to another, and are switching from the combination of DMRs from one to another. So this is how we use the guidelines in managing and choosing the disease-modifying anti-rheumatic drugs. So in a nutshell, you have a patient with early RA treatment with comorbidities. So you can use DMR monotherapies. And if there is moderate to high disease activity, you can try with disease-modifying combinations. And in the combinations, you can use methotrexate, hydroxychloroquine, methotrexate, sulfasalazine, or a triple drug combination like methotrexate, sulfasalazine, and hydroxychloroquine, or methotrexate, leflunomide, and hydroxychloroquine. Again, choice of this drug, as I said about the age, need for children's, and all those factors should be seriously considered when you are picking and choosing these drugs. So the basic crux and the basic thing what you need is, we follow the fundamental principle, the safety first, especially when the patient has comorbidities. At that time, we shift our gear from what we were otherwise thinking of looking for a remission to a total tight control. So from total tight control, we move to a pain relief. For example, elderly, 65 plus, has a cardiac disease, also has a diabetes, borderline renal dysfunction. In this patient, I would love not to go aggressive in combining methotrexate, leflunomide, and others. And even we are little worried to use biologics and TS-DMRs, because here using these drugs are going to expose him for a higher risk of infections, higher risk of adverse events. So that being the case, there we move back our target from a remission back to a palliative care. We would love his pain to be brought under as good control as possible. This is the place where sometimes we use a small dose of steroids. Small dose of steroids like 4 milligram of methylprednisolone or 5 to 7.5 milligram of methylprednisolone. Asking physician to tighten the control of diabetes or hypertension can help, because influence of 7.5 of steroids is much more safer when it comes to renal dysfunctions and also has less impact on some of the cardiovascular things. So you need to pick and choose based on that. So you can use low dose glucosteroids, you can use DMR combinations, you can use triple DMRs, and or sometimes you can use a short-term glucocorticoids. So simple algorithm, poor prognosis, use combinations, and not helpful, then you can use otherwise. Further, you can use multiple combinations of DMRs. So decision-making is always preferable, a shared decision-making, discuss with the patients, pros and cons of the drugs, and also talk about the compliance, ask him to be taking these medicines at least for a longer time, weigh the risk to benefit ratio, individual case by case basis, cost, affordability, and other issues also to be discussed. Sustainability is something which we have to make ourselves reassured, and based on that, you can think about how to handle that. So, as I said, it is effective, but no long-term response. Not all will respond to the same disease-modifying anti-rheumatic drug. So still we are in the because sometimes I think that this patient may respond to methotrexate, leflunomide, and hydroxychloroquine to the despair of me as well as the patient. 6 months, he still comes back with the pain, swelling, etc. So we are trying to work on different ways to personalize the medicine and precise the medicines. Precision medicine and the personalized medicine are two different things. All of us are used to go for a personalizing medicines. What I spoke about is a personalizing the medicine, comorbidity, age, gender, etc., where I pick and choose. And the precision medicine is something which we are trying to work. If I can come to know that the patient who was sitting right in front of me because of ABCD biomarker respond very well to methotrexate. Yes, there I am. I am precisely picking up the right DMRs. There are work which is going on across the globe, but immune system is little complex. And being the case, to get the right biomarkers to figure out who respond to methotrexate, who respond to leflunomide, who respond to biologic is still a challenge. My center is working from last 5 to 8 years in getting these personalized and precision medicines. We have come to few algorithms which we are going to make it public so that it can be used. But as a part of the Indian thing, and my belief that is no biomarkers is too expensive, is useful, or can be applied into the general mass. We are trying to work within the available clinical simplified biomarkers wherein we can pick and choose and precise the medicines. Hopefully that should help in customizing the DMRs. Maybe in a few years we should have those kind of things. Thank you very much for patience.
Thank you, Dr. Chandrasekhar. It was a very good elaborative talk. But you are an expert here, and we are orthopedic surgeons, one. And this is an association meeting. Almost 70% of our audience is junior residents. So I give you a typical scenario, because if and buts and so, and that is quite common for us. Typical scenario, 40 years old lady with 3 months old, polyarthralgia involving small joint, completed a family, ESR raised. What would be writing in your prescription? And this is what my PGs want to know. What would you be writing in your prescription?
Severe aggressive disease. I would love to choose a triple drug combination.
Good.
Of methotrexate, leflunomide, and hydroxychloroquine.
Yeah, doses.
We start with 10 milligrams to 15 milligrams based on the patient's liver function test and screen of HbS, etc., and her previous precedence about the tolerance of the drug. If she is able to tolerate the drug, every 4th week we cross-check her inflammatory parameters, CRP, ESR, disease activities, as well as the liver function test and the counts. If it is stable, not adequately responding, only marginally responded, I go on scaling up leflunomide up to 20 milligrams, that is from 10 to 20, and methotrexate starting from 10, we scale up to 25 milligram. Or if she does well at 20 milligram, I halt there. Otherwise, I go up to 25 milligram. Scenario 3, 6 months down, she is still not responding. What will I do next? So if that's the case at that point of time, if she is affordable and can go ahead or she's covered by the third party payers, I would like to get her into TSDMRs, target specific DMRs, or biologics based on whatever the scheme. But I would prefer, if finance is not an issue to take a decision, we would like to go for biologic DMR first, preferably rituximab, especially if her rheumatoid factor and anti-CCP are high and ESR levels are very high. If rheumatoid factor and CRP are low and ESR, CRP are not really very high, still continue to persist of the pain, I would send it to my assessor of the social counselors and a reassessment whether she is having fibromyalgia or any other reasons for her persisting pain, which is deviating. If inflammatory parameters are persistingly high, which clearly suggests this is not under control, I would like to go for biologic DMRs. Not helping, then I switch to TSDMRs.
Doctor, one question. Your waiting period is 6 months, as you were saying.
3 months.
3 months. Our patient is to come after 2 weeks, 3 weeks only. Doctor, I'm not getting relief. What to do now?
No, actually, that's where I said my last but one slide. I said it's a shared decision making and counseling. You need to make patients very clear that actually, see, normally we tell the patients very clear. I put the patient on NSAIDs and we put the NSAIDs and tell them to take it for 4 to 6 weeks. And the NSAID dose should be optimized for her pain control. And you should tell her that the disease modifying anti-rheumatic drug or slow acting drug, it takes its own sweet time. So if you want a rapid control, so if the patients who are less likely to get convinced, you can always use a bridge therapy of steroids. But remember, you need to look at the compliance of the patients. If patient is someone who just escapes with the prescription of steroid, doesn't come back to you, still you get a Cushingoid feature, preferably use injectable depot steroids where it is under your control. So otherwise, best preferable is to use a small short course of steroid so that they are compliant with it and you bridge the time by the time your DMR takes.
That is the thing we are doing also. Thank you. Thank you.
Sir, Currently, it has been approved for methotrexate and hydroxychloroquine failure. Use methotrexate and hydroxychloroquine or leflunomide in combination. If it fails, then you can replace with ibrutinib. I mean, that's a recommendation. But in the Southeast Asian countries, China and Japan, where it is very frequently used, it's almost used as a first prescribed DMRs.
Thank you.
In India, prescription is post methotrexate failure.
Sir, thank you. No counter question. Sir.
Sir, what will you recommend? Methotrexate in high doses or a combination?
We would like in a patient who has a mild to moderate disease, only use methotrexate to the full dose. Go up to the full dose.
Thank you, sir. Thank you. I will call Dr. Chinmay Das. Dr. Chinmay Das is here? Yeah. Sir, he will be talking about when not to use DMRD. Just counter to you. Dr. Das. Yeah.
So after a very elaborate and fantastic lecture by Professor Chandrashekha, so it's difficult, but I think you have already chosen the drug. So I will be speaking on when not to use your drugs. So good afternoon, everyone. Permission of the chair. So what is the therapeutic toolbox drugs we are having? So there are conventional DMARDs, methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, gold azathioprine, then glucocorticoids, cyclosporine, chlorambucil, cyclophosphamide, then minocycline. Then we have got biologic agents, TNF alpha inhibitors like your etanercept, infliximab, adalimumab, golizumab, then certolizumab, rituximab,
Sir has already given good indication to use rituximab. Then we have interleukin-1 inhibitors like anakinra, and we have abatas, tofacitinib, baricitinib, and upadacitinib. This is not available in India, freely available upadacitinib, but tofacitinib is good because it's given in oral dose. Very low doses can be given, and convenient in using, means OD doses can also be given with tofacitinib. So these are some mechanism of action, how these drugs act, starting from antifolate methotrexate to your JAK kinase inhibitors. So coming to methotrexate, it has got a formula of C20H22, nitrogen 8, and oxygen 5. So it should not be given when the patient is hypersensitive to methotrexate, when it's a pregnant breastfeeding woman, in peptic ulcers, in active infections. Most of the DMARDs cannot be given any pre-existing blood dyscrasias or bone marrow hypoplasias, leukopenia, thrombocytopenia, and significant anemia, and chronic liver disease, because this methotrexate goes on for your interstitial fibrosis of the liver. So in chronic liver diseases, liver cirrhosis, alcoholic hepatitis, and chronic alcoholism, you have to stop methotrexate. Or in HIV, AIDS, blood dyscrasias, renal dysfunction, because methotrexate is excreted by the renal route, as well as radiotherapy. And methotrexate also has got some interactions because it's a highly plasma protein bound, and it has got effect with renal clearance of methotrexate. If any drug has got, then NSH, salicylates, penicillin, warfarin, valproate, aminoglycosides. So these should be avoided with methotrexate. Coming to HCQ, it is very safe drug, usually very safe in pregnancy, then contraindicated if there is any visual or retinal damages, retinal changes. And that's why we advise the patients that for the first 3 months, every month, eye checkup should be done, and after 3 months, every 3 monthly eye checkup should be done. Then if there is any impaired liver functions, if QT interval is your prolonged because of the cardiac risk, we have seen this risk in this COVID pandemic, because in between it was said that hydroxychloroquine is well tolerated or it acts against COVID, and people started using HCQ, and we had many complications, many mortalities even with HCQ during that time. Then another drug, reflunomide, it is a very good drug, very effective drug. It is as effective as your methotrexate, but it is, as Sir has already said, that it should not be used in your pregnancy and lactating mothers and children's, then severe liver injury, fatal liver failure, pre-existing liver diseases, and not for severe immunodeficiency, bone dysplasias, bone marrow dysplasias rather, and severe uncontrolled infections, and hepatitis, hypertension, he has already mentioned, GI upset. Then we have to monitor CBC and the LFT as well as the BP for every 2 to 4 weeks. And combinations with this drug is hepatotoxic, more hepatotoxic rather. Sulfasalazine, contraindications, they include patients with hypersensitivity to sulfasalazine or sulfonamides, then intestinal or urinary obstruction, porphyrias. And main adverse effects, their GI symptoms are there. There is orange staining of the urine, as well as the contact lenses, they are also stained orange. So you have to be careful with this drug. The neutropenia, thrombocytopenia, it occurs very less because 5 to 10% of patients. Then monitor the CBC and LFT. Corticosteroids do not arrest the rheumatoid process. You have to be clear. These are actually corticosteroids should be used for a lower dose, as low as possible, and for a shorter duration. Of course, during flare-ups, you can use it, and you can use it in monoarticular involvement. When there is a flare-up in a single joint, you can use it as intra-articular injections. And this may lead to steroid dependence. And steroid means prednisolone induced osteoporosis if it is used in a dose of 7.5 milligram for more than 3 months. Azathioprine, again another drug which should not be combined with methotrexate. Then we have anti-TNF alpha inhibitors like infliximab, etanercept, adalimumab, golimumab, and certolizumab. Their susceptibility to opportunistic infection is increased, mainly your lung infections, pneumocystis, pneumonia. Active or latent TB, we should not use this. Active or latent viral hepatitis during lactation period. And these TNF alpha with methotrexate, it increases the response of the drug. This is a very good indication. And it reduces the antibody formation against the drug. When we are using a drug for a longer period, any drug, the body forms antibodies against the drugs. But it has been seen when you combine these biologic DMARDs with methotrexate, the antibody formation is reduced. Then we have got IL-1, interleukin-1 blockers like anakinra, canakinumab, and rilonacept. So any infection and neutropenia, these should not be used, or in lactation also. Then interleukin-6 blockers like tocilizumab in diverticulitis and SARS-CoV-2. Then T-cell modulators like ibatacept, they can be combined with methotrexate, but not with TNF alpha antagonists, because they increase the risk of infection tremendously. Then B-cell lymphocyte depleters are there, like rituximab. No doubt it's a very good drug, very good biologic, and it depletes the B lymphocytes, but it can be combined with methotrexate. Then lastly, we have got the JAK inhibitors, tofacitinib, baricitinib, and upadacitinib. It should not be used in infections, severe hepatic failure, renal failure, pregnancy, or lactations. And the good news is more than 130 these kinase inhibitors, they are currently being evaluated. So in the next, I think, 5-10 years, we will have a good armamentarium to fight rheumatoid arthritis. So to sum up, any latent infection should be ruled out, organ dysfunction to be screened and monitored. In females, history of pregnancy and lactation should be taken, risk of opportunistic infections to be kept in mind, and vaccination and pre-treatment to be started if required. So take-home message, dear friends, is rheumatoid arthritis should be diagnosed early and the treatment initiated early and aggressively. And these treatment, they are targeted towards disease activity remission or low disease activity. We have over 20 DMARDs, but the approach should be highly individualized for each patient. And to achieve the disease activity target, methotrexate, it's a DMARD of choice. You can go up to 25 milligram once weekly and given subcutaneously also. And combination DMARDs with or without biologics, they achieve the disease activity target. Many effective biologic DMARDs, they are more effective when administered with methotrexate. And NSAIDs, they are never indicated without concomitant use of DMARDs. Glucocorticoids, they are very rapid, effectiveness is very rapid. These are powerful DMARDs, no doubt, but they should be used as bridge to effective DMARD therapy. The best dose, as I have already said in my morning paper, for chronic glucocorticoid therapy is 0. Biosimilars, they are cost effective and should be used when possible. And comorbidities of rheumatoid arthritis, especially your cardiovascular disease, as already Professor Chandrashekha has said, that they should be addressed aggressively. Thank you.
Thank you very much, Dr. Chinmoy. It was really, really important if a patient comes to us with what.
Dispur as a blood thinner. Should we advise methotrexate in that?
With aspirin, sir. Methotrexate with aspirin, it is not advisable, sir. Yeah, it is, but if he's taking aspirin for cardiovascular disorders, sir,
For cardiac issues, they already taken continuing and need for a methotrexate. Two medicine at the same time.
It should not be direct discussion, please. Questions should be directed, yeah. So at least thank you, Chairman Das, because it is very important for us to know when not to prescribe a drug. We don't want a patient with one problem and landing into another problem under our treatment. So thank you very much again. Requesting Dr. Chandrasekhar again on talk on JAK inhibitors in rheumatoid disease, requesting him to finish it in half his time, please.
Just on the concept and why we should be careful with this particular drugs. So available drugs are tofacitinib and baricitinib. Both are approved by FDA for varieties of indications, including rheumatoid arthritis and IBDs. So this is a cartoon which I like to JAK-STAT pathway is also required for housekeeping. In a sense, these JAK-STAT pathways are active even in hematopoietic cells. These are also required and active in some of the endothelial and epithelial cells, which are a regular housekeeping work it has. It's like what you remember in NSA, it's like cyclooxygenase pathways 1 and 2. One is a housekeeping, another is a induced enzymes. Here they have both housekeeping function as well as the induced functions. We may interfere in some of the housekeeping functions, but by modifications, they were able to work on that. As I said, there are quite a few of these NIBs which are going to come in the pipelines. They have a specific pathways which they inhibit. We have 4 different types of JAKs, JAK1, 2, 3, and type 2. The different combination of these JAK pathways are interfered, and we expect them to behave differently, as I showed in the previous slides. So, as I said, JAK inhibitors are pan-cytokine blockers, and as a result of which it can impair the immune system function effectively and probably more than what I expect. So, altering JAK pathways, which is crucial as a secondary messengers, may interfere several cytokine pathways. So, where is the current recommendation of JAK pathways? I made it in my previous presentation. It is after the failure of methotrexate or any of these combinations. Never use the JAK pathways as the first drug to be used. Though there are enough trials to say that it can be used as a first drug, it can be used as the earlier single drug. We need to remember a few things, because should I really go so aggressive in a patient who really don't require it? If you are sure that patient has a very aggressive disease and a disease which is long lasting, there is no other way out. For example, in ankylosing spondylitis, in a very aggressive disease, probably sulfasalazine and methotrexate may not work. Option left for you is either to use the biologics like anti-TNF or to use the JAK inhibitor. If there is an axial disease, you have every right to use the JAK inhibitors in these settings. Whereas in a rheumatoid arthritis, where methotrexate, leflunomide, and sulfasalazine, which could be more effective, the adverse event therapeutic toxicity ratio of these combination is much more better than the JAK inhibitors. JAK inhibitors, infection rates are very high, MACE are very high. So that being the case, if I have a cheaper and a much comfortable option where therapeutic toxicity margin is less, I would prefer to go for the lower portions. Whereas in angst, as I said, I have less choice. Methotrexate is not as effective as I see, and neither the combination of sulfasalazine and methotrexate is not effective in the late course of the disease or the patient with a very aggressive disease. There you have every right, because the adverse or whatever the risk you are taking is worth it. So that's how the decision making should come with reference to JAK inhibitor. Currently, as I said, JAK's position is in phase 2, not in step 1. Because one of the concern I expressed to pharmaceutical companies, including the marketing, I told them very clearly, be clear to everyone that JAKs should be used in rheumatoid only after phase 1 effective trials. So many recommendations are there, which have included now tofacitinib in their recommendations. All of them have recommended at that point of times. So as I said, it's an inadequate response. Psoriatic arthritis, you can use little earlier than what we recommend. Angst, NSAID failures or biologics cannot be used, or biologics failure, there you can use. It may be used as monotherapy in combinations with others or other non-biologics DMRs. So these are the other indications. We do also use in atopic dermatitis, leukoderma, and other chronic inflammatory conditions. Even in few of the patients in scleroderma, pyoderma gangrenosum, where I really didn't get a good response to the immunosuppressant, JAK inhibitors have really done a wonderful job. No doubt, it's a wonderful drug, but we need to remember it has a lot of concern with reference to adverse event. Adverse event are serious infection, malignancy, MACE, DVT, and pulmonary embolism. And you need to risk stratify the patient. Patient above 60, preferably avoid. Patient with a previous history of a cardiovascular disease, it is preferable to avoid. And patients with a previous thrombotic or a thrombosis episodes, preferable to avoid. Patient with repeated infections, patient who comes to you and tells that I've been admitted 3-4 times in the hospital with an infection in the last 6 months. He is patients who need to be avoided. So you need to carefully choose these patients, because you are working with a little aggressive drugs, because serious adverse event can almost come at 3.4 to 0.3. So there is a lot of adverse events which is expected when you compare it to methotrexate and leflunomide combinations. So one thing which it has been advised as per the recommendation is to screen for tuberculosis before prescribing tofacitinib. Tofacitinib, one of the major concern is the flare of tuberculosis. And it's as I said, it's a pan-cytokine blocker. It's as powerful or as good as an anti-TNF. The way before we prescribe anti-TNF, we need to preferably screen for tuberculosis. Simple chest X-ray and Monto is fair enough in a resource-constrained patients and the resource-constrained settings. In a place where it is possible, if a TB quantiferon patient can afford, that's the best way to do it. Just do a TB quantiferon test negative, as well as chest X-ray is clear. The patient is cleared for going for the treatment. If patient has a TB quantiferon positive or chest X-ray shows a possibility of old tuberculosis, patient is preferably put on a anti-TB prophylaxis. Here, you are not going to use rifampicin and INH combination, which we suggest in other patients. In tofacitinib, the only preferred prevention is to use INH, because INH, rifampicin interact with tofacitinib in reducing the efficacy and adverse events. So the risk for thrombophilia, lipid abnormality should be excluded. So malignancy prone individuals should be avoided and a good surveillance should be expected. Follow-up, please do the lipid profile within the next 6 weeks to 8 weeks. We do find quite a good number of patients to have a tilt towards atherogenesis. If the lipid profile tilts to atherogenesis, introduce atorvastatin in these group of patients. Check CPK, very unusual, we have a myositis in them. LFT, creatinine and CBC should be screened at a regular interval of at least 2 to 3 months. So the drug adjustment, suppose if the patient has here ANC around 500 to 1000, discontinue the drug for a short while. After recovery, reintroduce it. In contrast to other DMRs, you need to also look at the lymphocyte count. If lymphocyte counts are less than 500, absolute lymphocyte counts less than 500, there is absolute contraindication to start tofacitinib. These are the set of patients who are likely to land up in infection. So lymphocyte count is something which you have to be very crucial. And patient with hemoglobin less than 8 grams, think twice too. So this is the last one which I choose to use. It's a very good drug, no doubt. It's like a nuclear energy. You need to safely use it. So nuclear energy is safe as long as you follow all the safety measures. It is one of the best green friendly energies, but if you blast it, you had it. So that's what with the tofacitinib. Thank you very much.
Thank you, Dr. Chandrasekhar. Was nice. I don't know how to screen for various herpes zoster beforehand, but once you have given this drug and patient has got a highly painful herpes zoster, how do you manage on that?
Actually, now at least we have the vaccine for herpes zoster. The patients with a susceptibility to have the herpes zoster, especially above 60, give the vaccine and start it. If I get a herpes zoster, treat the herpes zoster, and you can reintroduce the tofacitinib after 2 weeks. So it's not a contraindication to withdraw the drug. Hold the drug only for a couple of weeks till patient comes out of the herpes zoster, and then you can reintroduce.
Sure. Thank you very much. Next talk would be by Dr. RENUKA. Lab parameters monitoring in inflammation. Really a topic which interests all of us. Will requesting her to kindly emphasize on more common investigation which we can do and not what can be done only in corporate. Thank you very much. Sorry to give you some unsolicited advice.
Yeah, absolutely, doctor. See, when it comes to monitoring, it is only the basic tests which are available.
Thank you very much.
Yes. So when it comes to, as doctor has already informed, I'll be looking into the very simple test over here, but the one thing which is common to all these autoimmune disorders or connective tissue disorders, be it rheumatoid arthritis or SLE, is that inflammation is the hallmark of all these rheumatological diseases, which are of course multidimensional with varied clinical manifestations. And there is no single marker for actually monitoring any of these diseases and which are very disease specific. So what we need to do for assessing the disease activity, wherein you can reverse the disease, is a very critical component of patient care, and which the disease activity also fluctuates. So monitoring therapeutic aspect is very important. To measure the disease activity and quantify the inflammatory process, we use markers of inflammation. It's not moving. हिल नहीं रहे. हिल नहीं रहा. अच्छा, ठीक है. So whenever there is an injury and there is an inflammation, what is happening is the cytokines will be released by the monocytes, macrophages, endothelial cells, fibroblasts, which then act on the liver, and it causes a downregulation or upregulation of the transcription factors. And certain proteins are released. These proteins are known as inflammatory biomarkers or acute phase reactants. If there is a increase in it, it is called as a positive acute phase reactant. And if it is a decrease, then it is a negative acute phase reactants. The positive acute phase reactants are haptoglobulin, serum amyloid, fibrinogen, ceruloplasmin, CRP. All of these there will be an increase in inflammation, and these are the cytokines which are associated in stimulating this particular parameters. And the negative factors are, of course, albumin, transferrin, transthyretin. But in clinical practice, the two markers which are most used are ESR and CRP. And I'll be focusing only on these very two simple, commonly available in every center, CRP and ESR, along with total counts. And I'll touch on the neutrophil lymphocyte ratio. So when it comes to ESR, this was a very common test. All of us would have done it during our undergrad days. When you allow an anticoagulated blood is allowed to stand, the RBCs settle down, form a rouleau formation, and then they sediment. And that is what we do in the erythrocyte sedimentation rate. And this happens because of the action of fibrinogen and other plasma proteins. So it actually is not a direct acute phase reactant, but it's the indirect measurement of acute phase reactant, because it actually reflects the increase of the acute phase proteins such as fibrinogen, which is a degradation product. Widely available and cheap to use. Very important that the lab parameters, quality checks have to be performed. I won't go into the details over here because we are running short of time, that the length of tube should be right, the diameter should be of appropriate, because there are a lot of tubes which are available in the market which are not standardized. And when we are doing the test, we have to ensure that it should be kept vertically straight. So we also have automated ESRs, which are actually in accordance with the Westergren's method, which take a reading instead of at 1 hour, we are able to take readings at 25 minutes. And here we use a digital sensor, so that instrument automatically determines the sedimentation level of the erythrocytes when the data, and then within 25 minutes, and then the data is processed. The sample which is required is comparatively lesser compared to the ESR. And here the good part is the temperature is controlled. But and the ESR, as we all know, that in males it is 0 to 9, in females it's about 20. But as the age increases, the ESR level can be high, and we should not take very clear cutoff values. Generally, it is required that as per in males, it should be age divided by 2, and in females, age plus 10 divided by 2 is a better approximate idea of getting into the ESR rather than exact figures. ESR is increased in all of these autoimmune conditions, but it's also increased in a lot of other infections, chronic infections like tuberculosis, osteomyelitis. It is increased in malignancies. It is increased in multiple myeloma specifically, and renal disorders also. So the problem, what I would like to mention is, we should remember that there are a lot of physiological variables that affect ESR. One is the age, the gender, the plasma protein concentration, pregnancy, there will be an increase, and RBC factors. Like in any anemia, basically it is like, moving. If there is a less crowd, I'm able to move to the other side of the class, the room faster than in compared to when there is a more of RBCs which are there. So basically in anemia as such, the ESR can be high. So that is what happens. And smoking increases, and of course temperature, which I have already mentioned. So there are a lot of physiological variables which are there, but then that's a test which is easily available and where we can do it. So the other parameter is C-reactive protein, which is a homopentameric acute phase reactant, and it is released by the liver. because of the stimulation by the cytokines, inflammatory cytokines, IL-1, IL-6, and sometimes TNF-alpha. The CRP gene can be located at 1q2.2 on the long arm of chromosome, which are not really required now. It is produced primarily in the liver, but also reported to be synthesized in the smooth muscle cells, macrophages, endothelial cells, and lymphocytes. What's the basic difference between CRP compared to ESR is that CRP shows a rapid response to any inflammation, increasing within hours of stimulation and repeating and falling back to normal after the treatment. So here basically CRP has two isoforms. During inflammation, the liver is stimulated by the cytokines, pro-inflammatory cytokines, releases the CRP, which then forms two isoforms, the pCRP and the mCRP, which is the mutant CRP and the native one. And these CRPs, these are also the isoforms, which are the active forms. This basically also causes stimulation of the activation of the complement pathway by the C1q and causes complement fixation. Also, it activates the platelets, leukocytes, and endothelial cells. So basically, this CRP is a parameter which is not just an increase in the inflammatory marker, but also plays a role in the inflammation. And it helps in both by the T cell and complement mediated pathways. Methods of detection, same as in rheumatoid factor, it is either done by latex, immunoturbimetry, or nephelometry, what I have discussed. If you use any of the automated methods, it will be easy to do. You get quantitative results and you require a very small sample. And you are able to monitor more accurately when the patient is come for treatment. The CRP level is usually less than 6 milligram per liter. I would just like to bring in this, it is usually elevated here, an aspect of HSCRP or ultra-sensitive CRP. It is a concept that CRP and HSCRP are actually different tests. These are more of a technical aspect that HSCRP and ultra-sensitive CRP are much more sensitive at lower levels of concentration, and which is what is used when we are doing the cardiac monitoring, because CRP is also raised in atherosclerosis, used in ischemic heart disease for monitoring and so in MI. So there it's HSCRP plays a role because there it is, we are taking the lower values as the cutoff. When it comes to inflammation, cutoff, it is, we do take a consideration of 6, and the other aspect is HSCRP and ultrasensitive CRPs, usually they have a very low linearity when they are doing the assay. So that is the reason it does not pick up very high values. So if you do a regular CRP, you can pick up even high values of CRP, and in inflammation, you will find 100, 120 also CRPs which are coming. Of course, all of us are aware during the COVID period. So it is increased both in infections, hypersensitivity reactions, other chronic inflammatory levels, and a lot of cardiac conditions. ESR versus CRP, I will not get into the technical aspect, but I will just say, suffice it to say over here that ESR is an indirect measure of inflammation, whereas CRP does a direct measurement of acute phase reactant, and it rises comparatively slowly and may not return to normal for weeks despite clinical improvement, whereas CRP is elevated within 4 to 6 hours, peaks at 36 to 50 hours, and returns to normal within 3 to 7 days after the stimulus is withdrawn. Most of the conditions of which is the parameter which you should choose, ESR or CRP. In most of the arthritis, as well as to know in inflammatory arthritis, in rheumatoid arthritis, CRP is the parameter of choice. But except for SLE over here, CRP has no role. Actually, it is mainly the ESR which is elevated. CRP does not correlate with the disease activity. If a CRP is increased in a case of SLE, then it could probably be because of infection. Just to recapitulate clinical condition wise, rheumatoid arthritis, RF and CRP are not really useful, but it's the ESR and CRP which are useful for monitoring along with clinical disease activities. In juvenile arthritis, elevated levels of CRP are associated with polyarticular synovitis erosions, and there can sometimes be some amount of discrepancy when there is a ESR is normal, CRP is high. In that case, you give more importance to CRP. And in adult onset, CRP doesn't really help. ESR, it's more of serum ferritin levels, which show a good correlation for monitoring the patients. We had taken up this study to see which was the better parameter for rheumatoid arthritis, and it was found that CRP is a better measure of inflammation than ESR for when we were doing the and correlated with the clinical factors like tender joint count and swollen joint counts. When it comes to SLE, I've already said, though ESR is a non-specific marker, it may be raised, and CRP has no role, but it indicates probably infection. In ankylosing spondylitis, it is more of the clinical picture. So you have other clinical markers which are important for disease activity along with the inflammation, and very moderate association is there. You can't go by it, but still CRP is a preferred one, elevated in 50 to 70% of patients, particularly with arthritis and uveitis. Scleroderma again over there, and vasculitis, again ESR, CRP are not specific but can be used for therapeutic response. CRP, rather PR3 anchors are used for it, and CRP levels correlate better. There is another new emerging marker which we are looking at. Very easy to do is, along with the total counts, is neutrophil lymphocyte ratio. It is a very simple parameter where you do the take out the neutrophil and lymphocyte ratio. Usually it should be between 1 to 3, and it has proven to be very good. Only thing is with stress and steroids, it can get affected. In critically ill patients, particularly, it's much more helpful. So we had taken up in our center this study of characterizing of neutrophil lymphocyte ratio as a measure of inflammation in patients with rheumatoid arthritis. And it was found that patients, when they have a low disease activity, particularly where RF and ESR are still normal, neutrophil lymphocyte ratios have been useful in monitoring these patients. So basically, inflammatory markers, the most commonly used markers are still ESR and CRP, more than the disease autoantibodies or any other specific markers. And they're very useful in monitoring. They have to be, you have to take into clinical context all the limitations of the assay, but they are otherwise, currently they are the only ones which are used for monitoring and to differentiate between active and quiescent disease, as well as to assess the severity of the disease. Thank you.
Thank you, Dr. RENUKA. It was a very nice presentation and very useful for us. It is really important. Drugs we use, we should monitor. We are doing in a good way. May I request Dr. Amul now to talk on rituximab in RA. I wanted to cut off 5 minutes of your talk because I saw you distributing sweets to all the organizers. Chairmen are really also important, isn't it? So, but anyway, I will allow you because you are Dr. AMULYA and I have to live in Patna.
Respected Chairperson, sir, good afternoon. Talking on this aspect of rheumatoid arthritis, where we are concerned with this rheumatoid arthritis, koi na koi cell hoga jo disturb karega. It can be T cell, B cell. My concern is B cell therapy, and after that, why chimeric monoclonal antibody. 3 चीज याद रख लो, इलाज हो जाएगा. Rheumatoid arthritis, B cell, chimeric monoclonal antibody. Lecture khatam nahi hua. Let me continue for 15 minutes. And this, in management rheumatoid arthritis, we have to be early aggressive management. If not done properly, that deformity and morbidity can occur. And concern of orthopedician are the joint pain, stiffness, and deformity. Patients with advanced rheumatoid arthritis have lots of problems in their daily life activities. They have physical problems which lead to social problems and ultimately psychological problems because the family life is getting disturbed. Life is not the same after misdiagnosis. You see this young boy, now an engineer. What happens if we do not treat or sub-treat optimally? Patients can go to this stage. Why not early aggressive? Chronic inflammation. Sound off. Chronic inflammation in the rheumatoid synovium. The T cell stimulates the release of cytokines that directly activate synovial macrophages, and these activated synovial macrophages release a large amount of interleukin-1 and tumor necrosis factor. This is towards the T cells, but T cells also activate the B cells, which release the rheumatoid factor. B cells for the past 30 years, RA was considered a T cell mediated disease, but later on only the important role of B cells in the pathophysiology of rheumatoid arthritis was revealed. This new discovery led to a breakthrough in the management of rheumatoid arthritis, and we have to plan our treatment depending on the pathology and cells involved, and sometimes we do require biologics for management. What Dr. Chandrasekhar has said, when, how, let's decide. Biologics are medications genetically engineered from a living organism, such as a virus, gene, or protein, to simulate the body's natural response to infection and disease. They are typically reserved for people whose arthritis has not responded adequately to traditional disease-modifying anti-rheumatic drugs. Yes, Dr. Chandrasekhar has said the same thing. And what are biosimilars? They are biologics, highly similar to innovative biologics, but the only difference is between the design, manufacture, composition of the end product, and the formulation. But the end part is that efficacy is the same. Price is less, but efficacy is the same. And different types of biologics, I will be only concentrated on my topic, that is a B cell inhibition, and how we started. Yes, we started from 1990 when leflunomide, and before that methotrexate, salazole, Palan, etc. was there. In 1990, leflunomide came in the market, and now 2022, where JAK inhibitors have come. In 32 years, lots of revolution has come place, and my concern will be 2006 when rituximab came in the market as a B cell inhibitor. This is the first selective B cell therapy for rheumatoid arthritis, chimeric monoclonal antibody. My topic lands here. Chimeric monoclonal antibody. What is this? Chimeric antibodies are structural chimeras made by fusing variable regions. Try to remember only two things: variable, constant. Variable regions come from one species like a mouse, and constant regions from another species, that is a human. So chimerization of antibodies reduces the immunogenicity and increases the serum half-life and when preparing monoclonal antibodies. And these monoclonal antibodies are identical antibodies with the same antigen specificity. This property, chimeric monoclonal antibody, this has revolutionized the field of diagnosis and immunotherapy for the treatment of a variety of diseases. And my concern is rheumatoid arthritis only at present. Examples are infliximab, rituximab, and afliximab. This rituximab, what I call your chimeric monoclonal antibody, two things: constant and variable region. This is a novel genetically engineered anti-CD20 chimeric monoclonal antibody that selectively targets CD20 positive B cells. When I started, rheumatoid, B cells, chimeric. Yes, here comes the positive CD20 B cells. And structure, 1 year region is coming, constant region from human, and the variable region which is coming from the anti-CD20 murine antibody. That's why this is called a chimeric monoclonal antibody. CD20 is found on the surface of B cells, which plays a role in the development and differentiation of B cells in rheumatoid arthritis. That's why the reason binds to on the B cell surface CD20 antigen, and human derived, the constant reason activates the cellular mechanisms to initiate. This is the only thing we are how rituximab acts on rheumatoid arthritis. There are three postulated mechanisms. First is a complement-mediated cytotoxicity. Second is antibody apoptosis. So Now you have come to a drug which is going to be effective to rheumatoid arthritis. The diagnosis has to be correct. One gram infusion of first day followed by second dose after 2 weeks. This is the dose. One infusion once a week for 3 weeks means total 2 gram has to be given in 20 days. Always give pre-medication. This is mandatory, and always infuse under strict supervision with ICU setup preferably, because there are chances of some reaction. First infusion may take between 6 to 7 hours to complete. This is mandatory. First infusion minimum is 4 hours 15 minutes, not less than that. 3 hours 15 minutes. Don't rush with the infusion. Go slowly. If the patient had no adverse effect during the first infusion, then only you can do slightly faster on the second infusion. The rate of infusion will depend on the concentration of the rituximab and whether it is the first or second infusion. If you have given rituximab at right time with accurate diagnosis, then there is good and early relief, what you see in this patient. And also the deformities can be prevented later on. Yes, what you have to monitor? Pulse rate and blood pressure to be monitored every 15 minutes while doing the first infusion for the first 1 hour, followed by recording the same every 30 minutes till the infusion is complete. That's a cardiac monitor essential. Watch for sweating, palpitation, rash, itching, hypotension, etc. And checklist, big list is here. What you have to do before we are planning to start biologicals means rituximab, routine blood test, rheumatoid factor, ANA, chest X-ray, just to rule out the tuberculosis. TB screening is mandatory, pregnancy test, viral screening. For rituximab, serum immunoglobulin level has to be checked. And screening question, you have to rule out tuberculosis, interstitial lungs disease, cancer, etc., etc. And checklist, all patients should be vaccinated with influenza and pneumococcal vaccine 4 weeks before starting the biologics. No live vaccine like herpes zoster to be given to a patient while on biologics. This is mandatory, what Dr. Chandrasekhar has also said. But after that, you can again give your biologics. Adverse effects can be there. Local rash, erythema and itching. Infection, chances of minor respiratory infections. Infuser reaction, tension, but go slow, chances are less. What are the adverse events during rituximab infusion? 30 to 35% after the first. Serious infusion reactions can occur, but are rare. Reported more in literature and books. Acute infusion reactions occur within first 1 to 2 hours of the first rituximab infusion. This has to be taken, and you have to do it very cautiously. Yes, I will be using mostly in my rheumatoid arthritis, not concerned with the other diseases.
आपको कब शुरुआत हुआ था जोड़ों का दर्द सबसे पहले?
What is good and safe?
2018. उसके बाद आप
long video. Now some of the case of rheumatoid arthritis which came to me in August 2021, already on DMRD for more than 6 to 7 months. Hip was deformed and ankylosed. You can see the first picture on the bed. Rituximab injection was given in August, September 2021. The patient was bedridden before and was able to stand and walk, but hip joint was still not that normal. In March 2022, last year, he came to me. Pain had decreased, but he wanted to walk properly. Bilateral THR was done by me, left in April 2022 and right in December 2022. This is what patient is still at my place because he has come with 4 patients 4 days back from Assam. This is the result, what is there, X-ray of 6th of April. Able to climb up here. Another lady, this is a long case. I will try to summarize. 4 minutes are left, try to summarize. The problem started November 2007 with pain in finger and toes. There was no fever initially. She took some analgesic. Pain was more in night and morning. Associated morning stiffness was there. In December 2007, antibiotic analgesic was prescribed somewhere else, but no significant relief. Pain increased gradually and involved other joints by January 2008. Patient shifted to Ayurvedic treatment after 3 months of primary onset. After 5 months, AKT was started with some good physician. After seeing the reports of raised ESR, etc., there was no relief. Pain swelling increased. She went to Kerala for Kerala massage that in May 2008. In June 2008, after 7 months, homeopathic medicine was started. Again, no relief. My first interaction in July 2008, 8 months after the primary onset. Patient was brought in ambulance with heavy dose of analgesic. She was crying with pain, joints acutely tender, severe pain. She was begging for some relief. Her DAS score was 22. Total count on that day was this: ESR 96, CRP 34.5. Other factors are there. Yes, confusion was there with it is arthritis, and if arthritis, which type of arthritis? I had to bring the pain less. X-ray was done. X-ray of wrist was done. Pelvis was done. Really sorry, no clinical picture available because this patient was 15 years old who came to my center. Same day, high dose of Solumitrol was given, 1 gram IV with analgesic antibiotic. There was relief. Next day, same drug was repeated. More investigation was done. ESR was 90, CRP 42. This was the third day, very good relief of pain because of high dose of steroid, nothing else. Now, what to do next? MRI of wrist. Lots of investigation, not going in discussion. Started DMRD, methotrexate 15 milligram weekly and hydroxychloroquine 4 milligram per day. DAS was 15. I thought my job is over, but pain started increasing after 10 days. In September, she came to me in July. In September, problem increased. More test was done. PCR for COX was negative. MON2 was negative. HIV negative. She was already on DMRD. What next to be done? Planned for biologics. Should I start? Question was there. I talked to Major General Ved Chaturvedi. He said, start it right now. Rituximab was given on the 59th day after a first visit in my chamber, and after 54 days of starting oral DMRD, and result was good. And in this case, this is the first case of Reditex RA of Dr. Reddy's lab, which was used in India. I was the first one who used it in India. 500 milligram IV infusion, the same does. Pain and swelling decrease. She is the lady in my hospital. It was a miracle. Movements improved, appetite improved. She was back to work. The quality of life changed. She was able to do almost all her work. The attendants were happy. Patient became irregular in DMRD gradually. Again, I consult. Time is going on. I will take maybe 1 minute more. Leflunomide added 10 milligram with methotrexate hydroxychloroquine in July 2009. And monitoring was done with ESR, CRP. But in May 2015, something alarming was happening. ESR 113 now, CRP 26.87. Something serious. I consulted the patient well, wanted to give her a next cycle rituximab after proper investigation, but she went home. And again, when she came back, she was in this condition. Extreme weakness, lethargy, fever, decreased appetite. Just 1 minute more, maybe I will take. And 1st of September 2016, total count was 61,000. What to do? Bone marrow was advised, CLL diagnosis, flow cytometry was advised. Total count 85,000. Diagnosis was leukemia B CLL. Chemotherapy started, rituximab and other things, not going in detail. Again, patient started feeling well. December 2017, DMRD continued with methotrexate and hydroxychloroquine. Progress has been monitored till 2019. ESR was 28, CRP was 3.02 in the last line. and October 2019, all well now. Patient is happy on DMRD, regular follow-up. And
What's the age now?
going in this video, this year, 2023, not on DMRD for last 1 year. To answer on this, at present, not on DMRD. So take home message, rituximab with a unique mechanism of action. Rituximab is an important agent approved for the treatment of rheumatoid arthritis. Depletes B cell by various mechanisms, what I told you. Most efficacious in seropositive, not in seronegative. Reasonably safety profile. Infusion reactions are initial infusion caution. It is very serious. It is important to screen patients for hypersensitivity to murine proteins others, and vaccination should be provided prior to treatment whenever possible. Friends, goal for treatment is low disease activity, inhibit the joint damage, maintain function capacity for work, and basic activity of daily living, and prevent disability. But ultimately, what as a clinician you want is remission. This is our work. We want a remission in our cases. If you plan out aggressively, you can do it. Thank you very much. We have to change.
Thank you, Dr. Amul. One thing I would like to know, what about the cost of this rituximab?
Rituximab is 40,000 MRP. They supply at around 12,500 these days, Dr. Reddy's lab.
So altogether it will cost something
80.
1 lakh
Sir,
something.
everything, yeah. It
1
will
lakh
go
something.
to 1 lakh.
It will cost you 1 lakh something in 20 days. Right? Thank you.
Yes. Thank you, sir.
So I will call Dr. Ravi SAUHTA. He will talk about Estravad. So drag with double-edged sword. Estravad. Dr. Ravi SAUHTA, yours.
Respected Chairman, sir, my take is on steroids in rheumatology, the current status. 5 key points of this talk are basically main therapeutic effect of of the glucocorticoid steroids is anti-inflammatory immunosuppression. It is used as adjunct therapy with conventional DMRDs and biologics. It is never used alone. Judicious use of a steroid as a bridge therapy in early rheumatoid arthritis, and a low dose in established rheumatoid arthritis, and a pulse therapy in acute flare-up and connective tissue disorders. Beware of adverse events related to the glucocorticoid use. In comorbid patients, basically, you have to choose a very effective therapeutic window for early rheumatoid arthritis. Where there is a monoarthritis, you use the intraarticular, and or in enthesitis, you use local steroids, particularly intralesional. Additional stress dose can be used, especially when you are operating these patients for major surgeries like cardiothoracic or arthroplasty. Use of a steroid was by these pioneers in 1950s and perceived as dramatically altering the long-term course of the disease. And it was obviously with a lot of adverse effects, and have been reintroduced for the treatment of rheumatological conditions, and more rational approach of this has been recently re-looked into. Corticosteroids are most effective in early inflammatory arthritis. There are 3 scenarios. One is new onset, when it is less than 12 weeks of a disease. Oral steroids can be used, or intramuscular or intraarticular if it is monoarticular, in a very early disease for introducing the remission. In a new onset rheumatoid arthritis, systemic therapy can be used, 2 to 20 milligram of a dose which can be used. NaCID can be added in these patients. Early aggressive rheumatoid arthritis, adjuvant therapy, which is with the basically DMRD, and it is used in a dose of 60 milligram per day, usually followed up in a gradually decreased dose. If you look at the spectrum of a rheumatoid of a glucocorticoid adverse effects, there are cardiovascular, eye, skin, stomach, metabolic disorders, CNS effects, bone effects in the form of osteoporosis, osteonecrosis, and myopathies, and so on and so forth. But at the same time, there are good therapeutic effects on the other side, where it has anti-allergic effect, it has a DMRD in rheumatoid arthritis, decreases the swelling, inflammation, stiffness and physical activities, improved vasculitis, and various other conditions. It has a lot of advantages. And one has to see that these Cushingoid syndromes do not occur in these patients. And as already pointed out by somebody, that people go to the chemist and they keep on taking the steroids on their own. And of late, because of persistent use of steroids, there can be sarcopenia and osteopenia, which has been highlighted. Reappraisal of the use of a corticosteroid, which started in 2012, where they are using a low dose, which is distinct from the high dose. Use of early rheumatoid arthritis, which is different from the established rheumatoid arthritis, and a radiological progression and delayed early arthritis. These are the conditions where you can use the steroids, which is known as a judicious use of a steroid, which improves the outcome in these patients. As far as the mechanism of action is concerned, there is an anti-inflammatory and immunosuppressive effect. These are various complex mechanisms which are beyond our understanding, and at time does not permit to talk about in detail. However, these are various genomic as well as anti-inflammatory effects, which are determined by the genomic as well as non-genomic effects of the steroids. And immunomodulatory effects are seen. They act upon almost every immune cell type, monocyte, neutrophils, dendritic cells. They inhibit the ability to activate T cells in these patients. Standardized nomenclature which is used for the rheumatoid arthritis is a low dose, which is less than 7.5, medium dose, which is 7.5 to 30 milligram, high dose is 30 to 100, and a very high dose is more than 100, and a pulse therapy requires to use more than 250 milligrams of the dose. And when you look at the pulse therapy, there is a genomic as well as non-genomic effect, which is seen in when there is a multi-organ, multi-system involvement with the SLE patients. Formulations which are available are short-acting, these are cortisones. Intermediate acting are prednisolone, and long-acting are dexamethasone and betamethasone. When you look at the dexamethasone and betamethasone, they are have got a maximum anti-inflammatory potency and as compared to the cortisones. Rational use of a steroid is basically to modify the progression of the disease in addition with the methotrexate, and window of opportunity is used in those patients where bony erosions and improve the quality of life. Bridge therapy is used for those patients where there is inflammation and to combat the acute flare in these patients. Steroids as a bridge therapy to bridge the gap between the onset of biologics, whether it is conventional DMRDs or biologics. So NSAID is used for the rapid relief of the symptoms. NSAIDs do not prevent bony erosions. And rheumatoid arthritis, when it is established, the disease remission occurs with the DMRDs. And basically, DMRD takes some time before they can act. So they can be, onset of action about 6 weeks. And in some cases, it could be very, very late. Patients who require corticosteroids for the symptomatic relief in NSAID produce adequate response, and this may bridge the gap between the onset of action of DMRD in these patients. Low daily dose, it can be used in those patients where NSAIDs cannot be used and whom the DMRDs have proven to be problematic. That is, there is an adverse reaction, there is a monitoring difficulty, there are poor compliance, and a low dose corticosteroids in the form of, in the dose of 5 to 10 milligram per day, which gives a good symptomatic control, and prednisolone 5 to less than 7.5 milligram per day is used disease modifying effect. There is a prevention of bony erosions. This is the very busy slide where it talks of various studies which have been published in last 6 years, which talks of effect of corticosteroids in a different situations. There are a good decrease in the DAS score and various other parameters when it is used, and almost all the situations it has been used in combination with the various conventional DMRDs. Pulse therapy is indicated when there is a major organ threatening disease, when there is a scleritis, pneumonitis, or mononucleotitis, and there is patients do not settle with the adverse flare up, and there is an effect which may last for few months and weeks, and these patients in conjunction with DMRD such as gold compound may result in improved efficacy. Pulse therapy is well tolerated and less toxicity response is seen. Pulse therapy of corticosteroid is given in severe lupus, where methylprednisolone is used in a IV 1000 milligram per day. 3 doses are given daily, and concomitant cyclophosphamide, or especially when there is a life-threatening conditions like nephritis, vasculitis, or pericardial tamponade and severe cytopenia. Steroids in SLE is the mainstay of treatment, where prednisolone is used. Initial doses of steroids when there is a disease activity which is very, very severe. And in a severe conditions, large doses can be used. Up to 1 milligram per kg per day of prednisolone can be used, or a pulse therapy is initiated in few of these patients intravenously, when and then followed by oral therapy. Steroids in polymyalgia rheumatica and arthritis in connective tissue disorders. Low dose of steroid, that is 15 to 20 milligram, is used in polymyalgia, whereas higher doses are required for giant cell arthritis. ESR-CRP show a downward trend when low maintenance dose of steroid is used in the 5 to 10 milligram per day. And systemic lupus erythematosus is vasculitis, polymyositis, and systemic corticosteroid therapy is used. Severe flare-up, high doses of the corticosteroids are used. Considering before starting the corticosteroids, there are safer alternatives. If there are no safer alternatives, steroids can be started. In patients with diabetes or hypertension and osteoporosis, one has to be very, very careful that there can be uncontrolled diabetes in few of these patients. Blood pressure can shoot up, and obviously long-term use can lead to osteoporosis. Duration of a treatment should be short. Early timings should be early morning, which should match with the body surge of a steroid, which normally occurs in the body. The lowest possible dose should be used for a shortest period of a time, which is and also safe route should be used for the steroids, which could be, if there is a monoarticular disease, you use the intra-articular. If there's the enthesitis, use the local steroids. And patients where there are adverse reactions who are advised in those patients, it should be avoided. So GS glucocorticoid steroids intralesional can be used in these patients. These are various conditions where it can be used. Crystal arthritis, rheumatoid, seronegative, and in other conditions. Whereas carpal tunnel nerve entrapment, it can be used. The dose which should be used is 40 to 80 milligrams according to the size of the joint, which is very important. And you do not give 2 injections within 6 to 8 weeks, and a maximum of 3 injections in a year can be given safely. So these are various ways how the injections are injected with the help of ultrasound guided in particular conditions. And the local, when local steroids should not be used in a periarticular sepsis, whereas unstable joint, in a septic joint, hemophilia, and local intra-articular infections, inadequate septic precautions, and rupture of a tendon can occur, TA ruptures which have been seen. Superficial infections and post injection flare-up of arthritis can be seen because of the in crystals of the steroids. So temporary immune response is seen. Biologics are required to reduce the side effects. Severe surgical stresses, these are the patients where those who are undergoing a surgical stress, their high doses of steroids can be used for a short period of a time. Hydrocortisone 50 to 100 milligram or a methylprednisolone 10 to 50 milligram can be used intravenously. During the course of the disease for 1 or 2 can be tapered rapidly. Long-term use of a glucocorticoid should be avoided. They should be stopped usually within 3 months, as the principle is low dose and for shortest period of a time. Parental bolus can be used in few of these patients. As far as the US recommendations are there, 2015 ACR guidelines, they talk of a lowest dose of steroid for a shortest possible time. European guidelines, they talk that they can be used with the conventional DMRDs to initiate the effect of the disease activity. And US recommendation is less than 10 milligram, whereas European recommendation is less than 7.5 milligram per day in combination with the rheumatoid and others. Guidelines, international guidelines, they talk of to avoid glucocorticoids, lowest dose which should be used, and you should be aware of side adverse effects. In summary, glucocorticoids are important role to play in the rheumatoid arthritis. Clinical efficacy is widely acknowledged, conventional as well as biologics. And in a connective tissue disorder, pulse therapy is recommended. Toxicity requires only when if the comorbid conditions are there. New biologics therapies have not been able to replace the role of a steroid in specific conditions of rheumatoid arthritis. Thank you very much for your attention.
Thank you very much. It was a very important presentation. A small announcement, a talk of Dr. S.S. AMARNATH would be the first talk in the next session. It has been advanced due to his flight condition. Advancement of OA knee regenerative therapy would be the first talk after the lunch. And the last topic before lunch is really very important, very close to our heart. TKR and THR for orthopedic surgeon. Really, this is what we want. And really, rheumatoid is a scenario when we are able to do shoulder also. Osteoarthritis helps to do only knee and hip, but rheumatoid gives us a chance to do a shoulder also. So very good, very important topic. Let's listen to and wait for the lunch now.
Thank you very much. So I'm in the way between you and lunch. I won't be obviously talking on shoulder. This is restricted to hip and knee. And also, I don't know much of shoulder. I know only hip and knees because I work exclusively as a hip and knee surgeon. Greetings from Mangaluru. I will try and keep it technical because this is the only talk which is hardcore surgical in the rheumatology session. So I will try and get straight to the point. So just to introduce the topic, what happens with surgery in rheumatoid is you are dealing with a whole gamut of different situations. So you've got a disease which can clearly be treated by right drugs. The problem is having the brain, which clearly I don't have, to get to the right drug. And we had a lot of clever talks this morning, which is again the reason why patients are not properly educated about it. They are not counseled well about it many a time, and they end up with various alternative treatments, which then bring also the third sympathy aspect, or they are left with folded hands, which kind of complicates the picture. And by the time you come to surgery, there are even more complicating factors. So what important things here before we get to the actual technical part is which ones require surgery, and with good treatment here on the lines of what we discussed, the requirement for surgery is indeed much less than what used to be a decade ago. If you have to think, the surgeon coming in with his knife in a rheumatoid is failure of proper treatment in the proper stages. And despite that, because of all these factors, we are still not out of business. And probably we will still be in business because, like Sir said before, this is indeed a complex disease with remissions and severity and whatsoever. The timing of surgery is very important, and with that, I would like to say that the most satisfying part of the surgical aspect and treating hips and knees has been working, and the most learning part here has been working alongside rheumatologists, because we have published, it's just in the stage of publication, we have presented one of the best, or rather the first time, the Indian series, continuing DMARDs while doing surgery. Of course, the mainstay of treatments is methotrexate. And nowadays, when doing, we've got change of guidelines recently, and we know apart from certain drugs, we don't have to stop these drugs during surgery. I'm very pleased to report in 3-figure numbers, no whatever flare-ups of disease and no infections or skin problems in people with DMARDs who had surgery. So we've reported that very well, and we also know that outcomes in surgery, when it's properly managed, are as good as osteoarthritis, and we've got that in rheumatoid. So we published that with 1-year clinical scores, and actually no difference in clinical scores between rheumatoid and osteoarthritis without stopping DMARDs in a range of rheumatological conditions. We will now go to the technical aspects of it. So when the technical aspects are all about matching what is required and managing that with the right approach. So it's just got to be complementary to the situation. And for an orthopedic surgeon to understand this mechanically is a lot more difficult, a lot more easy. So we just go from knees and then go to the hip. I will try to justify. The organizers have agreed that this will be 15 minutes, I'm sorry, rather than 10, but I'll try and finish as much as possible soon. Thankfully, they have counted as 15 minutes. So, as far as TKR is concerned, we are dealing with situations here which are technically complex. So, no rheumatoid knee should be treated as just rheumatoid and the knee replacement. It is, by definition, a complex primary. Ideally, we need to have somebody who is well managed in conjunction with the rheumatologist, or if the orthopedic surgeon is managing the rheumatology as well, which has to be done where you don't have a rheumatologist. It has to be timed properly with the rheumatologist adjusting the perioperative drugs. Apart from that, you've got complex deformities. We talk about it as valgus. Rheumatoid, yes, commonly is valgus, but we have now published this also. It is not just the valgus, it is going to be more of flexion extension and kinematic problems that these prostheses are going to face. So valgus, of course, the textbook teaches us to do certain releases, but it is not just about that in rheumatoid. It is actually treating the soft tissues, treating the contractures. What you'll often find in these cases is that the contracted soft tissues are in fact harder than bones, because on the other side, the bone is getting weaker. The soft tissues are getting hard, the bones are going to get weaker. And therefore, you will have a range of complications associated. Not only soft tissue complications and chance of infections, but you'll have complications like periprosthetic fractures and dealing with defects. So let me therefore put it up with just a few examples, and I'll go on to examples of hips as well. So that is a typical valgus knee, where all the classic teaching in rheumatoid is this: you're going to have a stretched MCL, you're going to have a contracted lateral side. So people, what is classically discussed in the textbooks is very judicial release of the MCL. Don't release the MCL like you would do in a standard knee, because here it's going to be stretched, and in rheumatoid they come with weaker tissues.
So very easy to avulse and damage it, leaving an unstable knee and unhappy patient if not dead with problem. But I'm not going to talk about the classical valgus releases because I'm sure all of you have sat at conferences and have listened to that. What we'll talk about is something like this. So this is equally common. It's not that most of them are going to be valgus. It is just in India particularly because most of us have a natural bowed leg. It is just going to be a tricompartmental disease and therefore it is going to affect the compartment which is anyways naturally affected. So if somebody gets rheumatoid and it gets worse, particularly in their middle ages, it's going to be more like this than valgus because they have a natural varus and it is a disease which has affected the whole joint. So you have to think of the joint as a whole rather than as a valgus joint. And what you've got here is before you go in, see the inflammation, there's clearly some osteopenia. So this is partially treated. And it was, you couldn't wait too long because of the unstable thing. But, we just got the disease under control. You see massive cysts there. So you've got to be aware of defects that come. So you see the burnt out synovium there. This is, I hope it is clear enough. This looks a reasonably good bone after a bone cut, but you give a pulse lavage and see what happens. This is literally bone being washed away. So luckily here, they are all contained effects, but you can see how the honeycomb is opening out because of all those cysts. And if you can a controlled defect like this in a younger patient, you want to be able to graft, but otherwise, have your supports ready. So that is of that patient. You can see after you've done some release, the collaterals might open up and you might require higher poly sizes. So have your modularity there. The moment you're dealing with somebody osteoporotic, have extra support. So technical help with grafts and or such a case like this, bilateral, polysymmetric disease with kidney disease as well. This person had. So have a low threshold in these people to use stents because they can have higher chances that your tibia might sink. You might get fractures, if not intraoperative, in the relatively early post-operative phase. Now, look at somebody like this. This I will just talk about for 2 minutes. So this guy presented in his middle age with that unstable knee. When he walked, he was actually going into valgus. So he would have been thought of as a valgus knee, but you can see how the tibia is here. It's a very dome-shaped tibia. So there's global instability. What makes it worse was he was on DMARD and we planned him for a complex knee, and on table, or rather just thankfully the day before, he tells us there's a little bleeding from the backside. You look up the backside, there was actually a fistula in ano. The surgeon, thankfully, I put off the TCAR obviously, and I got the surgeon to see that first, and he found a fistula. He used a seton or whatever. Fortunately, he was a head and shoulder surgeon. He sent whatever he took out there for biopsy, and lo, it turns out to be tuberculosis. So rheumatoid plus tuberculosis, he was on DMARDs. So then that had to be tackled. We went down, treated the tuberculosis, and then we had to do a constrained knee. So that is in pretty much, if it is done properly, this is in literally 2 days. We mobilize everybody on the same day, make them walk, but within 2 days, you could easily change him to a stable knee and had good outcome of treatment. Something like this. Now, this is a rheumatoid, which was again treated, was again elderly, but went home, they were doing stairs, just literally missed a step. And what came to us, a week after this was done, because somebody had taken the X-ray in the peripheral sector, but they did not realize that that was actually broken. You can see that it looks like a very lateralized stem, but it was clearly a very, very bad fracture there. And the bone so crumbled that you can't even think of fixing this. So those are the cases where you just throw the distal femur into the bin and do a simple thing. Now, we often get a little, washed away thinking that's a bad fracture, try to fix the fracture. But in these kind of situations, if you try to fix these osteoporotic bones, they are going to be more wrought with complications.
So the approach now is to try and make them walk early, especially if they're elderly. So something like this is actually a very simple operation. You tell them that they have to mobilize carefully afterwards, but you can make them get up and walk pretty much within a day of surgery. Coming to the hip, there is technical considerations from either side, the ball and the socket. On the socket, you have to remember these would be young many times. These would be very, very small patients. Particularly, I somehow feel the youngest hips I have done have been juvenile rheumatoid. So somehow in juvenile, you have more action involvement and hip joint involvement. Hip joint involvement, of course, can be further complicated because when it develops when you get the inflammatory disease in their formative years, you would have an element of dysplasia, which then makes it a little more complex, because as they develop, if something is affected, there would definitely be less development on the socket and a relative hypertrophy or a relative hypertrophic limb entirely rather than just the socket or the stem. Of course, you would have process, you would have to orient the hip joint because it's a central joint, you have to take into account a whole general examination with the joint above, joint below. There could be multiple joint problems, so you have to take all that into account before you do the operation. Let us take a few considerations. This is a commonest theoretical thing talked about in rheumatoid hips, that you are going to get protrusio. So this is a bilateral severe protrusio, of course. But there are many, many cases of very subtle grade 1 and grade 2 protrusios. Grade 1 protrusio is just it being deeper. So compare, whenever you're doing a total hip, compare the thickness of the floor of the acetabular with the other side, if you have a normal side, and you will realize that there is some amount of protrusio. The reason I'm stressing on this is many times in the periphery, when we rely on the representatives with the instrumentation coming with the drills, what they don't give us in the periphery, if you don't have your own saw, this is particularly for the juniors who are starting their practice, when you're dealing with osteoporotic patients, if you don't have a good a saw and a drill system, which has particularly the drill system from the good manufacturers, will have a saw, will have a drill and a ream component for the acetabular. So the striker saw or the desutter drill apparatus will have different frequencies when you're reaming the acetabular. So if you use, for example, if you use your acetabular reamer on the standard Manman, it could just go in very easily because it is not on that system. You're not able to change the oscillation or the revolution speed. This revolution speed for the acetabular should be a real speed. It is that many revolutions per minute as compared to a standard drill. And these are the ones where you can have complications with the cups going in entirely or failing in the early post-operative period. Now, coming to how to deal with protrusio, this is a simple protrusio. Even though it is grade 3, it is a contained defect. So what happens in this case is the grip of the acetabulum remains good. So you deal with it in a standard. You just have to have a multiple cup of a slightly larger size. Don't overream and use it in bridge fixation mode. So what happens is the head which is sacrificed can be crumbled and use this graph there. And like a plate, you construct a bridge from one rim to the other rim with fixation on either sides, and that will give you a very, very good result. You can also, in older patients, of course, use cemented cups, but with cementless, we have a much, much longer outcome. Hips nowadays, once you've done them, they can last forever with the bearings we have. So have no qualms. My youngest hips would be in their 20s. And nowadays we can confidently say if you do good hip replacement, it will probably last as long as the patient. So it can easily last 50, 60 years these days, not a knee replacement. A hip replacement can definitely last. So that is one way to deal with the protrusio. Here is a minor amount of protrusio. So the, sorry, I take a couple of, yeah. So Okay, that was there. A minor amount of protrusion where you can easily see the base of the cup, but it is a slightly deeper cup there. So just a simple method, just to show that is after reaming, you put up a little morselized graft and you use the same reamer in reverse mode. If you have a good drill and the acetabular reamer, as you can see, it reams on one side. So if you ream it in reverse, this is one way of impacting, that is with the head, you're impacting the graft. Or if you use the same reamer in reverse mode, that actually works as a very, very good impaction. So you just impact the graft and then put your cup in, you'll have good results with that. Don't ignore those osteoporotic thin, see, so that is the reamer being used in reverse mode instead. That actually, it's not reaming, it is impacting the graft. Now, here's another case. This is among my youngest hips again. This is to talk about the femoral side. So on the acetabular side, this lady was probably something like 21 when we did it. You can see the dysplasia. You can see the open cup there. On the femur side, it seems like a simple, straightforward femur. At 21, you would like to do a cementless femur there. But remember, there are cases where, like you've developed necrosis because of long-term, this was particularly JRA. So I think they take a long time to achieve remission or come under control. So because this probably happened with added effects of steroids, which would have been given in high doses, and that when it happens, when you get AVM kind of processes there, you can also get affection in the metaphysis. I was fortunate. She had an MRI, and like you can see avascularity there, you can see avascularity in the shaft as well. So you can see why there is literature that cementless stems can fail in AVM. Now, if you don't have an MRI, it's difficult, but do suspect there are about 20% cases of AVM in the head will go along with metaphyseal AVM. So I particularly don't use proximal bearing kind of stems here. So I use more of fully coated stems or distal bearing stems. In this case, obviously, I would have less threshold, or in any rheumatoid, I would have less threshold for doing a cemented stem. There is, with a good Exeter cemented stem, there is no qualm to doing a cemented stem because it will be as long lasting as a cementless stem. One just has to remember, just a technical point here, that it is not the stem design, it is the cementing technique which is more important. So it is not Exeter, but the Exeter cementing technique. Because the reason I'm stressing on this is many companies have made Exeter equivalents and people are knocking in Exeter hemiarthroplasties. But those, if not cemented properly, will be day one failures. A proper Exeter system, you will have to do a proper canal lavage like I showed there. You have to have vacuum mixing of the cement, because otherwise, if that is not there, there will be air vacuums in that cement, and then again, that will be day one failure, and it will not last as much. And you have to insert it very slowly under pressure with good pressurization. So an Exeter stem has to be inserted over a period of 4 to 5 minutes. It should not go in straight away. It should not even be tapped. If it touches anywhere in the canal, again, it is a day one failure. It will not last as long. If it goes properly with the proper principles, it is the longest lasting, the best stem out there. So last point here. Here is somebody again who's young, who looks, of course, it is global kind of inflammatory arthritis there, but always examine joint above, joint below, and look what happens to the joint above. So in that kind of case, this is a fixed pelvic obliquity. You think that patient has an adduction deformity and you might be able to correct it, but you can't correct the deformity at the hip there. So then the surgeon has nothing to do but cheat a bit. So what have I done here? This hip is going to be at a higher risk of dislocation because the pelvis is always going to be like that. So therefore, intentionally, I have kept the cup out. So because you can't correct the spine, when I showed that X-ray to the spine surgeon, I have a spine surgeon sitting next. So he said, when is she coming tomorrow? I'm on leave tomorrow. So, that is a difficult one because nobody's going to be able to, very easily correct that deformity. So you have to cheat on the hip. and that's how you make them survive longer. Of course, that patient had very bad knees. We've replaced the other knee now, and she's come in a wheelchair now. She's driving a car, fortunately. Thank you very much.
Thank you very much. As we know, knowledge with food would be more important, talk with food. So all the questions would be in the lunchtime. Enjoy your questions with the food. Thank you. Handing over to Rajiv Anand for further.
Thank you very much. Excellent talk, Yogesh Kamath sir. So may I request our past president, Dr. Bharat Singh, and Dr. A.K. Sinha and Dr. Rakesh Chaudhary, 3 past presidents are there, and Dr. Om Prakash to come and give a memento to our speaker, Dr. Yogeesh Kamath and Dr. Amulya Kumar Singh. Go on. Dr. Ravi SAUHTA, please.
Incidentally, Dr. Ravi SAUHTA is himself a joint replacement surgeon also.
And I will request Dr. Ranjit Kumar Singh to give a floral bouquet to all our speakers, all our chairpersons. Sir. Thank you. Excellent, excellent.
You have just skipped.
Sir, बेटा तो है.
अरे इन लोग का नहीं जानते हैं, ये लोग जो मर्जी आता है. So thank you very much. It was an excellent session, and we are 1 hour behind the schedule, so we'll move for the lunch. Thank you very much. दीजिए ना वहाँ पे चंदन पे दे दीजिए.
चल चल तो होते हैं
This will be a session. This will be the session 5 on spondyloarthropathies.
But I will be talking. ये spondyloarthropathy है ना?
So I would like to first invite all the chairpersons for the session. Dr. S.N. Saraf sir, Dr. Anup Kumar sir, Dr. Soman Chatterjee sir, and Dr. Madhusudan Kumar sir. Kindly come on the dais.
Good afternoon. Welcome to you all. In this session, we will discuss about spondyloarthropathy. I invite Dr. AMARNATH to present his paper.
Thank you, chairpersons. Friends, ladies and gentlemen, I think post-lunch session is always going to be a session, a challenging session. With the permission of the chair and the organizers, I would probably not talk much on spondyloarthropathy, but I'll just let you know a couple of things. But my main talk would be on the regenerative therapies and osteoarthritis. So let us run through a couple of slides and then we will have probably take it forward. This is extremely important for us. Most of our practice is with spondyloarthropathic presentations, neck pain, upper back pain, low back pain. We have array of symptoms and we need to recognize it and make sure that it's there. Recognition is the biggest thing. Diagnosis is the biggest thing, because with target therapy that we already have, target specific therapy, we don't have to see this kind of challenges. We don't have to do hip replacements in spondyloarthropathy or ankylosing spondylitis. That's a kind of advancement that we have now. We don't see this kind of challenges there. So simple things. If you were to see the sacroiliitis and be happy that your diagnosis is an X-ray, it's too late. You need to be very, very careful and probably early diagnosis with an MRI. MRI could be MRI negative spondylitis, and even X-rays sometimes can mislead you and I. Plus HLA-B27. Antibodies would be the biggest thing. Human leukocyte antibody 27 is the biggest challenge that we all have. Is it a positive ankylosing spondylitis or HLA-B27 negative? All those issues are going to be there. I'll not touch upon that in a big way. Burden is there. All the things are there. Excuse me, because the time constraints. I would probably skip this talk now and go to thank you. I'll go to this slide. We will take this. Yeah, thank you. So to understand osteoarthritis and beyond, we need to understand, go back in history. I'll take you a few centuries back, because there are things that we have not understood probably as we are learning. Today, the documentation is a very, very big thing. Back in few centuries ago, 2000 BC, before the Christ, or BCE, what we call it as now, Emperor Hungti and Dr. Qingpo have given the clarity in the medicine.
Excuse me,
Naiching.
This lecture is on the fifth session, sixth session, or fifth session. Your change. Okay. Okay, thank you. Thank you. Thanks. Oh, those. Okay. 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 Thank you.
I finished talking on spondyloarthropathy, just that. So this is where the whole challenge is happening now. Comes to European continent. Even there, in the first century, it has been given very, very clearly in the Materia Medica. The documentation of arthritis is being put in there in a very big way. So this is where the documentation is extremely important for us even now. If they had not put it, we would have not even known it could be that, you know. Next, we're coming to a little further towards the century progresses in Renaissance, and the disease have been put in, and we have understood how each of these parameters of arthritis is behaving. Is it rheumatic? Is it osteo? All those things are going to be revealing on their own now. Taking back to, or coming towards the 15th century, in Purdue, what happened was, in a big way, the 7 volumes of the medicine those days. Imagine 7 volumes. If Gray's Anatomy is not sufficient for us, imagine Gray's Anatomy and all put together into 7 times, or even probably the medicine book we talk about. It's massive. This documentation has been put in De Humani Corporis Fabrica. So that is where the documentation has happened for arthritis. In the crypts of London, we have seen arthritis happening in a big way. It's in 1700 we got this. Now, coming towards closer to a century, even now in London and in other areas of, in UK, we see this very often. This is very well documented. Now, the term osteoarthritis did not come there. It came a year later after Sir John Kent Spender talked about. And here, Archibald Edward Garrard talked about osteoarthritis, and the documentation was there. It was not still known as inflammatory. It was wear and tear, and that's ho gaya. That was the main thing. But yes, the documentation has been there in the 1800 and 1900. Now, with that background, we'll move forward faster. You and I know all the symptoms, the grading. Kellgren grading is extremely important for us because the therapy is on that, on the grading of the Kellgren's radiological changes that we have. We have seen many worse osteoarthritis knee, which may be or would be the parameter for our treatment in terms of surgical intervention. So keeping that in mind, a couple of years ago during COVID time, we had a lot of discussions, and Dr. Jha has been a part of our geriatric work, and we discussed a lot of things. And that was the time, right from Max, Saket, down to south in Trivandrum, a lot of people said, we don't want knee replacement. People who were put on the waiting list, they said, no, we are okay. COVID was literally ruling the, roost kind of a thing. So that is where the whole challenge came. So when we can manage without operation, there must be something, how we can help the patients. We know we all has challenges in some of the guidelines. We fall back on AAOS. You know the criteria which is there. And the been taken and accepted by the only Indian probably to give these guidelines and Americans to recognize it by Padma Shri and our BCRI awardee, Dr. John Ebenezer. So he is time in Europe, in Vienna, as well as in UK. So these do very well. These are all unloader braces. So in an initial system itself, we talk about and give them. I have more than 60 to 80 patients who are wearing this and vouch they don't want knee replacement even on their deathbed. That's the kind of clarity they come with. They have a very, very fixed idea on we don't want knee replacement. That's where we challenge comes into picture. So next comes into what we do, and Yogesh is going to talk about the intra-articular, what all we are going to be taking it forward. I'll avoid that. I will also not talk about ULAR and ORISI or even APLAR guidelines on these. It's already there. Just to run you through that, where we go, how do we take about it? This is the biggest thing. Right from the day, early morning onwards, we're talking about the shared decision making. Extremely important. When you and I counsel the patient, counsel is important. Patient is happy, and when they are knowledgeable about the disease, not just the Google knowledge, because in Bangalore, I'm sure you should be getting here as well. I'm not clear, but in Bangalore and in Mangalore, we see a huge amount of patients coming with a huge amount of references, unimaginable to deal with. Counseling is important for us. So shared responsibility in treatment. Doesn't matter. Extremely important. So this is where you score over the patients. So the legality comes much less, and we can deal with it in an appropriate way. So a lot of guidelines are coming in. We were born literally as postgraduates, and we did a lot of conservative surgery. Knee replacements was not a part of it was not even in the books. So that's where we come in. We did It could be total knee, or it could be even a medial compartment, Oxford, what I call, or it could be unilateral, putting the right word without using the right, the brand name. Gold knee is available, you know that. So the cost is not a factor for somebody. We can definitely take it forward. And again, this is the reason I was coming here, because this particular therapy is focused on grade 2 and grade 3 osteoarthritis. 1 is to forget it, patient don't even come. 4 obviously is little late. Now, let us talk about stem cell. After having 4,000-5,000 years of arthritis, what you learned earlier, today we talk about stem cell itself is 100+ years. So this is the growth which we talk about. This is where I don't want to confuse terminologies come into picture there, and we need to understand the mesenchymal stem cells, which is rounded off in the right corner there. So that is very important. Now, that can be, here we have hematopoietic, it could be neural, it could be mesenchymal and adipose tissue. So we can have the source from different kind. Fat. Today we have stem cell which can be taken out from the fat, but the challenge is, I'll come later, it will be coming in details little later. Now, I don't have to take you to the pathogens of osteoarthritis. Now, the mechanism of action, you know, I know it, where the chondrocytes are getting degraded and the challenges of arthritis is getting worse. So with that in mind, where the chondrocytes are affected, we can grow cartilage. I mean, we can take it forward in a massive way. You could have an autologous or even allogenic. So the terminologies are going to be a little confusing for you. Please understand, there are challenges, there are advantages, in either way in both the things. Now, this is a cell, stem cell, 15 years of research in India, in Udupi, in Manipal. It is a sister concern of Manipal University, I would say, and 15 years of research, both in animal study and human study has been taken care. So I'm going to run a couple of things which was done, and evidence-based medicine we all practice, right? So that's what we need to understand. So this is where, how it's been taken out, and it's been available for us very recently. Now, how it's being done, manufacturing and all that, I'm not going to worry. But here, the advantage is you and I don't have to have a matching of your blood. Blood matching is not required. So that's the biggest advantage here. Next, it's available off the shelf. Now, phase 1, phase 2, phase 3 studies have been done, and we are waiting for the government approval for the PMS, post-marketing survey. We are coming out with that, and then we will be in touch. We will give you the results of that as well. So the placebo and the actual treatment were done in the laboratory with 60 patients, and the proof has been done in a big way there. Now, how many cells to be given? What is the dosage? There was a lot of variation from 5 million to 10 million to 50 million, 75 million, 100 million cells. They saw advantages and disadvantages and came to the conclusion of 25 million cells per ml will give an adequate and very good response to that. So this is where, yeah, thank you. So this is where that comes into picture. Double-blind study was advised by the government, and it's been done in 9 centers. And the 9 centers had 146, 150, but 1 patient died earlier, and 3 were lost of follow-up. So 146 patients, in that 73 and 73 had placebo and the stem cell. Now, stem cell is given not just on its own, we give it with hyaluronic acid as a scaffolding to latch on to something and put in the knee joint. So this is one thing, very, very important. Now, with this, patients were observed. I'll tell you, it is not just observing with the VAS or WOMAC, but it's been done with a scoring system through the MRI. I'll talk to you next slide about it. The grading here, the grade 2 and grade 3. Even grade 3 is pretty advanced. So please understand, grade 3 plus, we have used it. And the endpoints is not just WOMAC or even VAS. That is the only beginning. What we did, what else has been done, I'll talk to you more about it. Here, the cartilages have been taken, assessed. How? Not arthroscopically. Nobody wants to have surgery, right? So it was taken into, I'll run that. WOMAC score was better, VAS was better, so we'll take that earlier, take it forward. This is what I'm talking about, the MOCART scoring. In MRI, the cartilage mapping has been done. Pre-therapy and post-therapy. How? 7 times before the therapy was given and on a regular basis when the patient was called, and the 7th one was at the end of 1 year. In that parameter, the cartilage has grown. This is in research. Apart from that, 9 double-blind studies have been done. Institutions where PGI, Chandigarh, AIMS, MS Ramaya, no, I can go on naming. There are 9 big centers in the country where they did the double-blind study. Except the person who packed it, nobody else know what it is. Is it placebo or is it the actual stem cell that was given to the patient? So this is where the advantage came into. Now, the improvement has been seen. I'll talk to you about the other areas. Medial tibial plateau, femoral, lateral tibial plateau, everything has been checked. And the growth, I'll give you one arm, stem cell arm. This was, you see the baseline, 7 visits patients have had, okay? To give you, you have 56 to start with, medial femoral condyle. After the therapy, 1.5 centimeters, 153 millimeters, the cartilage has grown. Imagine, this is what we're talking about. The advantage of having the stem cell is that. Today, we talk about PRP. You must have done it, or you may be doing it, I don't know, but PRP has its place. Yogesh is going to talk about it. I'll not touch upon that, but I'll talk about the stem cell and the hyaluronic acid, which has been taken as a scaffold. Now, there's a huge amount of difference when you talk about in the amount of stem cell, what is there in total. And we talk about the placebo. Now in placebo, baseline was 77. Somehow it's degraded because as disease advanced, and there's absolutely no development happen in the placebo. So imagine, I'll take the one slide back, 56 millimeter or very thin. Now going on to 3 times, 153. In placebo, it's gone even worse. So that is the whole challenge now. Safety, 100%. Yes, there were issues. They have taken the endpoints and assessed at regular intervals in 1 year. At the end of 2 years, we have seen these patients have not had pain. Knee replacements have not been done. 3 years coming now. This was made available. Allogenic cells, pooled bone marrow mesenchymal stromal cells, BMMSC. It's available for you like picking up an injection or a tablet like paracetamol but it is not that easy. What's been done? And in summary, I'll talk to you. I'll give you the background. It'll come to your hospital at -196 cryogenic packing or cold pack. You want in Patna, that'll be given to you at -196 degrees. You need to inform the lab 5 days in advance. The preparation is ready and that will be mailed to you. Transferred to you. But the only thing is you need to tell the patient that is made available. You'll come on that particular day. Today we receive it, tomorrow the patient can be called in. But the protocols had to be done. About 2 years ago, we sat together and we discussed, 18 months ago, we discussed, February 2022, the approval came. And there, the advantage, but by then, we had to process the whole thing with 3 donors. 1 donor is good, but when you mix with 2 donors, it gets better. But 3 donors, the sustenance of the stem cell life is much better. So that's what we did. That's what has been done in Mangalore. And with this advantage of mixing the 3 donors together, we have 3 million, 30 lakh doses. Now, this was launched in all over country. 15th November, it was made available. I have given 4 patients. Out of that, 2 patients have got insurance claims. And I have 6 patients waiting. 4 nationalized companies have not approved them yet. So there are issues. We're dealing with insurance companies as well. Last 6 days ago, I discharged a patient who traveled to Bengaluru from Andhra Pradesh, 850 kilometers. Insurance company gave 99% claim. Not easy. 3.3 lakhs was the amount. Patient got 2.27 cleared by the insurance. She was extremely happy. And she called up and said, I have not taken painkillers for the last 6-7 days. It's too early, but the last 3 patients whom I've given since December, they've been extremely happy. And we are talking about the new idea. Yes, many of our seniors have assisted. I have assisted and not done probably for many of you, but you might have seen it. This was GJ vagotomy. This is not done in a routine fashion. Every hospital in the country was doing it, in the world was doing it. Cimetidine, ranitidine killed the GJ vagotomy. But is this stem to cell, stem 1, off the shelf, going to probably get Yogeesh out of business or RAJEEV, Ravi SAUHTA out of business? Time will tell us. You and I want a smooth, pain-free, mobile knee. Stage 2, stage 3, grade 2, grade 3 arthritis, grade 3 plus we can give it. We have given that and this is a reality. Will this win it? I don't know. But 100 patients so far have taken. Once you talk about 4 months, every month, every day almost 1 patient is getting in India. We are crossing that 3-figure now to a next level of 200. It's happening and it may not be available in Patna, I don't know, but this is very much available. The cost is 1.25 lakhs per knee and the hospital costs. So there are differential, the financial will be discussed once you order that, but 5 days in advance, you need to tell them. And what the protocol we did as an SOP, we said the patient pays the money first to the hospital, even if they have insurance company approvals, because if the patient doesn't turn up, you have to pay the lab. Now, what we did, we sat with them and told them SOP should be very clear. Hospital, doctor, or the patient, somebody has to pay for it, or the insurance. So we said patient pays the advance money, and then the insurance claim can be reimbursed, or it can be taken as a caution deposit. So that's what we have done. Lab will prepare it only after the money is received to them, because the life of the stem cell after preparation is only 5 days. 1 day is gone in transportation to bring it to Patna. So 4 days are left. So naturally, you and I need to be extremely clear in getting that happening and brief about the advancement, what's happening. This is just the beginning. We need to see how we can take it forward. Thank you. Thank you, sir.
Thanks, Dr. Amarnath. You got a very vivid and lucid explanation about ONE, which is a very common things in our orthopedic practice. Now, I'll call upon our own Dr. RAJEEV Anand, who is the organizing secretary of this beautiful session. Please come and give your lecture. Your topic is diagnosis and diagnostic criteria for ankylosing spondylitis and psoriatic arthritis.
Thank you, sir. Respected chairperson and my dear friends. So today I'll be talking on diagnosis and what are the diagnostic criteria of ankylosing spondylitis and psoriatic arthritis. So what am I going to talk now is to differentiate between inflammatory pain and the mechanical pain, how you'll differentiate, diagnostic approach for axial spondyloarthropathy and axial spondyloarthritis and ankylosing spondylitis diagnostic criteria, and what are the diagnostic approach for peripheral arthritis, and what are the overlapping features in psoriasis and psoriatic arthritis, and how you diagnose psoriatic arthritis. The spondyloarthritis, as the name suggests, it's the inflammation of the spine and the joints. So that's called as SPA. So first of all, we have to differentiate between the inflammatory and the mechanical back pain. So I'll concentrate on ankylosing spondylitis and the rheumatoid. So age of onset is very important. AS is always common in 20 to 40 years of age, as in rheumatoid, you can see there's more than 40 to 50, and in non-specific low back pain and lumbar stenosis, usually the higher age groups are involved. Coming to the HLA-B27 positive is almost always in ankylosing spondylitis is as high as 90 to 95%, whether as it is not related in rheumatoid and other mechanical back pain. Morning stiffness, of course, it is greater than 30 minutes in ankylosing spondylitis, whereas in mechanical pain, it hardly matters, not related, but it is very poorly associated. It is more than 1 hour in rheumatoid. So that is the difference of morning stiffness. Night pain in ankylosing spondylitis, it usually worsens in the second half of the night, whereas it is indifferent in all those conditions. Enthesitis is very common in ankylosing spondylitis, which is not common in rheumatoid. But active inflammation of the SI joints, the odds ratio, that is the exposure and the outcome is very high in ankylosing spondylitis. And where the sacroiliitis distribution is there, it is 100% symmetrical in ankylosing spondylitis. So that's a very important part of that. So when the MRI has been introduced for the sacroiliac joints, it has led a major shift in the recognition of the disorder. It picks up very early the inflammatory changes in the SI joint, like osteitis and the fat metaplasia and the bone edema, marrow bone edema, it picks up very early. Even the radiological features by X-ray, it comes around after 5 years of the disease when it starts. But even the structural changes has not been occurred, MRI can pick up the very early findings. But a positive MRI and SPA remains controversial. An interpretation of MRI lesion always should be dealt with the clinical context, with the history of the patient and the examination of the patient. So coming to the characteristic lesions in spine and sacroiliac joint by MRI, So sacroiliitis is very common thing which MRI picks up. It is the bone marrow edema and the osteitis either in the ilial part of the SI joint or the sacral part of the SI joint, and the substructural change is subchondral sclerosis. Synovitis can be picked up and it gives erosion, capsulitis, and that is the subchondral metaplasia. Bone bruises can be seen as a structural changes, enthesitis, then finally the ankylosis of the SI joint occurs. Coming to the spine, there is anterior or posterior spondylitis, bone marrow edema, osteitis, mainly in the vertebral corners. So it starts with the vertebral chain, the spondylodiscitis, arthritis of costovertebral joint, and the facet joint arthritis, which produces and diagnostic criteria for axial spondyloarthritis and ankylosing spondylitis. This is a very important slide. Any chronic back pain, which is of the duration more than 3 months of 3 months of time, and if the age is less than 40-45 years, then some of the spondyloarthritic features we have to take into account. If the X-ray is positive, then straight away you can diagnose axial SPA. Otherwise, the features are, I'll just enumerate those points: inflammatory back pain, alternate buttock pain, good response to NSAIDs, peripheral arthritis, enthesitis, dactylitis, psoriasis, inflammatory bowel disease, uveitis, increased CRP and ESR, preceding infections, and positive family history. So if in these criteria, if is 4 or more than 4 criteria are present, then you can diagnose axial spondyloarthritis. If the criteria is 2 to 3 criteria are there in the patient, and if the patient is HLA-B27 positive, straight away you can diagnose axial spondyloarthritis. And if there is HLA-B27 is negative, consider other diagnosis. And if none or one spondyloarthritic features are present and HLA-B27 is positive, then MRI should be done. And if the MRI is positive, then you can diagnose it. Otherwise, you have to consider other diagnoses. So the structural changes visible on X-rays are the sclerosis, erosion, and new bone formation. It can be osteophytes can be seen, which is characteristic of spinal involvement. So coming to the Ankylosing Spondylitis Association of America, they have classified that any patient who is having back pain of more than 3 months and less than 45 years of age, and if on imaging sacroiliitis is present and more than one SPA features are there, then you can diagnose it. Or if the patient is having HLA-B27 positive or more than 2 other SPA features are there, then you can diagnose axial spondyloarthritis. Sacroiliitis in imaging, this acute inflammation of MRI, highly suggestive of sacroiliitis associated with SPA. And there's a definite radiographic sacroiliitis according to the modified New York criteria, which have added the sacroiliitis and HLA-B27 as well. So the modified New York criteria concentrates on only radiographs of the SI joint, classifying ankylosing spondylitis, but there is ankylosing spondylitis association. It goes further ahead and they have added HLA-B27 positivity and active inflammation of the sacroiliac joint. So I'll just skip this. So as we know that ankylosing spondylitis primarily affects the sacroiliac joints, spine, hips, and very less commonly knee joints as well. But ankylosing spondylitis most commonly occurs in males with a ratio of 3:1, and it always occurs less than 40-45 years of age. But the hip involvement is as high as 30 to 50%, and bilateral affection is around 90%. So these are some of the radiographs of the ankylosing spondylitis. So MRI diagnosis of the ankylosing spondylitis, they have created a one vertebral unit, and that is the lower half of the upper vertebra and the upper half of the lower vertebra, that they consider as a one unit. And if and the graded, like if there is no lesion, no changes, there is a 0. Grade 2 is sclerosis and vertebral squaring and torn separate vertebra. Possibly you can see the osteophytes, but grade 3, 1 or 2 osteophytes are seen, and minor erosion can be picked up. Grade 4 is more than 2 osteophytes and severe erosion is there. 5 is vertebral bridging and 6 is absolutely vertebral fusion. So they have graded in 0 to 6. So vertebral anterior bridging, the arrow which you are seeing it now is between the 2 vertebral units, as in the thoracic spine it is seen, indicating a score of 5 in the SPA node. So in another, if the facet joint is involved, sometimes then it is seronegative spondyloarthritis. So only facet joints from the cervical spine to the lumbar spine is involved and nothing else. Then also it can be diagnosed as seronegative SPA. So this is one of the radiographs. These are the CT. You can imagine the whole vertebra is fused and the SI joint is absolutely fused. Here's the case of 22 years of male with completely ankylosed hip. So that's the reason we have to identify the early disease of ankylosing spondylitis. In this situation, this 22-year-old guy is unable to sit properly, even unable to stand and unable to walk. See the lateral view is a complete fusion of the joint. So the only option is total hip replacement, and further the patient can work with these total hip replacement surgery. So things are there that you have to identify early. So one of the things which this you would know, that's diffuse idiopathic skeletal hyperplasia, which mimics with the ankylosing spondylitis. How we can differentiate is, again, the age is there. Usually this is seen after the 50 years of age. Kyphosis is not present in this, whether that is an ankylosing spondylitis. You'll always see the patient is kyphosed. Reduced mobility is occasionally seen in this, but it is very often in ankylosing spondylitis. Pain is common to both, but chest expansion is decreased in ankylosing spondylitis, but no change in this. Coming to the radiological findings, hyperostosis is seen in both the cases, but anterior longitudinal ligament and the posterior longitudinal ligament ossification is not seen in ankylosing spondylitis, whether that is very common in this. Syndesmophytes is very common in ankylosing, and erosive enthesitis is also very common in ankylosing spondylitis. So coming to the diagnosis and diagnostic criteria for peripheral spondyloarthritis and psoriatic arthritis. So when peripheral spondyloarthritis is suspected, ultrasound and MRI may be used to detect peripheral enthesitis, which may support the diagnosis of spondyloarthritis. Furthermore, ultrasound and MRI might be used to detect peripheral arthritis, tenosynovitis, and bursitis. So again, the association of ankylosing spondylitis criteria, if arthritis, enthesitis, and dactylitis is there, or plus any one of the criteria is present, then you can diagnose it. Or otherwise, these two criteria plus these two criteria are present, then we can diagnose it spondylar arthropathy. So diagnosis of psoriatic arthritis and how we can differentiate between rheumatoid arthritis. Number of joints is very important. In psoriatic arthritis is oligoarthritis, that is only 2 to 3 joints are involved. But in rheumatoid, it is a multiple, predominantly it's a polyarthritis. And joint involvement, any joint including distal interphalangeal joint can be involved. But always remember that in rheumatoid arthritis, if the distal interphalangeal joint is involved, then you can easily rule out that rheumatoid is not there. Dactylitis is present in 30% of cases of psoriatic arthritis, but it's not typical in rheumatoid. Axial involvement as a phenotype, erosive cervical changes can be seen in rheumatoid. Skin and nail changes are very common in psoriasis. It is up to 80%. Nail disorder is in 60%. Serology, usually rheumatoid factor and CCP is negative, but in rheumatoid it is positive. Both the rheumatoid factor can be positive or CCP is positive. The radiographic changes, there is a periosteal knee bone formation in psoriatic arthritis, but in rheumatoid it is in erosion and osteopenia. So these are some clinical picture. The mobility of spine, not in the only sagittal plane, but in coronal plane is also affected in ankylosing spondylitis. Here you can see the initial osteophytes. So PA view of the sacroiliac joint and sometimes oblique view is also preferable. Some of the clinical photographs of dactylitis in which the digits of the hand and toes are involved, they are swollen and looks like this. This again dactylitis, you can very well see the swollen digits. Dactylitis, there is a deformity as well. Again, clinical photographs. Asymmetric peripheral joint involvement that occurs in psoriatic arthritis. So my take-home message is inflammatory pain should be differentiated from mechanical pain. That is very, very important. So early spondyloarthritis can be diagnosed by, by MRI. So if you have 40 to 45 years of age, below age, and more than 3 months of back pain, go for an MRI. You might pick up early changes of ankylosing spondylitis or axial spondyloarthropathy. Chronic back pain, which is more than 3 months, again, which I have said, that is very important and that has to be investigated. Second one, SPA feature or HLA-B27 positive with more than 2 SPA feature can be diagnosed as a axial spondyloarthropathy. I'll take 30 seconds more. So ankylosing spondylitis should be differentiated from DISH. So that is also very important. So you have to differentiate between these two. Enthesitis, peripheral arthritis, and tenosynovitis and bursitis can be diagnosed by ultrasound or MRI, but involvement of DIP, distal interphalangeal joint, virtually rule out rheumatoid arthritis, and psoriatic arthritis should be differentiated from fibromyalgia by the presence of psoriasis, nail dystrophy, and dactylitis. Thank you very much for your patient hearing.
Thank you, Dr. Rajeev. Our next speaker is Dr. YOGEESH KAMAT from Mangaluru. His topic is psoriatic arthritis pathogenesis.
Thank you very much, sir. Dr. Rajeev has indeed made my job very simple. The topic is also rather specific. It is psoriatic arthritis and the pathogenesis of it. So what I will begin by saying, So I will talk it just mainly from the orthopedic and the diagnostic perspective. What is probably the most important part to understand is that arthritis is, many times people with psoriasis still think it is just a skin disease. And if at all we remember one thing, we should probably just remember this. The previous speakers have stressed well on it, but it can't be stressed less. So therefore, a lot of psoriasis, about 2/3 of it, will eventually develop joint disease. And what I'll try and do is bring forth a few examples to try to help. But at the same time, people could have arthritis before they develop any skin disease. It is often that people are not aware that they have psoriasis because it will be obvious only to be seen on the exposed areas of the hands. Often they can come with just dandruff, they can come with patches on the back, which nobody has seen. There will be a lot of people having dactylitis and enthesitis. These are essentially the diagnostic features, and Dr. Rajeev has explained that very, very extensively. But there will be, again, a lot of people with very, very subtle lesions. Number one,
and these are typically chronic. So they could have this oligoarthritis, they could be dormant for many, many years, which is why having a high index of suspicion, the moment you see somebody with psoriasis, and these are all there in people around you, you have to probably be aware, because early recognition, again, as we talked repeatedly, is the most important. Now, half of these will go unrecognized, and it is over time they will progress if not detected early. So it is chronic, it is definitely immune mediated, and it is inflammatory. So we've talked about these things for a long time. There are all those different types of seronegative arthropathies, which I don't want to repeat. And enthesitis, a very, very predominant factor. This again, if it is, I will stress a little more on this, and I'll probably give examples. So this is probably what is important for us to understand, because it could take years to resolve. And Dr. Chandrasekhar is coming to enlighten us again on what to pick up. Dr. Renuka has done it already. These mediators will probably change depending on the immune system and how it plays around with us, and that will be responsible for progression. What we probably have to do is work more on preventive and educative aspects once we know we are in this domain. And at the same time, recognize it when it comes with arthritis without this, because that is when it is best treatable. Let me put it across with examples. I'll get a patient here. The patient is standing right on the stage in front of you, and that is my hand. This is, I don't know whether it is seen very well, but it was a patch right here, which I got about 2 years ago, and it was itchy. I thought this is probably some latex glove allergy. I changed my glove. It was still itchy. I liked the glycerine coated gloves, so I kept using them, but it was still itchy despite. Then I thought it must be allergic to some, betadine I'm using. So it was there. I was using emollients, moisturizers, and this is typically what our patients do. They will use things themselves, and we don't realize how these things evolve over time. This is that same lesion which came up again. It was up and down, and despite the moisture was positive, because I then asked the dermatologist, why is it doing that? This is some kind of eczema, and we were thinking on whether we should, go and do some advocacy. It was typically exacerbating of it. And that will I have a chance of developing arthritis at some point? Well, I treat arthritis all the time, and maybe with all those patients who curse me for having replaced their knees, and all their sons who curse me for blowing holes in their wallets, all those are probably going to come back at some time. I think when I start getting knee pain myself, are those curses coming to me, or is it this? So, I mean, I can still do that comfortably, but sometimes those knees hurt, So, therefore, what is then important? What do I classify if my knees hurt as
as probably arthritic. And sometimes, yes, if I walk for 10-20 kilometers continuously, I have had times when I've had a very little warm kind of feeling. I initially thought it was some injury when I played with my children, and that should I get an MRI, is it a meniscus? Then it was in the other knee also suddenly. So clearly it is not mechanical. And but you know, it stayed for about 10-15 days and then it went off. I obviously thought at that point, should I then go and you know, think of a DMARD? And then I was advised against, because it was not worthwhile. What is the point if it is not evolved? So it is probably something I have to go through here. So am I confirmed to be psoriasis? Yes, because I've had the skin biopsy. But I do not have any of those other features. And those points are whether I have nail changes, whether I have any radiographic evidence. I haven't done that, but I will do that guided on a clinical basis. So probably no. And maybe swelling over digit, definitely no. I am borderline to think of probably psoriatic arthritis. But with my own example, I think that kind of drives home. This is going to be a chronic disease, and whether I should any test, do any test, probably what Chandra said in the next talk, probably less likely. But if I develop these inverted lesions or nail lesions, definitely more or less indicated. We will probably know more with our knowledge in immunology. Will definitely indicate that I am now. Therefore, let me just put 2 or 3 more slides. I don't want to bore you in the afternoon. This will just act as a bridging to what is coming on from Dr. Jha and Dr. Chandrasekhar. So this is a similar crisis. So I have that 22-year-old sitting in front of me in the clinic. I'll make him get up and walk, and you can see what his hip is like. You've already seen the CT scan. So this is somebody, no, he was 25 when he came. And you can see the very bad deformity that he has gone through. To take down his history, he was diagnosed or started having stiffness in the joint when he was 15. And he was now 25. So 10 years, he was moving around well. Unfortunately, the father was diagnosed in the same year with cancer. So automatically, all the energies and all the money in the family went towards treating the father. This guy was neglected as a 15-year-old, and slowly, over a decade, he was not able to walk looking forward. You can see him walking there. He really describes it very well. While he was walking, he could not look forward. And on examination, the next joint upwards from movement in his knee, the next place he had movement was C1, C2. The entire bone, right from below the neck till the knee, was one bone, sadly. He then went to get treatment from a physician who was treating with some kind of, some DMARD, methotrexate and whatsoever. And we know how this treatment has evolved over the years. A decade ago, probably we were not aware also, neither did he get to see a real rheumatologist at that point. And he was under the impression that he's being treated. When I said, this is what it is, this is clear. Ankylosing spondylitis, we need to operate, of course. He came asking for this, and then you have a flare-up, and this, which is already bad, gets worse. That was my worry. So here is somebody who's asking for an operation, and I'm telling him I don't want to operate. He says, if you don't operate, who will operate?
So I said, no, I will operate, but let us see whether this is the right timing. So then I got him to see a rheumatologist, and the rheumatologist with the inflammatory markers, and he serially monitored with CRP ASR. His CRP was in two figures, but it was just about between 20 and 30. He was the right indication for biologics. He was actually well. There was no clinical sign of inflammation. But with biologic, I had to also convince him for hip replacement. Plus, I had to convince him for a biologic, which would probably over time take much more than that. We somehow convinced him at least take 3 months of biologic, take it for a couple of months, see how you feel, and then we'll operate. He took those 2 months and he swears by it. Of course, he got down to the operation, but it's been 3 years, I think now, he's not come off the biologic. But he saw that, he saw the effect, he's probably continuing it. And that is what is, giving him good results. So that is the hip replacement, of course. That is him with his story. Yeah, that was 3 years back. That was it, when we operated. And, now he's standing up straight and walking. So, I mean, that is how this should be. One has to understand the pathogenesis. One has to intervene at the right time with the medical, and the jugalbandi between the medical and surgical treatment is probably what we all need to understand and practice. Thank you. It was a great evening in Patna last night. So
Thank you.
Litti Chowka to the Ganga Maya. Thank you very much.
Thank you, Dr. Yogesh Kamat, for your nice presentation. And now our speaker is our own organizing chairperson, Dr. S.S. Zha. We will be talking on formatting guidelines in SPA.
Well, friends, I can understand the post-lunch lethargy that everybody is going through. I shall try to be brief. Management of rheumatoid arthritis. Spondyloarthropathy management is a little different ball game, but as far as the order of medication is concerned, they are somewhat similar. So the seronegative spondyloarthropathy, all of us aware and familiar with this photograph, which shows all the various kinds. So when we plan to treat a patient, what is our goal? We want to maintain quality of life and control symptoms and inflammation. And the best part is that can we really prevent the structural damage? Well, I tried to format on international lines that how could we proceed to manage such patients. As I said, history becomes important. So you have to suspect that maybe this particular patient is a patient of a spondyloarthropathy, a patient with 3 or more months of chronic back pain and age of onset less than 45. Friends, I would like to make you aware that there is arthritis. She's on the later part of the age. So we requisition, already told by Dr. RAJEEV, is specialized investigation, obtain MRI of the sacroiliac joint and HLA B27. The second guideline is ascertain and classify whether this is axial or peripheral or axial and peripheral combined. Now, determine ankylosing spondylitis disease activity with the help of various investigations that Dr. RENUKA has told us, and we classify our patients into active or stable. Well, active axial disease patients are having symptoms at an unacceptably bothersome level. and they are inflammatory as per clinician's judgment. Stable are those who are asymptomatic and symptoms are at an acceptable level. They are clinically stable for minimum 6 months period. Now coming to the management proper, first line, here is the difference. Rheumatoid, you may not give NSAID, but here the first line says NSAID and maybe continuous 2 NSAID for 4 weeks, but 2 does not mean both at the same time. Maybe 1 + 3 weeks or 2 + 2 weeks. This is very important to understand. There is no preferences and you can have individual preferences. Celecoxib, I can mention, is one which is effective. No systemic glucocorticoid should invariably be given, and peripheral arthritis will have to be taken note of. So sulfasalazine and methotrexate, they are effective on the peripheral arthritis. The teaching is that they do. So the first line therapy also says you can go for local glucocorticoid infiltration. As orthopedic surgeons, even rheumatologists are giving intra-articular injections. So give intra-articular injection if 2 or less than 2 peripheral joints are involved. And friends, even if it is sacroiliac joint, we orthopedic surgeons are trained to inject into the sacroiliac. Go for it. But avoid enthesitic areas like Achilles, patellar, and quadriceps. Well, physiotherapy definitely will have to be instituted. Guideline number 5, in active ankylosing spondylitis, the patient have not responded despite giving 2 NSAID. So the second line is first choice, TNF alpha, but there is no preferred one. You can use any as per your experience. The second choice is secukinumab or ixazumab, and the third choice is tofacitinib. Now, for patients of ankylosing spondylitis who have add-on features of inflammatory bowel disease or uveitis, prefer monoclonal antibodies and infliximab, adalimumab, certolizumab, etc. are to be preferred over other biologics. Friends, here is the time. If the patient has not responded, stop, think for a moment, look, and then go. So if no proper relief on biologic, further investigate and go for a spinal or pelvic MRI. Well, active ankylosing spondylitis patients, they have not responded to TNF alpha also. So now you have a first degree non-responder despite TNF alpha. So first strong choice becomes secukinumab or ixazumab, and second choice here becomes tofacitinib. Now second degree non-responder despite TNF alpha, another alternative TNF alpha inhibitor is to be given. Well, when the patient stabilizes on treatment, which should be minimum 6 months, and physiotherapy will have to continue from the very beginning. But what is noteworthy, don't send them repeatedly to a physiotherapist. So unsupervised back exercise. Maybe he joins a formal group or individual with self-management education. And patients of stable ankylosing spondylitis who have been on biologic, now you can think of either discontinuing it or tapering the biologic. NSAIDs can be given only on demand. If the patient was stable on TNF alpha and NSAID, stop NSAID. A stable ankylosing patient on TNF alpha plus targeted synthetic DMARD, continue TNF-alpha alone, and stop targeted synthetic DMARD. Well, these I would not deliberate surgical aspects, but this slide I love to speak. So an additional one I have made is use of traditional DMARDs in treatment of spondyloarthropathy. A recommendation of use in higher doses or following biologic therapy whenever cost is a constraint. And that particular DMARD is sulfasalazine. Does not work on axial spondyloarthropathy. It works only on peripheral, but in larger experience, people have found it to be effective. But you can increase the dose. I must tell you to the audience, you must be knowing, I am in the habit of not even prescribing 2000 milligram. I keep my patients only on 1000 milligram. But here are patients where you can not only increase up to 2 gram, you can increase up to even 3 grams. You said more? 4. He's 4, even up to 4. Well, even otherwise, sulfasalazine has the advantage that this is a potent anti-inflammatory effect similar to NSAIDs, also has antibacterial activity and is an immunomodulator drug. Friends, coming back to psoriatic arthritis, higher doses of methotrexate are more effective. So results are comparable to results in rheumatoid arthritis, and remission is achievable in 20% of psoriatic arthritis. Friends, in the end, I would like to overemphasize that when we talk about spondyloarthropathy, we forget other ankylosing diseases of the spine. So apart from ankylosing spondylitis, remember the other 3. Well, ossification of one or more ligaments in the spine can be underappreciated, and hence there could be a delay in diagnosis. I will not go into the detail, but one inflammatory such condition is EASM, end stage advanced sclerosis multiforme. And the other one we are all familiar, OPLL, ossification of posterior longitudinal ligament, especially they are seen in people from Asian descent. And for our spinal surgeon, I would like to say that they are in 5th or 6th decade men, and it is mostly the cervical spine where even myelopathy can be seen. This has already been talked about by Dr. RAJEEV ANAND. So this is the 3rd ankylosing disease of the spine. Friends, RAJEEV ANAND has already said mechanical or inflammatory, you have to decide. Thank you very much.
Thanks, sir, for your elaborate teaching. Oh, okay.
Using a spa, which you would prefer and why?
Right. Very good question. First of all, I would like to say that etanercept is one which was my favorite few months earlier. But there have been patients now that those that I have treated with etanercept, and they did not respond. And then I switched over to adalimumab, and I was surprised to hear from the patient, "Doctor, I am fine, I don't have anything." So maybe now I'm graduating from one biologic to another one, but again I will say, etanercept I have used in all my patients except very few, in only 50% of the dose, because I have gone through Japanese study where they say Asian patients require only 50% of the dose. So my dose has been only 25 milligrams subcutaneously weekly. And that also I give only for 3 months, followed by all the other ones.
Thank you, sir. Thanks for your elaborate and very clear-cut concept about the disease. Now, again, I'll ask Dr. Chandrasekhar to come for his topic. Advanced is biologics the best future? Our biology is the best future way to manage AIRD, autoimmune rheumatic disease. Dr. Chandrasekhar, please.
Good afternoon. I think having heard all the previous speakers about the protocols and the way we need to use the biologics and DMRs with reference to many of the autoimmune rheumatic disease. Now, one of the questions Professor Jha asked me to address, over a period of time, is it only the biologics which is going to rule the world, or do we still have a scope with conventional disease-modifying anti-rheumatic drug? I hope I will give a reasonable answer to that question. And let me start the story. So I think most of us know that rheumatoid arthritis is a progressive disease. Etiology is still not very clear, but we have a several triggering factor which drives the immune system to go towards autoimmune process. And the whole process, as I said in my previous talk, is they use the natural occurring immunological response in a wrong direction. So hence, if I intervene appropriately in the immune processes, I would be likely to get a remission that what is one of the expected target. So I think we all know clear that rheumatoid arthritis is not a simple disease as we look at. It's not just the pain. It has varieties of impact starting from the social, psychological, increasing comorbidity, reduction in lifespan, and so on and so forth. So now, what is the key strategies that has developed over a period of time is we have changed in 3 specific concepts. Number 1, we have optimized the intervention early in the course of the disease. To optimize that across all the autoimmune rheumatic disease, criteria have been revised again and again. It has been revised in such a manner to make them more sensitive and more specific so that we can diagnose the disease early. For example, if you look at the rheumatoid arthritis criteria 87, compare it to 2010, the sensitivity has significantly increased. By 2 simple definition, we have changed the 6 weeks as the cutoff for the diagnosis. And earlier, nodules and erosions were taken as one of the things which are the late manifestations. They were all deleted from the concept. So the overall, there is a big change in the way the criteria, the way we approach, and so that we have optimized the intervention in the early process. That's the number 1. Second, in all these autoimmune rheumatic disease, we have moved from just symptom alleviation to a treat to target. We have scores for every disease. We have a PASI score for psoriasis. We have ASA score for ankylosing spondylitis. We have DAS score for the rheumatoid arthritis. And we have SLEDAI score for SLE. Name the disease in rheumatology, we have a score. I always keep telling rheumatology is one place where you are working with criteria and scores. So we have scores for everything. And now we have a target to treat. We look at an optimized targets. And I think why these targets, what are these targets? How does DOS means to us when I talk about the rheumatoid arthritis or any of these disease? I think just to make people understand, I think most of us are very aware about how we work with HbA1c with reference to diabetes. What does HbA1c tell you today with reference to what is expected in long run? If HbA1c is consistently high around 9 and 10, we all now know his complications of diabetes occurs 5 to 10 years before what is expected like. So also with the clinical diseases like rheumatoid, ankle spond or everything, if their disease activity score today is on the higher side, he is likely to land up in trouble in a short period of time. So that's why we need to use this score. These scores are called as surrogate markers of today for something which happens down the lane in 10 to 15 years. Because You can't sit now and say that this guy is going to have a deformities down in 10 years, or this particular patient is less likely to develop these complications. Here we use the score. Development of the score and evolving into the treat to target is something which is very crucial. And another things which we need to, and which we have learned over a period of time, is weighing benefit to risk ratio with reference to each of these based on treat to target and etiopathogenesis. So now the biggest things which has changed is early. Why early? What early intervention is going to change? Why that early intervention is crucial, along with biologics or whatever the treatment I do is, over a period of time, any immune response is bound to mature over a period of time. What it means to us is, look at the infection. If the infection occurs first time, the infection is more prolonged than when it occurs second time. Why does it happen? The immune system is built in to develop this mechanism. As infection, or if I give a second vaccine, the immune response becomes robust. As I said, in autoimmune disease is also a natural immunological response what it is using. More the longer time you give, allow the autoimmune process to go on repeatedly, it becomes more and more robust. As it becomes more and more robust, it becomes less and less responsive to any of the immunosuppressive or any of the immunointerventions. Having understood this concept and a fact clearly, it's been made very clear, any of the autoimmune rheumatic disease, waiting to intervene is not worth it. Intervene at the early when the immune system is maturing to develop into a robust disease process. So I explained this to the patient, saying that if you have to pull a tree up, it is best when it is having a very less roots. As the root grows deep in, it's tough to pull that things out. So that's what happens when it comes to autoimmune rheumatic disease. Early intervention is the things which is required with reference to autoimmune rheumatic disease. So this is how if you intervene early, you can reduce the amount of deformities and disabilities. So we moved from the change in the treatment strategies from, as I said in the previous talk, the palliative pain to the low disease activity to drug-free remissions. Now comes the questions, is biologics superior to the conventional disease-modifying anti-rheumatic drug in achieving the remission? Answer to this question is the study number 1. The number of remissions that we have achieved doesn't much significantly difference between when you use combination DMRs as well as the biologics. So and also what we could also see that even in the biologics, when you discontinue the biologics, the remission relapse rate is also not significantly different what I would have achieved or accepted with conventional disease modifying anti-rheumatic drugs. The question 1 is, current biologics available, are they anyway superior to the available conventional biological DMR? With reference to the target that what we are talking is not really yes. But there are some advantages, but there is no significant advantage where I should say that I would like to choose the biologics over a conventional DMRs. That's why even the recommendations initially says use conventional DMR in phase 1, failing which then move towards TS-DMR or biologic DMRs. The major challenge, as Professor Jha was telling with reference to spondyloarthropathy, do we or should we first try with the conventional DMR and then go for biologics? Most of the current recommendation insist give NS8 therapeutic trial, failing which then move into the biologics. Only exception is in psoriatic arthritis and peripheral spondyloarthropathy, where we say try with methotrexate and sulfasalazine, failing which then you move to the biologics. This is a little biased information as it is available currently, because there is no good, well-controlled trial with reference to sulfasalazine and methotrexate with reference to both axial, non-axial spondyloarthropathies. ASAS and all those definitions which have come recently with reference to the ankylosing spondylitis are not being tried and tested with reference to the conventional disease-modifying anti-rheumatic drug. That being the case, the recommendations are refusing to accept or work with the fact that we can still try a conventional DMR before going into the biologics. My experience in the last 20 years, and like few of you have used these drugs in ankylosing spondylitis, where patient can't afford to go for a biologics, we do really see 30 to 40% of the patients, even with axial disease, do good. So that being the case, biologic is not a panacea for it, but you need to very skillfully work with that. So to achieve that, we have a good list of conventional DMRs. And because of this, we had a lot of unmet need. That is what led us to the development of the biologics. Biologics got developed because we were unable to achieve certain of the things in some proportion of the patient, a good achievement. That unmet need is something which led us to the development of biologics. So we have combination of DMRs, and combination of DMRs also have not significant increase in toxicity, but with a good achievement of remissions. Combination possibilities are many. We have a lot of reservation in using the combinations. Sometimes we use 3 drugs, and in my practice, in the patients who are unable to afford, I have gone up to 4 drug combination. There were few which I used 5 conventional disease modifying anti-rheumatic drug with a good response. I think one of the Western academician who had come, he saw my data sheet and he said that, why don't you publish that? We would like to evaluate it. So because they have their own reservation in using these kind of 5 drug combinations. And we could see that the 5 drug of disease modifying anti-rheumatic drug can really sometimes do a wonder and can replace or can withhold from using biologics. So now conceptually, when we talk of autoimmune rheumatic disease, this is a paper which I published 10 years back, which is one of the reference on which many of the therapeutic strategies are worked with reference to autoimmune rheumatic disease. Autoimmune rheumatic disease have a dysfunction at 3 different levels. Level 1 is at the tissue level, say in the joints, the inflammation which is happening as a consequence of the occurrence of the innate immune cells, that neutrophils, monocytes, macrophages, and immune complexes. A level above, that is at the semicentral node, which is supposed to regulate the infiltration of these neutrophils and immune complex into the joint, is also dysregulated. And at the central level, the autoimmune process which has set in triggers an autoimmune reactions. If you need to intervene, you need to intervene top down. What we do is from bottoms up. Most of the drugs which are works at level 1, conventional disease modifying anti-rheumatic drug. The biologics works to little above, including the level 2. We don't have any drug which works at the level 1. So that being the case, still now the biologics, though we reward or think it as one of the the best drug, still don't reach us what we are looking or what we are expecting with reference to autoimmune rheumatic disease. That explains why we still don't believe or agree that probably the biologics are the features, unless I get a biologics which is going to work at level 1. The works are going on. Hopefully we should get those CAR-Ts, vaccines, etc. If we get those kind of interventions, maybe we should be able to work at the first level, wherein we can really change top down the disease process. I mean, this is the maze in which we have the pathological process. And when we thought of biologics, we thought we have moved from a carpet bombing to a targeted shelling to a heat-seeking missiles, which were the evolution, how it happens with reference to the jet fights or air fightings. So we thought if we can target a specific location like a TNF, IL-6, B cells, we can regulate, modify, and work at level 2 or level 1 and alter the very basic process. Did it live up to its expectations, or what did we expect out of biologics? Did we really get it? Is it still a hype or fact? The answer to that is, this is what the rabbit says. I mean, the rabbit registry, even the registry of ours says that overall DAS28 remission, what we achieve both with conventional DMRs and biologics are hardly 1.2 to 2% difference. So biologics has a little advantage, but it's only at a rate of 2%. You have still a large chunk of patients who are never able to achieve remissions. This is even the experience of us. It's a data which we collected from Karnataka Rheumatology Association of more than 3,000 patients, where we could see the patients who are on biologics, who are on 4 drugs, and who are on 3 drugs, disease modifying anti-rheumatic drug, the number of patients who had less than 2.8 was not significantly different from each other. So what it means to us is, even with our population, the biologic is now a superior. It's the same as we could see with the Germans. So why biologics didn't meet the need, or we are still failing to meet the need, and is that the one of the basic reason, of course, with reference to biologic, is the safety consideration, because we have a lot of serious infections, opportunistic infection, including tuberculosis, administrative reactions, etc., are quite high compared to conventional DMRs. With all this, the dream with reference to biologics, which you are trying to work on, do I get a full response, or can I completely achieve a state of remission with reference to autoimmune rheumatic disease, is basically because, I mean, this is a pic from the old Iraq war from US. That's the time, first time US utilized the target heat-specific heat-seeking missile on Saddam's palace. They all thought that with heat-seeking missile and I can blast the palace of Saddam Hussein, we can really kill him, but that didn't happen. They could only capture him, they couldn't really kill him. The basic reason is, in immune system, as I was telling, immune response is a multicellular response. There are multiple players and there are many pathways through which immune system works. Nature has built immune system with a very specific thought process. I mean, the way the immune system has evolved, it's more or less like it has, sorry, I'll just take 2 more minutes. It has multiple pathways so that one deficiency should not affect the self-defense. As a consequence of which you have cell-mediated response, you have your immunoglobulin-mediated response, your complement response, even within the innate response, you have multiple players so that one defect is not going to be a major harm. That's one of the major trouble for us when we are synthesizing and planning the biologics. Targeting one molecule is not going to be the one. It's a nice one. It shot the Sikh missile. It has blasted the palace, but unfortunately, Saddam was not there. So that one what we were targeting was not the real target what we were looking at. So that's why, though biologics are hyped up too much, but currently the role and place where we need to use biologics are the place where conventional DMR fails. Why we need to use it after conventional DMR fails is because of the safety concern, which I said. The conventional DMRs are still safer compared to the biologics because they are not severely immunosuppressive. Where conventional DMRs fails, we use it. In India, we use it after all the efforts in controlling the disease fails. It's not just the 3 drugs. We use multiple drugs, 4 drugs, change alternative combinations. When all these fails, because of the financial constraint and our other risks, we usually use it as a last option when everything else fails. So, but most crucial, more than biologics, when it comes to autoimmune rheumatic disease, is my last sentence. A stitch in time saves a million. If you pick the disease very early in the course of the disease, if you figure out any of the disease, including spondyloarthropathy, rheumatoid, lupus, or vasculitis, if you pick the diagnosis right in time, you need not think of using biologics. Another major concern is no one biologics is going to treat most of these autoimmune rheumatic disease. One size doesn't fit all. And we have a choice and we really do not know where to use and how to use, when should I use. To some extent, I gave the guidelines. Still, that guidelines is not absolute because we still fail in precise medicine. We could personalize, but we are still not yet to reach the precise medicine with reference to this. With this brief note, I think I conclude biologics are probably what we are looking for. Maybe combination, cycling the biologics or using alternative biologics are the time to come. Hopefully with that, we must improve the outcome. I mean, these are just few helps which you can have from our place where Chandra Research Assist. Those who are interested in research can take the help out of that. And we have a free journal, open access journal, which is available, called as Internet Journal of Rheumatology and Clinical Immunology. It's a free access journal, which is published from last 8 years from our centers. Publication is also free. Reading into this journal is also free. And there is few books which I have published, especially with reference to managing rheumatoid arthritis. The entire of the things which I concised about, the how to use and when and pick choose, there is a 6-volume combined volume about the conventional DMRs, how and when to use. It's on a question and answer format. Thank you very much.
Well, Chairman, sirs, with your permission, I can put a point that it was the very appropriate time that you raised and answered this question that biologic is not the only answer. There are alternatives. Well, when talking of DMARDs, the conventional ones, I think one which we discussed least was leflunomide. Now, leflunomide was introduced, and in the same year, I very extensively used them. But unfortunately, let us leave those age period where a pregnancy in the family is required. So leaving that age group, perhaps it was the dosing pattern which led us to its not being used because of many complications. Recently, I have gone through some publication where they say you can either give 10 milligram and to make the cost a little less, 20 milligram, even alternate days, alternate nights. It should preferably be given nights. Any comment?
No, actually, the most of the complication which we saw when leflunomide was introduced was we had this thing of giving a loading dose followed by maintenance dose. Most of the adverse event happened because of the loading dose, the practice of loading dose. At that time, what it was recommended was to give 100 milligram 3 consecutive days followed by 10 milligrams subsequently. That loading dose of 300 milligram was responsible for the fatal liver toxicity and fatal Steven-Johnson syndromes and others, which really made the drug to be afraid of. But now we just go about giving 10 milligram and scaling it to 20 milligram. That seems to be safe, and number of adverse reactions are very less.
Thanks, Dr. Chandrasekhar. Thank you. Our next speaker is Dr. Ranjit Kumar Singh. His topic is biologics. Biologics in a special system.
Our Bangalore guests have to leave because they have their flights. 4:15 में जाएंगे? नहीं, talk तो हो गया. They have done their talks. Is it 4:15? 6 p.m. is their flight. So we must say thank you very much. We are really grateful. You made it so lively. I'm happy that you all were here, and particularly to Madam. Madam, you have given great lessons to us and what a clinician must know when it comes to investigating your patients and following them in lab. Thank you very much. Dr. Amarnath. Somebody will help me. On the counter, there are 5 packets of laddus from Mahavir Mandir. The local Mahavir Mandir Patna has sent laddus, which is made by Tirupati Karigars. So those Tirupati laddus are for you as a blessing from this city.
We are overwhelmed by the hospitality and the way we were treated. Thank you very much. We are extremely thankful for you. We remember this forever. Thank you. Thank you.
I think after having come to Patna, I felt that I have sat under the Bodhi tree. And we will definitely make a positive difference in the patient care. Thank you. Thank you.
These patients. So thank you for coming here, and making many things clear in our mind, and our approach, our attitude, and our concept about the disease and the management. Thank you for the
last paper by Dr. Chandrasekhar was a eye-opener sort of thing, because many people have started thinking that the biologics are the ultimate answer, while majority of our patients are well and good on, conventional. So that was a very good message. Thank you for that. Just a chance that you are right.
For Bihar Orthopaedic Association, It was wonderful meeting, sir.
सर बैठ जाइए, तब ना आपसे परमिशन लो. So everybody was telling about when to start. I will deal with when to stop and why. So what the objective of this is to enhance the patient safety perioperatively. We are dealing with when to stop and why to stop biologics and DMR. So reducing the risk of infection, to enhance patient safety promoting option of the patient taking regarding stoppage before and so the British Society of Rheumatology 2018 a statement on safety of biologics therapies encourages consideration of risk and benefits of pausing. Is the paper supporting that? Why? Tumor necrosis mediates inflammation, modulates cellular inhibitors, naturally affect host defenses against infection. I mean, cut down the defense mechanism. So there is high risk of development of healing complications under anti-TNF biologics or those investigating the association between anti-TNF agents and infection. These are the most numerous. the majority of which have focused on assistance. Majority of the studies have found a significant association between anti-TNF drugs in patients with RA and higher risk of serious infections. Now coming to anti-B-cell rituximab. Most recent observational data from US Corona Registry showed similar rates of infection in 265 patients receiving RTX compared with 739 patients on anti-TNF therapy. A meta-analysis showed decreased risk of serious infection with rituximab as compared to anti-TNF therapy. But the general recommendation is to stop rituximab prior to surgery. Risk of infection highest in first 6 months of treatment. Concomitant steroid increases the risk further. Biosimilar JAKs and apremilast to be stopped prior to surgery and start after wound heals well. There are broad recommendations of these biologics for this stoppage of biologics. Biologics should be stopped 3 to 5 half-lives prior to surgery. For clean procedures like arthroscopy, 3 times the half-life. For high infection risk procedures, 5 times the half-life. Stop biologics prior to dental extractions. Stop biologics prior to biopsies resulting in open granulation tissue. Do not stop prior to endoscopy, cystoscopy, or punch biopsy. For bloodless procedures, cataract, etc., stopping biologics are not routinely advised. Advice regarding stopping conventionals. Stopping conventionals, DMRs, perioperatively are not recommended. So you don't need to this etc. Contact radiology consultant for specific concerns for the surgeons. He is anxious. What will happen? Should I stop? Should I continue? And he is in dilemma. Recommendations for biologics therapies. Recommended around 14 days post-op. Only after wound condition is good. If even after 14 days wound condition is not good, don't restart. Surgical site is healing well, no sign of local or systemic infection is there, then you can start post-operatively. Biologics during pregnancy. Now we have dealt with the biologic perioperative. Now what to do during pregnancy? Management of RA cases during pregnancy and lactation requires weighing risk of withholding treatment from the mother against any risk to the fetus, child via exposure to drugs during pregnancy or breastfeeding. You have to weigh between the two. What are the risks to the patient, mother, and what are the risks to the child? Restriction in use apply for the few proven teratogenic drugs that has to be stopped, and a large proportion of medication for which insufficient data is available, you have to stop because you don't know what will happen. Anti-rheumatic drugs in pregnancy enhanced drug elimination procedure using cholestyramine. Sulfasalazine and azathioprine can be continued during pregnancy. Now coming to TNF inhibitors. TNF inhibitors used during pregnancy is not associated with an increased risk of congenital malformation and have any adverse outcome. The American College of Rheumatology guidelines support the continuation of anti-TNF alpha agents throughout pregnancy in a mother with active RA. So you can continue with the TNF alpha inhibitors in pregnancy. It recommends discontinuation of anti-TNF alpha agents in third trimester if maternal disease activity is in remission to minimize transfer of drug to the infant. Otherwise, you can continue it. Anti-TNF used during pregnancy is associated with increased birth weight of offspring of women with well-controlled rheumatoid arthritis. This is a flow chart. How to do, when to stop, how to stop. This is RA patient in the reproductive age group. A certain desire for pregnancy. Yes, then discontinue. If assess disease activity, postpone pregnancy until disease activity is low. If disease activity is low or no disease activity, start adjust therapy, activity symptoms, control NSAIDs or NSAIDs or paracetamol or DMR, conventional DMRs, etc. But don't give biologics. So this is the flow chart. You can go through it. I'm skipping it. So coming to postpartum management. DMRs are generally compatible with breastfeeding in healthy full-term infants. TNF inhibitors can be continued or initiated during lactation. Methotrexate and leflunomide should be avoided in breastfeeding women. JAK inhibitors and other DMRs target-specific DMRs should be avoided in lactating women. So nowadays we are very often using this because we should be cautious. Now coming to biologics in tuberculosis. All patients must be evaluated for the risk of tuberculosis, both active, latent, and reactivation. Appropriate screening tests like tuberculin, skin test, chest X-ray, and IGRA should be performed in all patients. IGRA is a more pertinent and for patients already on immunosuppressives. In case of active TB, treat COX, do not use biologic. If latent TB is diagnosed, combination of isoniazid and rifampicin is given for at least 1 month before starting TNF alpha inhibitors and can be continued for at least 4 months. Methotrexate and cyclosporine can be used in patients with latent tuberculosis infections after TB prophylaxis. That is the same rifampicin, INH, and then we can continue it. Now, biologics in HIV infection. Methotrexate and cyclosporine should be avoided because of high risks of opportunistic infections. Use etanercept. Adalimumab, ustekinumab, apremilast have been used, managed in collaboration with infectious disease specialists for close monitoring of CD4 count and viral load along with ART. Continue with ART, you can give these biologics, but not methotrexate or cyclosporine. Biologics in hepatitis. IL-17 inhibitors appear safe if used after antiviral prophylaxis and with close monitoring of LFTs and viral titers in hepatitis AG positive patients. TNF inhibitors IL-17 can be used with close monitoring in patients who are anti-HBC positive. There are two anti-HBC positive and hepatitis B, SBS AG positive. So
इसमें क्या कि we can give in anti-HBC positive as there is lesser risk of infection. TNF inhibitors and interleukin 17 can be used in SCV patients after close monitoring of LFT and viral titers. Methotrexate and cyclosporins is absolutely contraindicated. So this was all about different types of infection and situations. Thank you for patient hearing.
So this is the end of this session. Any question? No question allowed. Thank you.
We are running of time, short of time. Please, we can. Okay, please.
Thank you for the wonderful presentation. I would like to invite Ranjit Singh sir to kindly come for the felicitation on the dais, sir. I would like Saraf sir to kindly felicitate Dr. Ranjit Singh sir, also Dr. Rajiv Anand sir, Dr. AMULYA Singh sir, and Dr. S.S. Jha sir. Kindly, if somebody can call Dr. S.S. Jha sir, is just outside the door. एक और जहाँ सर को बोल अगले सेशन नहीं जी सर रंजीत सिंह सर एंड बाय एजन सराफ सर Dr. Somen sir, kindly felicitate Dr. AMULYA Singh sir. Sorry. Next, Dr. Rajiv Anand sir by Dr. Somen Chatterjee sir. And our chief organizing president and chief patron sir, Dr. S.S. Jha sir today. Next, next I would like to request our president Bihar Orthopaedic Association Ranjit sir to kindly felicitate our chairpersons, Dr. S.N. Saraf sir. Dr. Somen Chatterjee sir. Dr. Rajiv Anand sir will felicitate Dr. Kanhaiya Singh sir. And Dr. Madhusudan sir. Next, we're starting the next session on osteoarthritis. I would like to invite Chairperson Dr. Kanhaiya Singh sir, Dr. Mithilesh Kumar sir, and Dr. Praveen sir.
सर हो जाए बहुत नहीं आपका कही सकते एक के बाद करा देते हैं हेलो very good afternoon everyone, please be seated. Now we are starting our session 6 with the first speaker Dr. Santosh Singh sir, an eminent endocrinologist of Bihar, Patna, and he is very thorough clinical examiner. Any time patient coming to him. He is very thorough in methodically examining the patient as a whole.
Honorable chairpersons, respected seniors, dear friends, my sincere thanks to the organizing committee for giving this opportunity. And when I was asked to talk, I was in a quandary what to talk because I was not allotted a specific area. I was told that you have to come to our place and give a talk. So really, it was a tough job to think of what you are to say in a CME like this. So after delving into the literature, I could gather that it's a multidisciplinary area. It is not only the rheumatologist and the orthopedic surgeons who are involved. And from there came this headline of cooperation. And I will just see why this cooperation. So in going through this, you will find that almost all the specialties are involved in the management of this condition.
शांति बनाए रखें.
Sir, conflict of interest, sir. Conflict of interest. This is a very recent one, and my conflict of interest is just spreading facts. As I told you, multiple specialties are involved, almost all. And this is the P-GALS. All of you are aware of the GALS scoring. And then we have this pediatric one. The clinical examination, and you can see the diagnosis of rheumatoid, the osteoarthritis. And then we had a nice talk by Dr. KAMAT, where we talked about psoriasis. And you can file the nail changes over here. You can see the sources digits in the clinical examination. And interestingly, as he said, that almost 50% of these arthritis patients, they have the previous skin disease. 20% they have concomitant skin disease and arthropathy. But in the rest 30%, arthropathy can precede psoriasis. And equally important is, as he highlighted, to look for areas where it is very uncommon, like the scalp and the back. And whenever you see a patient, particularly with the DIP involvement, we need to be very wary about the diagnosis of psoriasis. Then we have the Paget's disease. You can just diagnose from the deformity. Lower down, you have a mention of acute gout. And once you see that, and when a patient experiences gout flare, definitely he won't forget lifelong. And the association, recent papers have come up with the association of VTE, that is venous thromboembolism, with a gout flare. So these are all associations and which we should be aware of. And this is deliberate. Everybody of you are well versed with vitamin D deficiency, but this was a deliberate inclusion of mine in this CME. Forgive me if I am wrong. So this is the usual therapy which we give. Look at the data, 50,000 units, and we have 60,000 sachets, and or the tablets or syrups, and you give for 8 weeks, followed by the same every 2 weeks. And this is a 6-year study. And most of the times I'm surprised to see even weekly injections of 6 lakhs arachital. And that is really surprising. And so I would request, and I would just try that all of us are well versed with the proper use of vitamin D, knowing well that with the increasing BMI, we do require definitely a higher dose. And in those cases, majority of the times, we give twice a month dosage, and that suffices most of the times. Lower down, you find a mention of the granulomatous diseases, where we try to keep vitamin D at less than 30, and this is just to avoid hypercalcemia and hypercalciuria. On the right-hand side, I mentioned about vitamin D toxicity, and the drugs which we use for it in the chronic stage, the steroids and hydroxychloroquine, they are directly acting on the macrophages and taking care of the endogenous vitamin D toxicity. I was mentioning about the exogenous one, which we go from the iatrogenic vitamin D toxicity. And we all know from for hypercalcemia management, it is mainly the fluid which is there. Diuretics are only there for the fluid and salt overload in patients with congestive heart failure. And then we have, initially, there was use of calcitonin which is not very much in use nowadays. And lastly, the use of bisphosphonates in the management of acute hypercalcemia and vitamin D toxicity. Lower down, you find a mention of hypoparathyroidism and pseudo-hypoparathyroidism. And you see a line, I mentioned the use of vitamin D for vitamin D deficiency. And definitely parathyroid stimulates the 1-alpha. And for that, these cases also require 125 in a very high dose. And now I have a patient where I'm using parathyroid hormone in the management of the post-surgical hypoparathyroidism. On the right-hand side, again, you'll see a mention of CKD. This is almost analogous to the management. Even in patients with CKD, we do give vitamin D for vitamin D deficiency to keep the vitamin D above 30, and definitely the use of 125 in our population to take care of the metabolic bone disease in CKD. This is the CKD MB, and on the left-hand side, I have mentioned about putting your this EGFR app in your mobile phone. And this is very much important because we need to take care of the dosage schedule in patients with CKD. On the right-hand side, I have taken an index case of gout, and this is for KAMAT in particular. He will be talking in detail on this area, and you will find a mention about the use of colchicine, which is to be given on an alternate day with EGFR of less than 30. And then you have mention of fenofibrate, which has to be reduced in EGFR of less than 60. And lower down, you find a mention of SGLT2 inhibitors, which have uric acid lowering property by producing uricosuriya. And from his talk again, you find a mention about the different clusters of C5, 2, and 3. And this is just to highlight, we have now clusters of hyperuricemia where you have cluster 5, which is linked with CAD, renal failure. And this is just to highlight that area that we have to manage these patients of renal failure. C2 is patients who are having obesity, and C3 are category of hyperuricemic patients who are having diabetes along with liver disease. So from these clusters, you can just guess which category of patients are prone to what. Like C2, they are obese patients, they don't have CVD. They have only hyperuricemia and your hyperuricemia along with hypercholesterolemia. But the stage 3, which is linked with diabetes, it is also associated with hypertriglyceridemia, and we all know the link of hypertriglyceride and fatty liver disease. So this is, cluster 3 is the most important one, linked with diabetes, fatty liver disease, and hypertriglycerides. And the mention of losartan, we all know this is an agent which also produces uric acid excretion, and this is a molecule in a proper use in hypertensive patients. And I would just reiterate again, this talk of mine is not only as for doctors, it is only also for doctors who are patients of diabetes, because subsequent slides will be on that aspect. You will find a mention of the Hounsfield units of less than 172. And this is the HRQCT data. And this is the data. Any guess what this signifies? This Hounsfield units less than 172. This is just a marker of increased risk of vertebral fracture. And this was a study where they have looked at this as a cutoff for compression fractures. Multiple myeloma, again, recent paper on the increased risk of vertebral fractures to the tune of 50%, and 25% of them was serious fractures. Now, this is the CKD-MB metabolic bone disease, and this is just to highlight that in patients with EGFR of less than 30, we prefer denosumab over bisphosphonates, which we cannot use. Okay, and on the right-hand side, you find a mention of cinacalcet. These are calcium mimetics, which can be used in almost 4-fold the dose, even in patients with CKD who are refusing surgery. Okay, and the role of hyperparathyroidism and its association with CPPD, that is pseudogout and calcific periarthritis. And from here, we have this slide depicting the different disease conditions associated with these two. The CPPD states and the basic calcium phosphate deposition disease. And this is just to highlight, on the right-hand side, you have calcific periarthritis, which is there in hyperpara. And for chondrocalcinosis, again, that will be spoken in the next talk. And this is a bit of a partiality, I would say. I have put up this to include disorders which are there in endocrine practice. So this is hyperpara, which is a common one. And then you have hemochromatosis, hypophosphatasia, hypomagnesemia, and Wilson's disease, which are linked with pseudogout. This is an example of the musculoskeletal disorders. Look at the percentage profile. So we deal with the inflammatory and non-inflammatory, and the subsequent slides will be depicting this. The associations in clinical practice of these two entities, of vague pain, vague, and this is linked with fibromyalgia, this is linked with polymyalgia rheumatica. And just have a look of the minimum investigations for fibromyalgia, and that again includes thyroid dysfunction. On the right hand side, again, polymyalgia rheumatica is linked with hypothyroidism, and any guess anybody would go for a thyroid function test. I have written about the SLE and scleroderma and sepsis along with ESR and CRP. So any answer for that? Talking about investigations of ESR and CRP, and on the right hand side is SLE, scleroderma and sepsis. Anything in particular? We all know CRP almost is analogous to ESR because of its association with infection and inflammation. But in SLE and scleroderma, it is just the reverse. If you are having an increased CRP, it is more suggestive of a septic state rather than the inflammatory part. So this is a very important clinical marker. Now, NSAID, Dr. Jha has talked about this, but this is very important. Recommendations for use, caution in CVD and CKD, lowest dose for shortest time. We are talking about steroids for this, but it also applies for the NSAIDs, because in the risk factors you see high dose and multiple NSAIDs, straight no. These are all linked with problems, and never prescribe more than one NSAID at a time. You have to look for the response for 2 to 3 weeks and then only go for that. And the NICE guideline says it has to be along with the PPI even in patients with COX-2 inhibitors. But the association of PPI with increased risk of hip fracture should always be borne in mind. So that is the caution over there. Now we come to this part, and as I said, this is also as doctors as patients, because there are some of us who are having diabetes, and the importance over here is the association of type 2 and type 1 diabetes. This is the similarity. Next slide is about the differences between the two. And here it is hyperglycemia, its impact on osteoblastic and osteocalcin suppression, the role of age, advanced glycation end products in osteoblast differentiation, and the low bone turnover state which diabetic is, it is linked with the lower mechanical strength and increased risk of fracture. And important again, there is impaired suppression, PTS suppression of sclerostin. And we all know sclerostin is linked with suppression of osteoblastic activity. So there is less suppression of sclerostin by PTH in diabetics. So this is the similarity between type 1 and type 2. This similarity is this one. IGF-1, less in type 1, more in type 2. Insulin acts as a IGF-1 stimulating factor. And as you can see, the hip fracture, almost 7-fold increase in type 1 compared to type 2. And the mediation analysis of BMD was only 1.5. So there are other factors linked with the bone strength which are responsible for increased fractures in type 1 patients. Okay, lower down you can see from the different studies, there are increased risk of fractures at a lower T-score. And this is to the tune of 0.6 in females and 0.4 for males. And here also I have mentioned about the glucocorticoid-induced osteoporosis, where you take the cutoff as 1.5 for instituting anti-resorptive therapy. So this is some analogy again in the osteoporosis of diabetes and the treatment management of GIOP. This is it, continuing with the management, bisphosphonates, raloxifene, helpful even in low bone turnover states. And this is akin to the management of GIOP. Lower down, I have mentioned about the utility of testosterone, but this is particularly in patients of hypogonadism. And we all know the association of type 2 diabetes with hypogonadism, and testosterone is to be used only when there are evidences of testosterone deficiency clinically. And this is a trial for 6 months where you reap the benefit of testosterone on the bone anabolism. And then in patients receiving ADT, there is still role of raloxifene and where you cannot use testosterone therapy. So raloxifene can be helpful in management of osteoporosis in patients with androgen deprivation therapy, in patients with prostate cancer, where you don't use testosterone. This is a recent paper again, GIOP, teriparatide scoring over bisphosphonates. The steroid-induced hyperglycemia, this is for us. Management for you people, whenever you institute a diabetic patient on steroids, just add a nighttime basal insulin and ask him to visit his physician, and you can give a guideline because some of us, as I said, are diabetics. So we can just tell him to manage with the basal insulin. Otherwise, in full-fledged scenario, we go for the basal bolus regimen of management of hyperglycemia due to steroids. Now, rheumatological problems in diabetes, again, as I said, for our diabetic doctor friends, we start with the frozen shoulder, and it is more likely to be recurrent and bilateral in diabetics. 10% of diabetics are there, but important is the association with retinopathy. So whenever we are seeing these patients, we need to be cautious about the concomitant conditions which can be associated with the arthropathy. Okay, management we are well aware of. Trigger finger again. Dupuytren's contracture, again known to you, but 13 to 39% patients of DY have diabetes, not related with glycemia. Any guess about this? Entity, diabetes, patients. This is Charcot. Nice guess. And this is it. Bilateral in 25%. Linked with long disease and all. Initial period, you can use bisphosphonates to ameliorate the pain and benefit the patient. And this is diabetic osteopathy, where you have osteolysis of the metatarsals and the phalanges, forefoot pain. This is OA. Recent study again showing the reduction of osteoarthritis incidence to the tune of 24% with metformin use. Okay, and on the right-hand side, I have which is linked more with the muscle strength and psychological factors. So it is not only the structural derangement which is responsible for the pain, it is the muscle strength and psychological factors in the form of anxiety and depression which aggravates the pain. And we need to take care of that for proper benefit of the patient. And interestingly, there was less of smoking in this category of patients. But OA of the hip, it was associated with, again, these two combinations of fibromyalgia and PMR, but there was more use of alcohol. So this is OA hip. And lower down, I have mentioned about the gout flare. Early onset, this is hardcore, your area. I won't go into the details. Only my area is the early onset OA, less than 45 years of age, polyarticular. And here the associations of hemochromatosis and acromegaly for that. Lower down, you find a mention of Cassin-Beck disease, which is linked with selenium deficiency. And we selenium are very much versed in the management of Graves' ophthalmopathy as a management protocol of Graves' disease. JIA, different types. Now we come to the extra-articular manifestations, and this is just to highlight the association of cardiac and pulmonary complications which can be there in these arthropathies. And important is to keep in mind that these patients are high cardiovascular risk patients. And you should disease there for psoriatic arthritis. For enteropathic arthritis, mention about the gliptins. And it's very important information for all of you. Inflammatory bowel disease, pancreatopathy. We don't use gliptins. Pancreatopathy, we also don't use. If there is disproportionate swelling and pain in a single joint, you think of septic arthritis. And I mentioned about the differences in ESR and CRP in differentiating sepsis in SLE and scleroderma. And on the right-hand side, there is mention of G6 phosphate deficiency, where can be a problem in users of hydroxychloroquine and sulfasalazine. And in sulfasalazine patients, you can have orange staining of the urine and orange staining of the contact lenses. So this blood therapy, I won't go into the details. It was nicely talked about. Only thing is it can be used in uveitis and ankylosing spondylitis, but it doesn't help in spinal disease. This is the Dr. Jha's area. Most of the prescriptions I have seen of the biologics is in his prescription. And maximal use, as you can see on the top, etanercept, sir uses 25 milligram every week. And here, the added benefit, if we have the added benefits of reduced mortality with bisphosphonates, with these group of molecules, and as Dr. Ranjit sir was showing his slides, it can be used way along, almost even the pregnancy, during pregnancy, after pregnancy, patients who are even so-called immunocompromised, where we are not using the other biologics, it can be used. And this is the nice guideline. Important is the antibody methotrexate. This is there. And NICE says that these molecules are to be used when there is methotrexate failure. Okay, but majority of the patients, they are using along with methotrexate also. It can be there as monotherapy. The etanercept therapy can be monotherapy, but most of the times we are using in combination. Then there is role of anti the etanercept has the advantage of vascular action, C4 linked with hypercholesterolemia. This was nicely talked again by Ranjit Boss about the different agents which can be used in pregnancy. But here a mention about spermatogenesis failure with sulfasalazine. So this has to be stopped when a couple is planning pregnancy for males. This doesn't apply to the females, but the male has to stop sulfasalazine 3 months before planning their offspring. And on the right-hand side, you find a mention of calcitonin. Calcitonin also should not be used in pregnancy and lactation. And this is the second last slide. The concerns of calcitonin, it was banned in Canada because of its association with cancer in general. But in meta-analysis, they have shown it was linked with liver cancer increase, but there was reduction in breast cancer. Okay, and the anti-TNF therapy, again, Dr. Jha's area, linked with basal cell carcinoma, and definitely exacerbation of other cancers are there, and flaring of the tuberculosis, which again was nicely dealt by Ranjit Boss. And this is the last slide, the importance of vaccination. Whenever you are using biologics, we need to put the patients on proper vaccination and for looking for latent tuberculosis for proper benefit of the patient. So thank you all for the patient benefit. And this is just again to remind you that this is not only orthopedics and rheumatology. This entails almost all areas. I've even included dentists, which is linked with osteonecrosis of the jaw, and the drug holidays which we require for bisphosphonates and proper dental hygiene to avoid osteonecrosis. Thank you all for the patient hearing.
Thank you, sir, for your elaborate and excellent presentation. And you also focused on giving vaccine prophylaxis to the person who are receiving the biologics, which was essential and probably we missed in previous presentation mostly. Thank you, sir, once again.
Now, our next speaker is Yogeesh Kamath from Mangaluru. Please.
Hello again. Because of the deficiency of time, I would, try and run through a little faster. Full screen kar dijiyega. Acha. Yeah. So coming to management of osteoarthritis. So Initially, we thought that osteoarthritis and rheumatoid arthritis are very, very different entities. Osteoarthritis was known to be slow developing, chronic. You don't come to know when things change, and it happens over a matter of years. Whereas rheumatoid arthritis attacks in a very fiery sense. So, with increasing knowledge and increasing patterns of disease evolution, we see different aspects on both sides. जैसे शादी के बाद पता चल जाता है कि दोनों एक ही देवी के रूप हैं. शादी के पहले ऐसी लगती है, उसके बाद वैसी लगती है. So rheumatoid arthritis and osteoarthritis can have similarities. So rheumatoid, of course, is known with remissions which are more obvious. But what we are now realizing is there are inflammatory patterns in osteoarthritis as well. I'm not going to go into the details of this, but a very good component of osteoarthritis is associated with flare-ups and synovitis, which could be immune factor modulated. Dr. Jha is going to enlighten us on a few of those issues. Oops. Okay, sorry. So it is a bit like that. You don't know when one will merge into the other in terms of treatment. And we are now seeing with emergence of treatment, we've got now a new terminology. Like we have DMARDs, we are classifying them as disease-modifying osteoarthritic drugs as well. There's of course connective tissue modulators, and there are a lot of these in the market, and they are being used left, right, and center. We probably have to really refine our knowledge and work a little bit on this, get better evidence to see where we stand in terms of future developments. What we cannot avoid knowing is that there are probable some effects. So whether these are just placebo treatments or whether we have good evidence is what will need to be built up over time. So what we know at the moment is that there are types of collagens and different types are constituents in different tissues. We are getting early evidence probably up to level 2 with use of collagen type 1 in tendinopathies. And that is more and more with adjuvant therapies. What we know in osteoarthritis is we are now using a lot of these. Whether it really works or no is a matter of time. What we also have is a lot of different drugs which can be given different terminologies. The problem that I would say I have myself conducted a post-marketing surveillance thing. I have seen scores improve. We have published it recently from Indian data. Having said that, what I myself am unclear is to the individual role of all these. Now, that is still, I would say, remains theoretical. I do prefer to give these things as an alternative to anti-inflammatories, but when the patient is not in more acute pain. What I myself am not convinced about is their long-term usage, because a lot of these are plant extracts and haven't been chemically evaluated like we have with the rest of our allopathy drugs. Here is where we come to whether viscosupplementation, hyaluronic acid, which has been there for some time, really has use in clinical practice. Because Dr. Jha particularly asked me to talk about this in relation with guidelines. Our associations, right from the American Association to others, do not really recommend their usage. But here again, we've got early osteoarthritis, where we have a large chunk of our OPDs filled with patients. You give them various things, they're not going to be satisfied. So there is everything from Dr. Ortho Oil in Bihar to what is it called, Amrit Noni in Kerala and Karnataka, where people will spend thousands of rupees going to Ayurveda, going to all these places. But if you prescribe one thing wrong and they have side effects, there'll be 50 people outside your door saying, "Hey, doctor, to paisa karta." So it is we have to therefore probably come together and get more data on the efficacy of these things. As far as evidence is concerned, we definitely have evidence rather than drugs. Drugs is something we have to see. What we definitely have evidence is that exercise modification, activity modification does work. Osteoarthritis is not about managing osteoarthritis. It's definitely not about telling patients कि आप नमाज मत करो या तो नीचे मत बैठो. ऐसा नहीं है. Our ancestors have been sitting down for generations. We have not had problems. It is how we habituate ourselves and how we use our muscles. Probably modern generations of sitting and slouching in chairs, particularly with work from home and all, is not going to do our joints good. What we probably need to do is develop better postures, develop better walking, develop exercises and teaching them about posture, we are seeing more positive changes. This is still early evidence, but it is evidence where you can't be blamed with side effects. What I would definitely do is with all these things, I would definitely prescribe this. So what I would say, if the patient is compliant and wants to make it better with good perseverance with exercise, that might work in combination with this. Whether this works alone, we don't know. Going on to injections, there are basically 3 types of injections we have been talking about. The oldest and probably the most popular, each of them probably have a role. This is the one which is commonly used, but also abused. So steroid, however, is indispensable when it comes to flare-ups, when it comes to severe inflammatory conditions, particularly in relation to osteoarthritis flare-ups as well. And what I use it commonly is in combination following a joint replacement. I use hydrocort in my local infiltrative analgesia. So because all 100% of my patients get up and walk the same day, we've gone to using after knee replacement, we don't use drains any longer. Within 24 to 48 hours, we want to get them 90 degrees flexed, and within 3 to 4 days, they all climb stairs. How do we do that? We want to have less effusions in the joint. We want to have less. Steroid does give us that. I include hydrocortisone in my post-operative local infiltrative analgesia along with the other drugs. We have got data for it. We have data with various combinations with local anesthetic, morphine, ketorolac, and things like that. So it does have a place in various situations. We will talk about HA a little more. And of course, there is PRP, which is around the block. Amar had a whole 10 minutes on cell therapy. So PRP, we should classify this. There is level 2 evidence. So PRP on its own, it depends really what you call PRP. PRP has various forms. It could be just plasma that people inject and call it PRP. Traditionally, what works in PRP is the growth factors from platelets. So if it has to work, the platelet concentration should be 4 to 5 times that in your plasma. And the leukocyte concentration has to be less. So it has to be very regulated centrifugation, which comes from commercially available some 1 or 2 brands. But there is at least 10 brands out there. There are people who are just making PRP in their own lab, not really counting what product they're getting and injecting it. So if it is wrongly counted and injected, it can produce a septic arthritis like effect as well. And therefore, when I use PRP, I use one standard preparation from one manufacturer where it has been tested with results. And I use PRP in combination with HA. So that will help as a stabilizer for PRP. That when we do cell therapy, we know that it is the active cells which make a difference. But with the cells, you need a substrate, you need a solvent, and that is an inert solvent more than anything else. Apart from that, if we are using HA,
we use it for its inert properties, just from the point of view of its physical presence. So there is the inflammatory pathology, and the early osteoarthritis basically described about breakdown of the glycoproteins, which is where we have those degeneration processes starting. And that is probably where HA has a role. The essential use of HA is in using its properties as a viscoelastic substance, which when you have faster impact, the substance actually gets thicker. So the purpose here, therefore, is to use a highly viscous combination. Now, when you're doing that, however, remember the side effects of HA. Allergic reactions are rare, but these are proteins. They can happen. I have myself had an allergic reaction with HA where the patient had to be put in an ICU for a day. Now, this was because I use HA a lot more intraoperatively, and I do it with cartilage regeneration and cell therapy. So the patient was anyways under anesthesia. But beware of doing HA in a clinic where there are no resuscitable facilities. There are more modern HAs, and those are made from genetically derived genetic engineering. The classical HA was made from chicken proteins, but even somebody who has chicken doesn't mean they will not have allergic reactions to HA. Therefore, I will bring you to the types of HA. You don't have to go through that. Remember that broadly from the preparations available, there are two types of HA. There is high molecular weight HA, which is more than 6 daltons, the molecular weight, and there is a low molecular weight HA. The low molecular weight HA is for the ones that first came in. Those were 2 ml injections from various brands, and they are available between 1,500 to 4,000 rupees per injection. What we was to give it at weekly intervals and build it up over 3 weeks. Now we know there is going to be a side effect from repeated injections into joints, side effect of not being able to maintain asepsis and an intervention in the joint, which can cause infection. So with the newer HAs coming in, we know that it has got to be a good hyaluronic acid with high molecular weight, a 6 ml injection, which will be having an MRP of something like 30 to 20,000 rupees. This is one injection. We know that that is high molecular weight, and that will physically be present in the joint for 3 to 4 months. It does work well. The evidence is it is not in the guidelines, but at the same time, insurance still pays for it. Patients want to pay for it. So taken the right indications, my current thing for giving HA in the clinic is somebody who wants conservative treatment or a grade 1, grade 2 OA, which has subsided the inflammatory phase, as a second line treatment because I don't want to give anti-inflammatories for too long, number one, and they have not shown response with the collagen supplements and things like that. We know it's not going to work in grade 4, so there's no point wasting time here, because if they want it as an adjunct or as an alternative to joint replacement, please don't give it to them. The reason being, if you inject HA into a grade 4 joint, which is mechanically unsound, and then operate within 6 months, you are against a very, very high risk of infection. The HA is an inert substance. It stays in the joint for more than 4 months. Same thing with steroids. Steroid, if you put high molecular weight steroid like depomedron in the joint, please don't operate on it for at least 3 months. You're against a very high rate of infection. With HA, it seems, we all know steroid. We don't know HA. With HA, actually, you should wait longer. The HA, if you've given HA or the patient has had HA, please don't operate on them for 6 months. You can have disastrous infection-related complications. Whether it works in grade 3 Kelvin Lawrence, it's a plus or minus. I use it predominantly for grade 2, that also as a second line. Of course, adjuvant treatment I've talked about, and take into account comorbidities and treat things like osteoporosis and all the other things which the previous speaker, sir, has mentioned very well. Rheumatoid arthritis, of course, if you have inflammatory components, I personally have never tried HA with inflammation. Whether we can is a different issue altogether.
But here, there is a whole different can of worms to manage. Thank you for that. Or shall I go on to the next one?
You may continue.
Shall I just finish?
But in next session, it is in next session.
Sorry? अच्छा, आपका दो है. It's okay. आपका भी दो है, हो जाए. हाँ. Oh. If you don't mind, I'll continue.
Okay, you can continue on your next topic.
So a little bit about gout and crystal arthropathies. Now, I personally finished my postgrad about 21 years ago, and probably that would have been the last time I prescribed allopurinol. After that, I spent a couple of years here as a senior resident. I was away in the UK for 12 years. So I didn't prescribe anything there. Rheumatologist. So anything which is vaguely inflammatory, I sent to him. I don't prescribe. I treat only hip and knee. Having said that, this is important for all of us to know, and I will talk it purely from an orthopedic surgeon's non-inflammatory knowledge point of view. We have to be able to diagnose this because it is all out there. It is the commonest thing we think exists because so many times, almost every week, we see patients coming with reports of uric acid, saying my uric acid is high, mujhe gout hai, ya to, things like that. What do we do? So I will try and put forth just a few points. There are various crystals which can cause inflammation. What we know about is, of course, the urate crystal, and we know about gout, but leaving these, there can be a lot of other things as well. Predominant of this, Dr. Sota is going to enlighten us more on the second aspect, but I will talk mainly from the detection point of view. So, gout essentially is an inflammatory disease. The thing about gout is, though all diseases can be mono or oligo or polyarticular, so can gout be. The one or two things to remember about gout probably is that gout can be more commonly monoarticular than will be things which are extra-articular deposits. Everybody may not have that. One very important thing is it will again be peripheral, though it can affect the knees without affecting any joints, any other joints, and it will be familial usually. So these two things, if you see, you can be, more or less assured of diagnosis. These are, of course, classical X-ray features. Here you see more affection outside the joint, or what we call juxta-articular, than actually erosions within the joint. What we will be faced with is joint pains, but if you find these juxta-articular things, then definitely it is gout. What the misconception that a blood uric acid correlates with gout is one myth, if we can bust, is just the probably the objective of this lecture. So, the infusion of crystals. It is unfortunate that even though these it's very simple. You just have to have somebody looking with a microscope with polarized light, but many pathologists are not able to give us that information. So I'll just explain what that is. So it is light in a particular axis. If the crystal is aligned to that axis, then it is gout. If it is not aligned, it can be anything else. So if you see that, then you can convincingly say it's gout, nothing else. So it is coming back to this uric acid thing. I thought, let me make the talk a little orthopedic. So, uric acid dig gaya, so we jump to conclusions. But, you just probe a little bit and you might be in for a surprise. So, that is what gout does most of the times. if that drives the point home. The rest is absolutely all of us know. So, you can get these digit involvements. The important thing in diagnosing gout really history. There would have been some kind of inflammatory episode, usually associated with the fingers and toes with a family history. The juxtaarticular deposits might come in very, very late. So essentially, again, acute or chronic, usually monoarticular and more common in women, but it can happen in anyone. Probably, it is more common in men. It doesn't mean that if you're a woman, you cannot have gout. Things about it. So gout, what we've talked about so far is primary gout. The most important part when you think it is gout is there can be many medical conditions which can give you gout. Essentially, it is about being not able to cause a hyperuricemia, can precipitate the inflammatory reaction into the joint. So when you treat gout, it is not associated with just giving allopurinol. In fact, allopurinol is something which is contraindicated in a gouty attack because it would make it worse. It has to be treated with anti-inflammatories. I will leave it to Dr. SAUHTA to tell you more details about that. And what you really need to do is allopurinol only helps maintain and prevent attacks. You need to diagnose it and get a medical referral because you might have all those other secondary features. Thank you.
Thank you, sir. Now, next speaker is Dr. Professor S.S. Jha.
Ravi.
Sorry. Okay. Okay, sir. Dr. Ravi SAUHTA, Gurugram. Management of gout and hyperuricemia.
Thank you, Dr. Kamat, for making it simple for me. Management of gout and hyperuricemia. The treatment aims and objectives are basically to treat acute attack and prevent recurrence and prevent or reverse the complication related to the gout and correct contributory factors which cause hyperuricemia. Having said this, there are various causes of secondary gout, which you have already mentioned, and these are various renal, endocrine, metabolic syndrome, and various drugs which are associated with causing hyperuricemia in these patients. Whereas as far as the classification is concerned, 2015, these are various scores which can be used. I'm not going into detail, but you can note them down. Score more than 8 if there are about high degree of sensitivity, which is up to 92%, and specificity almost 90%. As far as the pharmacological treatment, as already mentioned by Dr. Kamat, that this particular disorder, if patient presents with acute gout, need not be treated effectively with the allopurinol because that can definitely aggravate these symptoms. Whereas in acute stage, you have to rely on NSAIDs, colchicine, steroid, and in anti-inflammatory prophylaxis, you can give steroids, NSAID, colchicine, and steroids. Again, if there is a prolonged reduction in the urate, which prevents in a chronic stage, you have to use urate lowering drugs. Management, colchicine basically is a drug of choice in acute gout. Whenever there is a diagnosis of gout is not confirmed, one can give 1 milligram of initial dose and 0.5 milligram every 1 hour. As they say, if there is a decrease, pain gets reduced, or the 10 milligram can be given in one go. This acts at various levels. Colchicine acts at innate immunity level. There is an endothelial cell inhibition, there is a neutrophil activation which releases the interleukin and dendritic cell maturation, inhibition of the vascular endothelial growth factors. So this works gouty states. Colchicine toxicity, macrolide antibiotics, digoxin or calcium channel blockers, they increase statins and antifungal agents. They also increase the toxicity of colchicine. NSAID, this is basically quicker, and indomethacin is used 50 milligrams 6 hourly, naproxen 750 milligram per day, etoricoxib and diclofenac. There is hardly you can choose between the different types of NSAIDs. As far as the steroids are concerned, basically in an acute attack, when it is preferred, if NSAID or a colchicine is contraindicated or not effective. Intra-articular if it is monoarticular, and high doses of oral corticosteroids can be given in acute stage. And in renal and hepatic insufficiency, ACTH has been described in the intramuscular injection of 60 international units, and it can be repeated every 12 to 24 hours. In acute stage, these role of biologics is in a big way coming in. Monourate crystals stimulate inflammation, and there is a release of interleukin 1V secretions, and biologics which are anti-1 interleukin 1 drugs like anakinra, canakinumab, and renolisab and givokuzumab. These are used. Subcutaneous injection of anakinra is used 100 milligram for 3 days daily. And canakinumab is used 150 milligrams subcutaneous injection, and 80 to 120 milligrams subcutaneous injection of renolisab has been used. These are various levels where these different molecules act, and especially their role also is in refractory gouts for those patients who do not respond. So they are used in 2 stages, one in acute phase, and also in those patients who are not responding to the adequate anti-gout therapy. Dietary factors which are used which cause hyperuricemia. These are basically those dietary effects which are protective. These are basically vitamin C, cow's milk, and cherry, coffee, and low dairy products. Whereas causative factors, alcohol and meat, especially all forms of animal proteins for that matter, are aggravating factors, and protein-rich diets, especially in vegetarian source, also responsible for increase in the hyperuricemia. Treatment of a chronic gout, basically when 60% of the patients have an acute attack. In 1 year, they may have a repeat attack, and 80% may have in 2 years. High purine diets, they are the causative factors. Alcohol intake increases the uric acid levels, and other causes of hyperuricemia like hypertension, obesity, dyslipidemia. They are also comorbid conditions which can be associated with the gout. Pharmacologically, these are for a chronic gout. These are 3 main groups of drugs which are used: uricostatics, uricosurics, and uricolatex. In uricostatics, these are allopurinol and febuxostat, and uricosuric agents. These are basically probenecid, pyrazone, and also lesinurad, losartan, amlodipine, and fenofibrate. They are also available in our country, and they have certain role to play. When there is a chemotherapy given to these patients, especially when there is a very high volume destruction of the cells during the tumor and during the chemotherapy, these are used in those situations. As far as the management guidelines 2020 are concerned, basically whenever there is a polyarticular large joint involvement, and there may be monoarticular disease, and when there is a NSAID can be used, corticosteroids can be used, and a colchicine can be used. Where combination of therapy, especially ice packs, can be used in acute stage. Colchicine, NSAID can be used, corticosteroid or colchicine can be used, and intraarticular injection of these steroids can be used in these patients. Idea is to where urate lowering drugs are used, especially when there is a tophius gout. One has to aim at decreasing the uric acid levels less than 5. And in other conditions, one has to be careful that the drugs of the choice which are used, first line of a drug is allopurinol, and it can be safely even used in CKD patients, but however preferred drug would be febuxostat. And one has to be careful that few of these patients, the HLA-B5801, these are the patients who are Korean origin, Thai, Chinese, or some US blacks, they have probably allergy to allopurinol. It has to be avoided in those group of patients. Start with low dose, 100 milligram, and then you can also add anti-inflammatory. You can start with colchicine, NSAID, and steroids. And treat to target, as mentioned earlier, is in tophaceous gout. It is less than 5 and less than 6 suffices in those patients where there are no tophi. Allopurinol, again, xanthine oxidase inhibitor. It's a drug of choice in 95% of the cases. Basically, low dose you start with and treat to maximum effective dose and keep it at lowest dose. Occasional patient may require very, very high dose, up to 600 to 900 milligram per can be given. Hydration, alkalizing the urine helps, and drug interactions, you have to be avoiding azathioprine or theophylline and oral anticoagulants, because the protein bindings, there can be alteration in their actions. Hypersensitivity and uncommon side effects can be seen in few of the patients where there can be fever, bone marrow suppression, and hepatitis and sarcoid-like reactions. As I said, febuxostat, it is a drug of choice, especially in those patients where there is a significant renal or liver compromised, and contraindication in those patients, again, as for the allopurinol, and a drug can also be used. But if you give in acute attack, there is something called paradoxical gout flares, which can occur because of these drugs. Patients who are allergic to allopurinol, the choice would be febuxostat. Allopurinol failure, again, choice would be this, and renal impaired patients. And those patients who are on anticoagulants like warfarin, you should avoid giving allopurinol. You can give febuxostat in those patients. Uricosuric drugs, these are due to defective renal excretion of urates. Contraindication is there if there is a history of stone formation, and less effective in those patients where there are renal diseases. Urine should be alkalized, and adequate hydration should always be 1400 ml per day. And probenecid can be used well tolerated in these patients. Few of our patients where losartan, amlodipine, and fenofibrate can be used. Uricosuric agents are very effective in those patients where there are renal function insufficiency. And hepatotoxicity can be more with the drugs, benzbromarone, which is not available in our country. Lisinopride can be used in refractory gout. Uricosuric agents, especially losartan, can be used if patient is having a gout with hypertension. Amlodipine can be used in those patients where there is hyperuricemia due to cyclosporine induced. And fenofibrate is used for those patients where there is a dyslipidemia associated with the gout. So these are various, atorvastatin can be used, has also a uricosuric effect. Uricolytic agents, as I told you, these are the drugs which can be used. These are basically uricase enzyme which they create, and then they convert uric acid into a safer molecule furthermore. And they are used basically during the surgery for debulking the tophi. Contributing factors for hyperuricemia are obesity, hyperlipidemia, high urine diets, alcohol consumption, fructose diet, uncontrolled hypertension, diabetes, diuretics, and also suboptimal urine output. Indications for long-term urate lowering therapy is those patients who have more attacks, chronic tophaceous gout, urolithiasis, and adjuvant in cytotoxic therapy, and they can be used in those patients with comorbidities. In complicated gout, like organ transplant, these are the patients where there can be intra-articular steroids can be used. NSAIDs are contraindicated. In chronic renal disease, NSAID is contraindicated. Again, colchicine should be avoided. One can use febuxostat as a drug of choice. Peptic ulcer with the upper GI bleed, again, NSAIDs are contraindicated. ACTH is effective drug which is used. Allergic to allopurinol, these patients, one can use probenecid, losartan, or fenofibrate. And those patients where chronic liver diseases are there, the allopurinol can be used as a prophylaxis. In a metabolic syndrome, febuxostat is the choice. Allopurinol interferes with the warfarin, and basically ACTH in acute phase, and analgesics like tramadol can be used with morphine in those patients. In refractory gout, maximum dose of the uric lowering drugs can be used, and one can go up to 600 to 900 milligram of allopurinol in treatment. And again, as I was telling you, that combination of therapy like xanthine inhibitors and uricosurics can be used. Vitamin C should be added in these patients in a relatively high doses, and obviously regulate their diet. And those patients, interleukin and antagonists can be used in these patients, those who are non-responder or so-called having a refractory gout. Indications for treatment of asymptomatic hyperuricemia, previous history of a recurrent gout, those where there are tophi present, uric acid stones are there in the kidney, and if the uric acid levels are more than 9 milligram per deciliter, during chemotherapy and inherent enzyme deficiency in those patients, it should be used. Uric acid levels higher than the normal. Generally, many patients may be asymptomatic. Few of these patients would present with very vague symptoms, low back pain or some joint pain, which is very vague, or a leg pain. So if you look at their uric acid levels, they are high. You give them analgesic, but you lower their uric acid levels at the same time. They have very effective, dramatic relief in their symptoms, and that can again suggest that you can use them for a prolonged period of time. These are various mechanisms. I'm not going into detail for the paucity of time. And these are the newer classifications for the agents, and these are the various drugs which work at the renal level. Just 1 minute, I'm going to take more. And this is a new classification which in which earlier it was overproduction and renal undersecretion. Here is the third component where they have extra renal under excretion type, which has been added in the newer classification. In summary, in acute attack, don't give uric lowering drugs. So you have a colchicine, steroids, ACTH, and anti-interleukin antagonists and NSAIDs. In a chronic gout, you use urate lowering drugs, allopurinol, febuxostat, or topiroxostat. And uricosuric agents can be used, losartan, fenofibrate. Uricolytic agents are only reserved primarily for uricemia state, when there is a chemotherapy which has been given to the patients. And a complicated gout, you know what to choose from. I have already given you the different medications. And there are further newer drugs which are available in the pipeline. Thank you very much for your patient hearing.
Thank you, sir, for your excellent presentation over GOT. And since the session is merged and sir has new presentation, may I request the chairperson, Dr. Om Prakash sir and Dr. Brajesh sir, to please join us so that only one or two.
No, forgotten.
Almost finished, sir. So please join us, sir. I have two, sir. Sir, Om Prakash, sir, please join us. Sir, you please.
Can I continue?
Yes, sir, please
So,
proceed with.
so as
pseudo
Dr.
gout.
Kamath was saying, I would be talking little detail about the forgotten crystal induced arthropathy, and this is CPPD, what we call pseudo gout. Basically, EULAR 2011 terminologies. Under CPPD, there are asymptomatic CPPD, acute pyrophosphate crystal arthritis, osteoarthritis with CPPD, and a chronic osteoarthritis CPPD with the inflammatory arthritis in association. So these are various metabolic diseases which can be associated and the family predisposition, and that's how the whole cluster of these disorders and various subtypes which are there under this heading. So patient can present with the asymptomatic CPPD, acute CPPD or a pseudo gout, and osteoarthritis with CPPD, and a chronic CPPD associated with various osteoarthropathies like rheumatoid arthritis with CPPD. When you look at the triggers for the acute CPPD, these are basically direct trauma. There can be inherent medical illnesses like chest infection, UTI, or myocardial infection. There can be surgeries, blood transfusions, and there can be parenteral administration of fluids and joint lavage, etc. Whereas predisposing factors are more than 50 years of age. Hereditary factors, there can be patients with ankylosis and various metabolic diseases which are associated like hyperparathyroidism, hemochromatosis, and hypomagnesemia, as a previous speaker was talking about. There are rare associations with the Wilson disease and acromegaly and onchronosis. When you want to differentiate between the acute phase of a CPPD and acute gout, these are the various differentiating features. Most frequently, the metatarsophalangeal joints and ankle are 80% involved, whereas the larger joints like knee and wrist and shoulder, which are involved in pseudo gout. Hyperuricemia, hypertension, obesity, and high purine diet and alcohol may be the predisposing factor, whereas the same is not with the pseudo gout. And when you look at the X-ray, obviously, you can see osteolytic lesion, periarticular osteolytic lesions in the because of the erosions, whereas chondrocalcinosis, cartilage calcification, you can see with the CPPD crystals. In a chronic state, you can see these various intra-articular, extra-articular, absence of extra-articular features, which you can see. Juxta-articular osteopenia and marginal erosions are not seen as you see in rheumatoid arthritis. And also lack of a strong positive rheumatoid factor, absence of anti-CCP in these patients. Osteoarthritis and how to differentiate between pure osteoarthritis and osteoarthritis with PPD. These are the patients where there is an atypical distribution. So there is an involvement of the pain at the wrist, elbow, joint, ankle. And pain is more intense than the osteoarthritis, and a marked tenderness at the joint which are affected. There may be systemic symptoms associated with fever, malaise, presence of a superimposed recurrent acute attacks which do not see in osteoarthritis. Osteoarthritis, you have a typical pain and discomforts which you see. When you look at the various investigation, plain radiograph, you can see calcification of the articular cartilage on ultrasound, and as they say, DECT, which can be done in few of these patients. These are various X-rays which can be advised, non-weight bearing X-ray for the both knee joints, both hands, both wrists, and the pelvis. You look at the cartilage calcification, you can see the cartilage calcification lateral side. You can see TFCC cartilage, which is also calcified, and one can see pubic symphysis. There is a cartilage calcification which can be observed. There is something called Milwaukee shoulder or Milwaukee knee, which can be typically a lateral compartment disease, and advanced arthritis into the shoulder, which can be seen. There can be few of these patients, when you look at their knee joint, they come with a severe arthritis, and you see that it is probably osteoarthritis. But when you look at their shoulder also involving this type of a picture, obviously they are CPPD patients rather than just osteoarthritis. And when you look at the various investigations, there are no typical afflictions of the joint, osteoarthritic joint, isolated patellofemoral and wrist degeneration signs. Ultrasound can be helpful. The classically there are some advantages and disadvantages of doing the ultrasound. When you look at pictures, this is very classical of ultrasound picture, what they call a rose bed appearance. Basically, what you see is the calcification of the cartilage, whereas in a classical gout, you would see a double bed, double contour sign, and in between, if you see that there is a calcification, which you can see, that is because of calcification of the cartilage. Dual energy CT is one of the investigation of choice, and as already mentioned by previous authors, rhomboid shaped crystals which can be seen and aspirated from the joints. This dual energy CT is very helpful. It can even tell you what kind of a crystal is there, whether it is coming from the monosodium urate or whether it is coming from CPDD, depending upon their how they adjust the Hounsfield parameters for this. And they can be marked. Today's software has become so advanced that you can mark these crystals, and these green crystals are basically CPPD crystals. And you can see CPPD ultrasound and X-ray. There is a comparison of all of them, which has been given in different ways and different forms, which can help detect which one is what type of a crystal and where. So these are rhomboid shaped crystals. Screening for the patients, those patients who are young, you need to screen them for evidences of CPPD. There can be serum overload, evidence of iron overload. So serum fibrin levels you have to see. You have to also see their serum magnesium levels and do renal function tests, kidney function tests for them. Calcium, phosphorus, alkaline phosphatase, and TSH needs to be done in these patients. Basic calcium phosphate crystal arthropathy. It is again an entity which is sub-entity under CPPD. I'm not going into detail about this, but again, shoulder can be affected, knee can be affected, progressive destruction. Diagnosis is confirmed by the imaging and also with the help of synovial fluid aspiration. So synovial fluid aspiration is probably the key which evaluates between these studies and these different types of arthritis. As they say, ulcerine red S staining shows clumps of these crystals, and NSAID, colchicine, and intra-articular steroid forms image. This is how on the staining it would look that there are positive ulcerine red staining crystals. Especially if patient is on dialysis, this is a calcium oxalate arthropathy, which can be seen in this specific class of patients, where there is these patients have serum creatinine more than 8 milligram per deciliter, and basically primary oxalatosis and also crystal of calcium oxalates may deposit into the skin, joint, vessels, and many other places. As far as the treatment is concerned, these patients, colchicine for osteoarthritis with CPPD is a drug of choice. Again, you have to choose your patients if they are not suffering from, they are primarily osteoarthritic patient or they are osteoarthritic patient with CPPD. So CPPD crystal is crystals are quite common, and colchicine inhibits the crystal induction inflammation, and colchicine also acts as a disease modifying agent, and its efficacy and safety in these have been in various RCTs which have been proven beyond doubt. So recommendation for the treatment, those patients who are asymptomatic, they do not need any treatment. Acute phase, you can use NSAID, colchicine, intra-articular steroid, ice packs. And in chronic patients, you can see NSAID, low dose of a colchicine which can be used, and a low dose of steroids can be used. In osteoarthritis with CPPD, same treatment can be initiated. Those patients who are not responding to the treatment, SCQS, methotrexate, again, Those patients are not responding, interleukin or biologics roles have been now evaluated and newer therapies are coming into play. In summary, CPPD is a common underdiagnosed condition that treatment options are limited. No drug is available to prevent the crystal deposits or to dissolve the crystal deposits. CPPD disease can be accurately diagnosed using the compensated polarized light microscopy, which shows rhomboid type of a bifurcant blue colored crystals. Ultrasound and DECT is very effective in evaluating. And a chronic arthropathy, basically pseudoarthritis, you need analgesics and NSAID. And where there is a chronic persistent inflammation, you can use low dose of a corticosteroid, methotrexate, and hydroxychloroquine in those patients. Thank you very much for your patient hearing.
Thank you, sir, for your excellent presentation in gout and pseudo gout both. Thank you, sir. And may I invite our last speaker, Dr. Professor S.S. Jha, sir.
Thank you very much. Especially I'm grateful to the audience who is still sitting here. It will be a very brief paper followed by a very brief valedictory function. Well, friends, talking of emerging therapies in osteoarthritis knee, even Dr. Amarnath has talked about this osteoarthritis knee. Comorbidities, since these patients are elderly ones, are always there, and this is not an ordinary disease. This invariably is a complex problem where the patient may be only osteoarthritis or, as I said, elderly onset rheumatoid arthritis, could be associated gout, and there could be an inherent osteoporosis. Well, friends, I am here again to overemphasize about two investigations which have been talked about just now by Dr. Ravi for diagnosis of CPPD. Two investigations in gout are very important, and this is one. This is a double track sign about which Dr. Ravi has just now said that articular cartilage double track will be visible, and this is typical and characteristic in gout as well. For confirmatory diagnosis, but you have to aspirate the synovial fluid and look into the polarized microscope. The other he has talked about is DECT, and this DECT dual energy computerized tomography also shows crystals. Friends, I have searched world literature. Gout can coexist with osteoarthritis. Not more than 100 cases are reported internationally, but this existence has been noticed. So we have to look in either case where coexisting gout or OA is there or not. This is the usual picture in DECT. Now, talking about osteoarthritis of the knee, there are many drugs which target at various levels, from cartilage to subchondral bone and everywhere. So, one milestone observation has been there, that when I started attending rheumatology conferences, I found that osteoarthritis is included in rheumatology conferences. And I was all the time worried that this one disease also has been taken away from our purview by rheumatologists. But then when I started hunting the literature, I found that the basic pathogenesis of osteoarthritis has changed. It is not degenerative, and all osteoarthritis, if not secondary, they have an inflammatory component. It was in 1990s that progress in molecular biology discovered inflammatory theory, but this was not accepted till 2000. And as late as 2017, imaging studies have demonstrated localized inflammation contributing to osteoarthritis. Friends, it is the inherent synovitis which is the critical feature and driver of osteoarthritis process. Well, desirable management should have a goal to either forestall the disease or decelerate the disease. So the novel non-surgical latest treatments are available and you can administer medicines through the intra-articular route. Unfortunately, these drugs are still not available in India, and the existing triamcinolone has been repurposed into Gilreta, which is nothing but extended release formation of synthetic triamcinolone. This is 32 milligram dose, single 5 ml vial, and it is there effective for several months. It claims to provide greater pain relief in 5 to 10 weeks. What is available in India is triamcinolone hexacetonide, and this is 20 milligram per ml suspension. The dose is calculated 1 milligram per kg for large joints and 0.5 milligram per kg for smaller joints. The second one, the small molecules through the intra-articular route, I always keep on saying, remember Santa and Banta. Then you do not forget the name of the drug. This is BNTA. This small molecule also is important. Stem cell, Dr. Amarnath has said, now available in India, and we can use it. Well, when we say it is a matter of time that joint replacement will be forgotten, where I think of stem cell therapy and the gene therapy. Gene therapy is is available in South Korea, and this is the first arthritis gene therapy. So it has a futuristic role in stopping degenerative changes. The already emphasized in gout as well, IL-1 anakinra will target the inflammatory processes. But I must make it very clear that adalimumab, etanercept, infliximab, hydroxychloroquine, they are not effective in osteoarthritis knee, but they are effective in erosive hand osteoarthritis. These are some of the drugs, sprifermin, and the other drugs that are in pipeline. मिर्चा को अगर joint में डाल दीजिए, so intra-articular capsaicin has really been found to be very effective. Botox, which we have been using in cerebral palsy, or which is used for beauty clinic, so Botox intra-articular also has been found to be effective. Well, there are developments in the oral drugs also. Cathepsin K inhibitor has been found to be very effective, but unfortunately, there are complications like stroke, atrial fibrillation, and other complications. Friends, even there has been a developmental change in the local anesthetic, and prilocaine is another anesthetic which is preferably mixed with hyaluronic acid for use. As I have told you, whenever you treat a patient of osteoarthritis, must treat osteoporosis, because this is a combination, because they are there. Silver lining, I always keep on saying, do not forget sulfasalazine and tofacitinib when you are treating them, because sulfasalazine especially has 3 effects: antibacterial, anti-inflammatory, and immunomodulatory. So, friends, osteoarthritis will not remain the same if all the drugs are available at our disposal, and maybe in coming 10 years, number of joint replacements definitely become less. Thank you. Thank you very much.
Now,
yes, yes, please.
we end up this session with Professor Jha sir's talk.
Right. So now I invite the President, Secretary, Bihar Orthopaedic Association, and the Organizing Secretary for a very brief valedictory function. And I would like my residual faculty members and master trainers, please be here. And all the chairmen, please stay behind. Well, before the organizing secretary starts saying something, I am reminded of Professor H.N. Sinha, who always will tell me, Dr. Jha, organizing secretary of any conference, many a times is a very lone person, because everybody is looking towards him and he has to remain concentrated that nothing goes wrong in the conference. I must say I was associated with this team, but I never had to bother about anything, and I find today everything is in order from where this scholar came, from where the bouquets came, the mementos came. So I must say hats off to the organizing secretary, but you have a team. There is a president with a lion's heart who had nothing in his platter, and he said, yes, go ahead, sir, we will organize it. And he did organize it. And the ever smiling secretary, anytime you tell him anything and he's ever ready. He was the first person who came to this hall, and he's still here. I'm so very happy. And your presentation was also very unique, I must say. Nobody emphasizes even C2 pathology, which was later spoken to in one of the papers, and you did it so well. So now it is the turn of the organizing secretary, and before that, all our faculty members have left, but the two faculties who are still with us, well, they are our personally very close to my heart. And so I did requisition them and they never said no. Thank you, Dr. Ravi SAUHTA. Thank you, Dr. Yogesh. I always feel that you are a family member and you are into the family. Now, chairperson formalities will be done by Dr. RAJEEV Anand, and Dr. RAJEEV Anand will proceed further for the valedictory function.
Thank you, sir. Before the valedictory function, I must congratulate all the chairperson who did their job so nicely. So I request our president, Dr. Ranjit Kumar Singh, to give a floral bouquet and a token of love and memento to all our chairperson. So Dr. Ranjit Singh, please. And Dr. Yogeesh Kamat, I will request you to felicitate our chairperson, Dr. Praveen, our secretary, BOA, Dr. Mahesh Prasad, to felicitate Dr. Brajesh sir, and Dr. Ravi SAUHTA, please come and felicitate our chairperson, Dr. Mithilesh Kumar sir. Thank you very much. Being an organizing secretary, I am really relaxed and overwhelmed by the responses given by the delegate and wonderful national speakers and all the delegates, print media, and the pharmaceutical company. Thank you very much for your nice cooperation. It was a wonderful time. And before ending, I must say that I took the feedback and it was excellent that everyone has gained learned something over here till 9 o'clock to 5 o'clock, and such a huge, gathering were there present. I am really overwhelmed. I bow your head, and on behalf of Bihar Orthopaedic Association, I thank you all. Okay, thank you. So we end this CME and the course. Thank you so much. अरे वही हमको लग रहा है कहाँ देखा है तुमको। हाँ, good, good. कैसा रहा अभी? कैसा लगा तुमको? तभी तो इधर बैठे। नहीं, really अच्छा था। Good. बहुत आगे बढ़। हाँ हाँ, राइट राइट, तुम्हें भेजा भी था, राइट, वेरी गुड गुड।
वाह
How is that?